we'll spend a little bit of time talking about the mid-parental height calculation, how to use it, what its limitations are. We'll take a quick look at growth charts and use them to assess the likelihood that you might be dealing with an endocrine disease versus a non-endocrine cause of short stature. We're going to talk about the standard first pass workup for a patient with short stature, the kind of workup that you can get started before referring if you're interested. And this last topic, indications for referral, we're going to call that bonus just because I have a 30-minute window and we want to leave time for questions. So we may or may not get to that. If we do, it's bonus material. So let's start with the mid-parental height calculation. So you all know the purpose of the mid-parental height. You know how tall the mom is, you know how tall the dad is, and you can use those two pieces of information to figure out how tall your patient, the child, is on track to be. Of course, the mid-parental height has a lot of diagnostic value because if you're able to do a projection of your patient's final adult height, you can then compare it to your patient's mid-parental target height and say, are they on track to meet their genetic potential or are they not? And that's very helpful in terms of weighing, am I dealing with a disease of abnormal growth or am I not? So we have a series of pearls that have been scattered throughout this presentation. This one's a smaller pearl. It's simply remembering that equation. How do we calculate the mid-parental height? So when I'm talking to my medical students about this, something that I like to say to just kind of make it click or make it easier to remember right off the bat is, on average, the average man is about 5 inches taller than the average woman. So I'm a man. I can say, well, I'm 5'9". If I happened to have been a woman, I probably would have been 5'4". My sister, she's 5'3". If she had been a man, she would have been 5'8". Just kind of a simple way to get started with the mid-parental height calculation. In terms of actually using the calculation, the first thing to recognize is that the calculation is different for a boy patient than it is for a girl patient. Let's start with a boy. Essentially, you're just going to take the average of dad's actual height and mom's height as if mom were a man. So like I just said 30 seconds ago, the average man is 5 inches taller than the average woman. So you can take the mom's final height. Let's say the mom is 5'2". You add 5 inches to it. So you're essentially saying mom's height, if she were a man, is 5'7". This is essentially mom's man height, if you will. So you're taking mom's man height and you're taking dad's height. You don't have to convert it into a man's height because he's already a man. And you're essentially just averaging the two because you're adding them together, dividing them by 2. That's the mid-parental target height for a boy. Now, we often tack on this plus or minus 3 inches because, of course, if this dad and this mom got together and had 15 boys, we know they wouldn't all end up at exactly the same height, right? There's a little bit of a genetic lottery involved. So we like to give a little bit of wiggle room on either side. We'll say if you're within 3 inches in either direction, a total span of 6 inches of your mid-parental target height, we're still going to call that within normal range. That's the mid-parental target height for a boy. And then the mid-parental target height for a girl is kind of just the flip side. You don't change mom's height. You're just using mom's woman height, but you have to convert dad's height into what his height would have been if he had been a woman. So like I said earlier, I'm 5'9". If I had been a woman, I would have been 5'4". My woman height is 5'4". So if your patient is a girl, you take mom's height, the dad's height minus 5 inches, average of the two, again, use the plus or minus 3 inches. Really straightforward. So a quick example, let's say mom is 5'3", let's say dad is 5'10". Again, the equation is different for boy kids as it is for girl kids. So you have to use the boy MPH equation. Mom's height plus 5 inches, that's going to be 68 inches. If mom's 5'3", dad's height's 70 inches, you average the two, you get 69 inches or 5'9". Plus or minus 3 inches to allow for that normal genetic lottery that gives us a target mid-parental height of 5'9" with an acceptable normal range of anything between 5'6" and 6'0". Okay, that was pearl number 1. That's the more straightforward one. As I did each topic, I tried to have like 3 or 4 different pearls, kind of like escalating in level of detail. So there's a little something for everybody. So pearl number 2, mid-parental height. That target range, Dr. Swanson just said plus or minus 3 inches. some of you at home might be thinking, wait a second, I thought it was plus or minus 2.5 inches, or I could have sworn I sent a kid to endocrinology and they said it was plus or minus 4 inches. So what is it? So the truth is there's a difference of opinion. We now have 12 different endocrinologists in our practice, I believe. And if you polled the 12 of us on what is a normal mid-parental target height range, you might get 4 or 5 different answers. So that's just something to acknowledge and something to accept. If you've ever been in one of our meetings, I can promise you, you'll never get us to agree on a single thing. Now, where does that number come from? I suggested that we use plus or minus 3 inches. I'm going to provide a rationale. So if you want to think about it statistically, we know that plus or minus 2 standard deviations from the mid-parental target height technically would be 3.3 inches. As a quick reminder, what does it mean to be plus or minus 2 standard deviations? That essentially means if you take everyone who's within that range from minus 2 standard deviations to positive 2 standard deviations, you're going to capture 95% of the population, which means if you have a patient whose height falls more than 3.3 inches below the mid-parental target height, you're talking about a patient who's in the bottom 2.5% of the population. So that might be a reasonable situation to say, hey, this is a kid that might be flagged as on track to be abnormally short. Now, for some of you sticklers, you might say, Dr. Swanson, you said plus or minus 3 inches, but here you're saying plus or minus 3.3. Of course, no one wants to do that math, plus or minus 3.3 inches. It's entirely too complicated. Just stop at 3 inches is my argument. Okay, that was pearl number 2. Let's move on to pearl number 3, a valuable pearl. The mid-parental target height and the associated target height range is valuable, but like a lot of things in life, it has limitations. And when you're using it, it's important to recognize what those limitations are. Limitation number 1, parents lie. They lie about their heights, and they lie about a lot of other things too. As an example, when I'm evaluating a new patient for a short stature consultation, I'll look at the height that the parents reported in the primary care office. If it's documented, I'll write it down on my note. And then when the family comes in, I'll say, Dad, how tall are you? And he'll tell me. And oftentimes the 2 heights don't match each other. They said one thing at the primary care office, they're saying another thing to me. Then all of our patients, when they're checking in at a registration desk, their driver's license is scanned in. So I'll often pull that up and look at the height on the driver's license. And in many cases, that's a 3rd height that doesn't match any of the previous 2. So somebody is not telling the truth at some point in time. So there are situations where you have to take the parental reported height with a grain of salt. There are times when we'll just measure the parent in clinic ourselves. It's not always possible. We don't always have both parents in the office. But you have to keep that in mind. In particular, we do have some families who come for growth evaluations with an agenda, which is to say we have some patients who come in and the parents really want us to prescribe growth hormone. So my instinct is that in some cases, we have families that are over-reporting the parents' heights to convince me, the endocrinologist, or me, the prescriber of growth hormone, that the child's height is more abnormal than it really is. Parents lie about paternity too, you know that. I'm not going to talk much more about that. Okay, limitation number 2. The calculation assumes that both parents reached their own genetic potential. So the dad's in the office with you. You say, how tall are you? He says, I'm 5'9". If you use that 5'9" as part of your mid-parental target height calculation, the problem is you're assuming that dad was genetically programmed to be 5'9". But he might have actually been genetically programmed to be something else, but only ended up at 5'9" for any of a wide variety of causes. For example, if he's a cancer survivor, if he had chronic kidney disease, if he had chronic illness, if he had malnutrition, any of those things might have compromised him, his ability to reach his genetically intended target height. So he might be 5'9" in the office with you today, but his DNA might have been more on track for him to be 5'11". As a personal example, my wife is 5'8", but when she was a child, she tripped over the family dog and broke her leg. The fracture went through the growth plate in the affected leg. Her orthopedic surgeon had to take out both growth plates, like bilaterally, because she was developing a limb length discrepancy. So today she's 5'8", but we have reason to believe that she would have been much taller. So I actually don't know what my wife's genetic height potential is. And as a result, I actually cannot calculate my own son's mid-parental target height, despite me being a mid-parental target height nerd, which is very distressing to me. Number 3, another important limitation is if you're using the parents' heights and you're saying, okay, my patient's mid-parental target height is X, and if my patient is on track to reach X, that's normal. That's making an assumption that the parent doesn't have an undiagnosed genetic abnormality that prevented them from reaching their final adult height. So it's possible that you might fail to diagnose a genetic abnormality in your patient because the patient's father or the patient's mother had the same genetic abnormality and it was also undiagnosed. Important limitations. Like everything else in growth evaluations, you can't hang your hat on it. You have to think about it critically, and you have to weigh it in the context of all the other variables. So that's everything about mid-parental target height. Let's talk briefly about growth charts. I know this topic is going to be straightforward for most primary care providers, but it's something that's so beloved by endocrinologists that I couldn't resist the temptation to talk about it. I want to talk about what a growth chart typically looks like in endocrine causes of short stature and contrast that to what a growth chart looks like in typical non-endocrine causes of short stature. So, as many of you know, in our classic endocrine diseases that cause short stature, whether that be growth hormone, hypothyroidism, or cortisol excess, we expect for the height to be compromised in the absence of a weight compromise. And you can see that, I'm sure, illustrated on this chart. Somewhere after this child's 7th birthday, we had a significant vertical growth failure in the absence of any kind of failure to gain weight. That's very typical for growth hormone deficiency and hypothyroidism. Some people would argue, well, with hypothyroidism, you would also expect excessive weight gain. That's probably true, but probably not as significant as you might expect based on what you hear or what you read in the literature. That weight gain with hypothyroidism actually tends to be fairly mild in most cases. The one exception is cortisol excess. We know that with cortisol excess, which is extremely rare unless it's iatrogenic, we know that with cortisol excess, we would actually expect rapid weight gain to go along with the vertical growth deceleration. So that's endocrine causes of short stature. This is a kind of growth chart that if you see in your office, yeah, you want Dr. Steelman to take a look at this patient. In contrast, non-endocrine causes of short stature, as many of you know, the weight is compromised first. Usually the height is preserved for a little while, even after the weight is compromised. And then as the compromise continues, then we start to see the height affected as well. And number 2, the degree to which the weight is affected is often more severe than the degree to which the height is affected. So the weight percentile in these cases classically is lower than the height percentile is. So I think that's also pretty clearly illustrated from this chart. This is what we expect in undernutrition, chronic illness, really nearly all of the non-endocrine causes, with perhaps the exception of genetic causes of short stature, which can be very variable and dependent on the specific genetic syndrome. Okay, topic number 3, getting the workup started. So you may have been in this situation before. You might be in this situation often. You're seeing a patient in their office. They're officially short stature. You've said to yourself, I'm going to place a referral. I want Cook Children's Endocrinology to evaluate this patient. But Cook Children's is busy. Dr. Steelman's a popular guy. It's going to take me 2 or 3 months to get this patient in. Parents are kind of anxious. I want to get the workup started now. So what should I do? Well, let's talk about that. I think before deciding what labs you want to get, there's a lot of value in just taking a quick second to think about what diseases are most likely or most important that could be causing short stature. I like to group them into these 4 categories: variations of normal, endocrine diseases, undernutrition or chronic illness, and genetic syndromes. Normal variance, of course, familial short stature, always a consideration. That's the one where, well, the kid is short, but it's only because mom and dad are short. It's not pathologic. Constitutional delay of growth and puberty, that's the one that we call late bloomers. The kid is healthy, the kid is normal. They're just going to have their growth spurt 2 or 3 years later than everybody else. So they look shorter than everybody else. But they're also going to continue to grow after other kids stop growing. So at the end of their vertical growth, we expect them to reach a final adult height that's within their mid-parental target height range. Endocrine diseases, hypothyroidism, growth hormone deficiency, cortisol excess, we just touched on those. Any cause of undernutrition, any cause of chronic illness can cause growth failure. And then genetic syndromes. Here in endocrinology, we're always talking about Turner syndrome and Noonan syndrome, but of course, there are too numerous to count genetic syndromes that could cause short stature or vertical growth failure. So keeping that in mind, what does a traditional first pass workup look like? As with anything in endocrinology, there's some variability from provider to provider, but these are the things that I've seen most often among our practice and among other endocrinology practices. So this first box is our initial screening for endocrine diseases. IGF-1 and IGF-BP3, there are growth factors, are surrogates of growth hormone secretion. They're kind of screening tests for growth hormone deficiency. Of course, we're always worried about hypothyroidism as a cause of vertical growth failure. So the TSH and free T4 we always get as part of our first pass evaluation. This box was intended to get more at the chronic illness, undernutrition, systemic illness, diseases that can cause growth failure. So just kind of basic things, kind of broadly screening for underlying disease, CBC with a differential, a comprehensive metabolic profile, perhaps an ESR, perhaps a CRP, whatever your preference is, and a celiac screen. I don't know that I can speak for the other doctors in my practice, but when I was being trained, the mantra was, celiac disease can show up, it can manifest with vertical growth failure, even without the presence of traditional GI symptoms or signs. So my training was to get the celiac screen in any kid with short stature or growth failure, even if there aren't abdominal complaints. That might be open for debate. The karyotype, getting at those genetic causes, a good first-line screening test for your girl patients, because of course we're looking for Turner syndrome. Not much value at all in the karyotype in your male patients. So that's really something we reserve for girls only. And then the bone age X-ray, which has tremendous value, and we'll talk about it in a second. So this is what most people will do with their first pass. Pearl number 2, when it comes to the first pass labs, don't let those tricky growth factor labs fool you. It's really easy to be deceived. So just a quick refresher on the growth factors, a quick refresher on the hypothalamic pituitary growth hormone axis. The hypothalamus makes growth hormone releasing hormone that stimulates the pituitary to make growth hormone. Growth hormone has a direct effect on bone, facilitating the longitudinal growth of our bones. But growth hormone also acts on the liver and compels the liver to synthesize and secrete IGF-1 and IGF-BP3. Those are our growth factors. They're surrogates of growth hormone secretion and growth hormone activity. IGF-1 and IGF-BP3, like growth hormone, will have effect on the bone to facilitate longitudinal growth at the bone. So the value in the IGF-1 and the IGF-BP3 is that if the patient's making growth hormone, we expect that they ought to be able to make IGF-1 and IGF-BP3. You might be wondering, why not, Dr. Swanson, why not just measure the growth hormone level itself if you're worried about growth hormone deficiency? As many of you know, growth hormone secretion from the pituitary gland is pulsatile, and growth hormone is then rapidly removed from the bloodstream. So if you try to measure a random growth hormone level at any moment in time, you're probably going to get a low number. You're going to get a low number in your patients who have growth hormone deficiency, but you're also going to get a low number in your patients who are completely normal. You could send LeBron James down to our lab, we can measure a random growth hormone level, and it would probably be low, unless we measured it at just that right moment in time where his pituitary secreted some growth hormone. So a random growth hormone level carries close to no value in the initial workup of short stature, but the IGF-1 and IGF-BP3, which are more stable over the course of the day, can be valuable. Now, like I said, the growth factors are tricky and they can deceive you. Why do I say that? If you went to Quest Diagnostics and you looked at the list of orderable labs, you would see 2 growth factor-like labs that we want, but you'd also see 3 that we don't want. So remember, we want the IGF-1 and the IGF-BP3. Those are the ones that have diagnostic utility. These other ones that you can order have such poor diagnostic value for growth hormone deficiency that it's not worth getting them at all. And every now and again, I'll have a new patient referred to me where the primary care doctor has ordered one of the unwanted ones in the place of the ones that we actually want. And then I've got to kind of do it again, and it repeats the lab draw and stuff like that. So if you want to take a screenshot, if you want to write this down, if you want to put it in your workspace, if you want to put it in your phone, whatever, I don't really have a simple way of remembering which 2 we want, but it's the IGF-1 and the IGF-BP3. Okay, pro number 3. Just like with the midparental height calculation, we want to recognize the limitations of the studies that we're doing, and growth factors, the IGF-1, IGF-BP3, certainly have limitations. Perhaps the biggest limitation is that the IGF-1 and IGF-BP3 are not completely sensitive for growth hormone deficiency, nor are they completely specific for growth hormone deficiency, which is to say, we have some kids who truly do have growth hormone deficiency. They're in our office for a first evaluation. We get the IGF-1 and it comes back normal, a false negative, if you will. In contrast, we also have some kids who are totally normal when it comes to growth hormone secretion, growth hormone function, growth hormone activity, but when we measure an IGF-1, it comes back low. So we get false positives as low. The IGF-1 in particular, but the IGF-1 and IGF-BP3 can be inaccurate in either direction, which is a big problem. IGF-1 might be falsely low, abnormal, a false positive in a handful of conditions that potentially overlap with growth hormone deficiency in terms of clinical features. For example, while IGF-1 we know can be low in growth hormone deficiency, it also can be low in undernutrition. And when we're evaluating a new patient for poor growth, we're often thinking about growth hormone deficiency as a possible diagnosis, but we're often thinking about undernutrition as a possible diagnosis. They have a lot of overlap in terms of their clinical features, and they have overlap in that you might see a low IGF-1 in either condition. So that's a real problem with the IGF-1 measurement. In addition to undernutrition, IGF-1 can be low in a handful of other conditions: type 1 diabetes, hypothyroidism, which also causes poor vertical growth, renal failure, and many more. So a very significant limitation. Another important limitation for the IGF-1 is that it varies with age, gender, and your patient's Tanner stage. It's important to recognize that, because if you order an IGF-1 from Quest, Quest is going to return a report that gives you reference ranges by age and gender. So you're going to be able to account for that if you're looking at the IGF-1 and trying to decide whether or not it's normal. But you also have to account for the Tanner stage, and the Quest lab report is not going to know what your patient's Tanner stage is. So if you haven't carefully assessed your patient's Tanner stage, like I know a lot of referring offices are not using an orchidometer, the testicular volume beads, then it's going to be really hard and problematic to try to use the IGF-1 to weigh the probability that you're dealing with growth hormone deficiency. Okay, I can see that I'm running near the end, so I'll make this topic, bone age films, my last topic. Bone age film, let's talk about the value. First off, a bone age, it's pretty straightforward. It's just a plain x-ray of the left hand. That's all it is. What I tell my patients and what I tell their families is, just like a 5-year-old boy, to look at him is obviously less mature than an 11-year-old boy. And an 11-year-old boy, to look at him physically, is obviously less mature than a 16-year-old boy. The same can be said about their bones. A 5-year-old's bones are obviously less mature, less developed than an 11-year-old's. And an 11-year-old's bones are obviously less developed than a 16-year-old's. So we endocrinologists, we stock our clinical office with these big blue atlases that are full of bone age x-rays, standard films for gender and age. So whenever we get a new x-ray on one of our patients, we open up our atlas and we can assign a bone age to the patient. The patient might be 10 years old chronologically, but their bone age might be 8 years. That has value. Why? For any given bone age, whether it's 6 years, 7, 8, 9, 10, any given bone age, we have tables that tell us the percent of the final adult height that the child has already attained. For example, at a bone age of 8 years, the average girl has completed 79% of her growth. She has 21% remaining. The average boy with a bone age of 8 years has completed 72% of his growth. So if we know their height on the day of the bone age, and we know the bone age, we can do some very simple arithmetic, and we can calculate a final adult height prediction, which has a lot of value. If it falls within the midparental target height range, it's less likely that we're dealing with pathology. So you might be asking yourself, should I go ahead and order the bone age x-ray, or should I wait for you, Dr. Swanson, to see them in clinic so you can do it yourself? Again, there's a difference of opinion among the endocrinologists in our office. 2 things that I would ask you to consider. Number 1, the interpretation of the bone age is very subjective. So if you have a radiologist and an endocrinologist and some other endocrinologist looking at the same x-ray, you might get 3 different opinions on what the bone age actually is. That's important because if my read is off by 1 or 2 years from the radiologist read, it can dramatically affect the final height prediction, and it might affect my decision-making when it comes to additional diagnostic testing and treatment. So that's a long way of saying I like to look at my own bone age x-rays. So if you order it yourself and the patient does it at an outside radiology suite, I'm not going to be able to look at it. It takes a lot of time and effort to get it sent to us on a CD, and our computers don't have CD drives anymore. So I really like to just get it myself. It makes life a lot easier. The other thing is, if I get it myself, then I know the child's height in my office with like RMAs at the time on the same day that the x-ray was done. So then when I'm using the percent of the final adult height that's been attained and I'm comparing it to their current height, I'm using the height from the same day, which is more accurate. And I'm using the height from our office, which I feel like I can take personal responsibility for if it's wrong. So for those reasons, personally, I like to get the bone age x-ray myself. So in the interest of time, I can see that we're 8:57. I'll stop there. Everything else we'll say has been bonus material.
Well, thank you very much, Dr. Swanson. So a couple of questions for you, I guess just pearls for someone who's in primary care. So one of the things I thought was very, very, important in what you mentioned is about celiac disease, because as I've continued, through practice, and I know you've appreciated this too, I've really appreciated the diversity of, presentations for celiac disease. Many of the patients who come to us, have very few symptoms of celiac disease, and so it's a bit of a surprise. So I think, from your standpoint, is there any clues or things that you pick up on that will lead you away from like an endocrine diagnosis? Because I think many families come in with blinders thinking, oh, this is a growth hormone problem, or even their expectations are set up that they have growth hormone deficiency.
Sure. Okay, well, to touch on the first part, the celiac disease, like I said during the presentation itself, I get celiac screening in every single new patient that I'm evaluating for growth failure. Because like you said, there's a diverse range of presentations, and I don't want to miss it. It's something that there's treatment for, and it can prevent you from going down an extended invasive workup for endocrine disorders. To answer the second part of your question, features that are pointing us more towards endocrine disease as opposed to other non-endocrine causes of short stature or vertical growth failure. Like I said, I really value the growth chart. We talked a little bit about the difference between the typical growth chart for a person with an endocrine disorder where the vertical growth is affected first and more severely than the weight is, as opposed to the other causes where we see the weight drop off first and to a greater extent. So that has a lot of value. The other thing that has a lot of value is calculating that final height prediction based on the bone age x-ray and comparing it to your mid-parental target height range. So that really helps you move away from the normal variance of growth, the familial short stature and the constitutional delay of growth in puberty. So I think those are the features that are most helpful for me. In contrast, like specific features that raise red flags for endocrine disorders, it can be hard with growth hormone deficiency if it's isolated in terms of a pituitary deficiency. I feel like the majority of our kids who end up being diagnosed with growth hormone deficiency have very little in the way of physical exam findings or historical features that clues you into it. The exception is if that growth hormone deficiency occurs in the context of broader pituitary dysfunction. So if you see midline defects, a history of traumatic brain injury, a history of radiation to the brain, neurosurgery, any of those risk factors for pituitary injury, or if you're seeing evidence of more global pituitary dysfunction, that's a big key.
Very good. I had one other question, I guess. It's something that you had mentioned, but I think it'd be very helpful for the audience is, can you touch briefly in regards to Turner syndrome? Because that's an important and differential in short stature in a girl. Is there any particular clues or things, maybe one or two, that you would offer to the audience to help them in raising their level of suspicion for Turner's, besides just checking chromosomes by default?
Yeah, well, the truth is, my clinical practice when screening for Turner syndrome is very similar to my clinical practice when screening for celiac disease, in that, as you know, Joel, there's a wide variety of clinical presentations for our patients with Turner syndrome, and it's important for the primary care provider to remember that there are plenty of girls who have a mosaic form of Turner syndrome where only a fraction of their cells carry the 45XO karyotype, and it's possible that the remainder of the cells have a normal 46XX karyotype.
Correct.
So I like to think that a girl might have mosaic Turner syndrome, and it might be compromising her vertical growth in the absence of any other stigmata of Turner syndrome. So as with celiac disease, I try to screen just about every girl with vertical growth failure or abnormal short stature for Turner syndrome.
Very good. I mean, from my personal experience, I do much the same thing. I guess if I would offer a couple of things that I sometimes will look at as far as clues, academic struggles, so learning differences, ADHD, and history of otitis, frequent otitis media, are things that I'll oftentimes inquire about when I'm trying to look at Turner syndrome in a patient I'm seeing that's a young lady with short stature that's unexplained or growth failure.
Yeah.
But anyway, very, very good lecture. Thank you so much for your time.
Today's what I'm going to talk about is just discussing the barriers that we see, how do we assess readiness for change, what are those motivators, and then ultimately how do we evaluate that. But before I actually talk about the barriers, I'm going to kind of briefly discuss three of our primary models or theories that we use for looking at behavior change. The first one is the social cognitive theory. And this kind of really focuses on a reciprocal relationship that exists between our behaviors, our cognitive processes, and our social processes. And the tenet of this behavior or this theory is that a learned behavior, a new behavior, is going to occur from a learning, modeling, and observation process. So that's key, but also key to it is self-efficacy. And that's the ability of helping your patient, or the individual, recognizing that they are valuable and capable of this change. The next major theory is a theory of planned behavior. Now that focuses on one's attitude, kind of subject norms, but especially their perceived, behavioral control of their ability to make those changes. And so the primary tenet of this is that it's critical for them to perceive their ability to make change is going to actually impact that change. And if they feel like it's going to be inherent, like something that facilitates it or impedes it, then that will actually determine whether or not they'll engage in that behavior change. And then the last one is self-determination theory. This focuses on the belief that we all have these inherent growth tendencies, that we're going to behave in healthy ways. But along with that, it looks at competence and autonomy and social relatedness. And much like the theory of planned behavior, it's more focused on how that individual perceives their ability to affect that change. So regardless of what theory one subscribes to, what we do know is from tons of research, as well as clinical case reviews and just our own personal patients, is that there are certain things that will definitely lend itself to either ineffective or insufficient outcomes for patients. And it's these four things. If we do any of these four things or only address the patient from this direction, then we will wind up having a poor outcome. So if we only focus on education, if we take that you should do this approach, that controlling type approach, if we completely disregard any kind of personal barriers, or if we disregard contextual barriers, that will set this up for failure or lack of success. Now, what I mean by contextual barriers really is it's not only just the patient's own health literacy, but it's also, just our community infrastructure, their access to good health food resources, access to transportation to doctor's appointments or to exercise. So we have to consider every single one of those kind of community barriers. So now I'm going to talk about what are personal barriers, and there are actually 7 of them. The first one is social and peer influences. This often is the #1 concern that we have from teens, and many report shame with having chronic illness. And I know that I'm not telling you anything that you do not already know. Diabetics in particular report shame with glucose monitoring as well as their injections. And many mistakenly believe that their peers are going to perceive them in a negative way or have a negative reaction to their illness. What is interesting, the data specifically with diabetics shows that there is a very strong negative peer influence with regard to dietary adherence, and as they become older teens and young adults, even alcohol consumption. The other interesting research that has been consistent with regard to diabetics is that yes, they do mistakenly believe that their peers will have a negative reaction. However, peers can be a very positive support, provided one caveat, that they're actually good friends, someone who genuinely cares about them. The other major barrier, second one, is fitting in. Chronic, as you all know, chronic illness and their treatment often interferes with their school activities and just even being in school. There's lots of visits to the nurses' offices, there may be absences from school, and the other thing too is a lot of doctor's appointments, and that raises questions among their peers. Oftentimes there's shame with wearing medical devices and also body images in terms of body scars and stuff. Teens in particular have poor adherence to medical treatment and their daily care just because of this barrier of fitting in. The third one is emotional health. Teens with a chronic illness have almost twice as likely experience depression as an unaffected teen. And children and teens both report significant increased anxiety as well as anger. They also report there's a lot of emotional distress if they perceive that their caregiver or family has a strong negative reaction to either one, the diagnosis, but also their treatment requirements. And there's also a lot of feelings of isolation. You know, depression in general is going to impact motivation. So you think about how if we've got a teen with a chronic illness that requires daily medical care, that's not only going to affect their motivation to do it, but their adherence as well as effective problem-solving strategies. In diabetic teens, we know that there's a negative correlation with metabolic control. So the other thing to keep in mind is oftentimes with teens and tweens is that depression may not look like sad hopelessness. It may actually appear as more anger and frustration and isolation. There's also a huge amount of anxiety with regard to some of the daily treatment requirements, particularly with shots and glucose levels. The fourth barrier is lifestyle. teen and college life just in general is very unpredictable and lacks routine, which is going to definitely impact their ability to get good sleep, good exercise, monitor their medications, and then also just shop and cook healthy food. And our society in general also encourages our children and teens today to be heavily involved, actually probably over-involved. So these kids are not only worried about academics, but they're in sports, they're in extracurricular activities, they're doing volunteer work. As they get older, they're worried about that college entrance exam, applying for college, and even jobs. So all of that is going to impact their ability to incorporate daily care for their chronic illness. And many teens today, just in general, report the stress and fatigue. So just think about how that can be a barrier for those with a chronic illness. The fifth barrier is risky behaviors. Now I'm smiling because developmentally teens are kind of known for being risky. This is a normal developmental stage. And we know that that frontal lobe, which is the seat of executive function, is not developed until they're about 25 years of age. So this is definitely going to impact their ability to inhibit their responses, to engage in effective problem-solving strategies, delay gratification, and even recognize that there's, consequences of some of their actions. So we have to be mindful of that with them. So also risky behaviors may not just be testing the limits, it may also be one of their ways of expressing their anger, which is possibly depression. Another barrier is their struggle for independence. This is also a very normal developmental task at this age. And so it can be kind of difficult for maybe parents to loosen those reins, and that can create a lot of conflict. And for some, on the flip side, individuals with chronic illness, they don't really want their parents to give up the loosening of reins. So then they don't progress through a normal developmental stage that they need to do. And then the final personal barrier that is absolutely critical is family environment and their overall involvement. Healthcare specific conflict is a huge barrier. I've seen it consistently with every child I've dealt with a chronic illness. And conflict in general among parents, whether they're married or divorced, is also another barrier. But kids will also share that if they feel like they don't have family involvement, or if they feel like their parents are over controlling, or if they feel like there's this either real or perceived parental burden, that is also a barrier for them. And many, many studies have shown and acknowledged the importance and significance of this parent-child or patient dynamic and how critical that construct is for their overall both short-term and long-term success. We know in several studies actually that there's a greater, whenever a child, a teen in particular, perceives that whether it's real or perceived, that a parent feels a burden about their chronic illness, that it is significantly correlated with higher A1C levels for diabetics. So that addressing that in family environment is going to be absolutely critical. So so those are the barriers, but how do we assess readiness for change? One of the most prominent theories, and it has been implemented and studied in multiple contexts very successfully, is the transtheoretical model of change. And this model of change shows that it provides a framework for understanding the process of intentional behavior. It views change as a process rather than one event. It views change as a series of changes, and that typically they will cycle through those changes. Now, movement through those changes is not always linear. In fact, you can go back and forth. You may even skip some stages, and I will actually talk about that with this case I want to share. It also helps identify common barriers among individuals at those stages. So I find it as an incredibly useful framework for just understanding the difficulties and the challenges that they have, but also their motivation and adherence, and how do we effectively change that. So let me show you what this is. There's 5 stages. There's the pre-contemplation stage, there's the contemplation, there's the preparation, which also sometimes is called determination, action, and then maintenance. So First, I'm going to talk about the mindsets that occur with each one of these stages, and we'll kind of rush through these a little bit. But stage 1 is the pre-contemplation. Now, this is where they're not even considering of making a change for the next 6 months. They actually oftentimes don't think that they have a problem. They'll just deal with it later. Nothing bad's going to happen to me, and it's just too difficult to address. Stage 2, contemplation stage. This is critical. This is where they're seriously considering to make a change in the next 6 months. There's a lot of mixed emotions here, so they're going to be very ambivalent. They may feel kind of stuck. They recognize they should change, and they're just going to really think about it. The next one is the preparation stage. This is where they're going to actually plan to make changes in the next 30 days. They may have actually made some attempts. Maybe they weren't successful, but they're going to retry again. Generally, that ambivalence is resolved because they know they need to make this change, so they have to do certain things. The action stage is where they're going to have gauged in that behavior for at least 6 months. So they've had lots of education. They've got a lot of reduced stress about having to make change. They kind of got more of a routine going, and they're engaging in those healthy behaviors. Stage 5, the maintenance stage, they generally have met this goal for 6 months, and it's kind of more of a routine now. And then in the stage 6, that's the termination stage, the goal has been met and the behavior has been permanently changed. So now I've talked about what the mindsets are, but let's talk about what those primary tasks are for each one of those stages. So remember, pre-contemplation, they don't think that they even need to make a change. So they're not even considering it. So the goal here would be to raise awareness. Contemplation stage is a very strong critical stage because they're beginning to see that possibility that they really do need to make a change. Possibly something's happened that's kind of given them that information. So it's critical that we resolve those mixed emotions, help them address the ambivalence, and see that they can do things to help make that change. The third one is the determination, or some people also call that the preparation. This is where they recognize they need to make the change. They're committed to it. They still don't know quite completely how to implement it. They may have done some things. So the goal here would be to help them identify the appropriate coping strategies, as well as address any kind of risk that they might have. Then when you get to the action stage, this is where they're making change, and it's not completely stabilized, but they've been successful with some things. So you continue to help them implement those strategies and learn what are also potential risk and relapses and how to deal with that if necessary. Then you've got the maintenance stage. Again, they've achieved their goals, haven't been for a long term, it's not completely permanent, but they're working towards maintaining that change. So continuing to develop new skills, those small behaviors, setting rewards, and addressing any kind of relapse issues. Now, if there's a relapse or a recurrence, and the reason why I've included this, even though that was not one of the 5 stages, is because you have to be prepared to help them cope with the consequences of if they relapse, because that brings a lot of strong emotions and feelings, and just help them see that they can get back on the saddle and they can redo this, and what changes they need to make. Okay, so we've talked about the mindsets, we've talked about the primary task, and now I'm going to talk about the strategies that you have to implement in each one of these stages. So stage 1, the pre-contemplation, remember, the goal is to increase awareness. Here, what you need to do is focus on assessing their willingness to change and how serious they see it. So oftentimes educating them about what has to happen for them to realize that this is a problem. What warning signs do you need to do? So that's all you're going to really that you need to do here. Oftentimes you get a lot of resistance and even may find them to be argumentative. Don't engage in that. Our goal is not to convince them of it. And actually what it does is it just creates more resistance. So stage 2 is contemplation. This stage is critical, as I mentioned, because they're seeing those things differently, and it's going to be critical to help them see the benefits of change to propel them to the next stage. So I'll often use a cost-benefit analysis, that's the business background, or we call it a decisional balance scale, where you help them identify the pros and the cons. So if their pros and cons are about equivalent, that's not necessarily going to motivate them to take action. However, if they see more pros, that's going to kind of eliminate that ambivalence and help get them towards that change. So it's important for them to see that. So you have to explore those reasons for changing. What are those barriers, and help them kind of get past that. In the preparation stage, you're going to praise their decision for choosing to change. And you have to help them by prioritizing their behavior changes, focusing on those small steps, setting up rewards to encourage that, identify any areas of difficulty that they need to problem solve through. And it's really critical to get those supports, identifying their supports and align those for them. Stage 4, action. This is where they've implemented those changes. But the strategies here is helping them continue to make good decisions, focusing on the small steps with rewards, continuing to set up those supports for them. But you also need to help them address any kind of grief or resistance issues, because sometimes they'll get bored with it. They get tired. They get exhausted with having to do those daily adherence and daily care. So it's important to make sure we focus on that aspect as well. When you get to the maintenance stage, the strategies, again, you continue to focus on education, focus on relapse, identifying those risky situations and encourage them for that open and honest communication, the things that they're fearful of, and maintaining that support. And then finally, for the termination stage, although they've maintained everything, they have to be able to go back and reevaluate. What could I have done differently? What do I continue needing to do differently? Maintain those supportive relationships. And again, always that reward and for positive changes. Now, assessing readiness for change. Readiness for change is really and truly a key determinant in helping sustain an individual's momentum as they're trying to overcome a problematic behavior. So what we know is this theory proposes that you have to have high levels of readiness to change, and that will predict a positive outcome. But it also says that if you do not have those high levels of readiness to change, it will make them vulnerable to having a poor outcome. So the research has determined that the readiness to change really requires two things. You've got to have a strong perceived personal importance to this, and you have to have the confidence that you can do this. So where do you begin? This is where I oftentimes begin. I will help them identify what is their current stage of change. What do they believe in with this? And I've attached or identified an example of a readiness to change lifestyle questionnaire for you. And I've also attached one at the end of this presentation. But it's also important then to identify the patient's confidence to change. But equally important to that is also, particularly with children and teens, is identifying a parent's readiness to change. Because we know from research that in treating chronic illness, that parent support is so critical that they have to be on board too, and they have to recognize the value and the significance of that. So, motivating change. Number one is addressing the family involvement and family environment. Multiple studies show over and over and over again the importance of positive family involvement. We know that there is a strong correlation that when a child or a teen has a positive family understanding, positive family support, and no conflict, that they will have a greater outcome. So that needs to be one of our first things that we do with motivating change, is addressing that family environment. The next thing that I use is motivational interviewing. I'm sure all of you have heard of this, but the primary tenet is this, is that behavior change will fail if a patient feels coerced. So remember what I told you in the very first part. If we take that you should approach, it is going to fail. But motivational interviewing believes that it is our job as clinicians, practitioners, physicians, to help eliminate any cognitive dissonance that a patient may have and support them in their own salient reasons for change. So it's helping them understand change. Now, what I mean by cognitive dissonance, what that means is whenever there is, when a belief or attitude does not actually match a behavior, it's going to create this mental discomfort. And so ultimately what we try to do is either we adjust our belief and attitude, or we adjust our behavior so that we can restore that balance. So for example, if an individual overeats, which is a behavior, and yet they know that that's unhealthy for them, that's going to create that cognitive dissonance. So we have to eliminate that. Motivational interviewing also focuses on an empathetic approach, because empathy increases change. Confrontation will always impede change. And our job has to be to build the self-efficacy so they believe that they are capable of this change. And I cannot tell you how many research studies show this, and I've actually had patients report this, that if we communicate and share our belief in their ability to change, they are more likely to change. Also with motivational interviewing, what patients say often will reveal what they will do. So reflective listening is important, and listening to what they're saying and communicating that accurate empathy that's associated with each stage is absolutely critical. Now, so let me talk about how we use motivational interviewing for each one of these stages. So we've got the pre-contemplation stage. Remember, the goal is to increase awareness because they don't think there's a problem. So you have to assess their conviction to change, their confidence in their ability. You also do that with the parents. And you just simply provide feedback and education. Our job is not to force them in to recognizing why they need to change. We will lead them there. Contemplation stage. I mentioned this is where they're recognizing they need to make that change. The primary task is to help them see the benefits of the change and address those emotions. So you have to kind of share that this ambivalence is normal. Whatever you do, do not confront them and argue with them. You kind of, I call it the accept, expect, and roll with their resistance, all the while expressing empathy and making sure you address their cognitive dissonance, helping them see those pros and cons, and let them, encourage them to become their own change agent. In the preparation stage, you have to help them develop their options and choices. You encourage and foster that self-efficacy and responsibility. Always help them come up with their reinforcements for their changes, and make sure we always address and identify potential risks so we can problem solve that and have strategies for dealing with it. And in the maintenance stage, it's always critical to focus on relapse and how to reduce that relapse, as well as the behaviors, the positive behaviors. And when I talk about relapse and the positive behaviors, it's always important to identify the behaviors, the environments, the people, and the situation that may cause a negative impact on their success. And we have to address those. And sometimes those people may be their family and their friends. So motivational interviewing really results in creating an individualized plan that focuses on cognitive approaches as well as behavior approaches. Those cognitive approaches are going to be including the education and the knowledge, increasing that using a teach me back approach, identifying and reducing their barriers, identifying their benefits of changing. Whereas the behavioral approach helps them identify the steps that they need to take and setting up those rewards for those steps. So far for motivating change, family environment, using motivational interviewing. Then another critical thing is providing follow-up care. I cannot express this enough. Research shows that the greatest risk for patients with chronic illness occurs with those who do not have appropriate follow-up care. And care ambassador programs have been very effective in helping identify, reach out to patients when they fail to show up for doctor's appointments. Dr. Stillman is very good at emailing me when one of his patients or our mutual patients has not shown up. But another option is providing after-hour support, particularly for those teens that are transitioning into adult care. Other supports include this one is actually very critical, and I've used this many times, is teaching realistic options for eating in social situations. And this is critical for our children who are obese or have diabetes. But another support is actually providing kind of email or text messages, prompts, encouraging and fostering their adherence. Now, I will share with you my next, paying attention, close attention time, because in the process of preparing this presentation, of course, you run into lots of articles written by individuals who suffer with a chronic illness themselves, sharing their viewpoints of what helped them or what was motivating to them. So I took that information and I literally posed it with every single one of my current chronic patients with chronic illness. And so together, this is a collective tips that came from these patients. So first of all, I mentioned that teens don't think in long-term concepts because they don't have that frontal lobe ability. So one of the things they say all the time is those long-term scare tactics absolutely do not work. They feel like the focus should be on the here and now. So it's better to focus on that if they do this now, it will make them feel better now. One of the things that came up predominantly over and over and over again is they need stories and examples of other children or teen with the same chronic illness who are surviving and thriving. And that was huge. They also don't want us to sugarcoat things. They want us to acknowledge that this is going to be a hard task to have, and it's going to be a permanent lifestyle change. Another one that came up consistently, particularly for my diabetic patients, is they really want us to address barriers that create feelings of shame or embarrassment to them, particularly going to the nurse's office or wearing a device. And whenever you teach health literacy, always use a teach me back approach, because they get overwhelmed very easily. There's a lot of information. So using that approach forces them to repeat back what they've heard us say, and it helps with their competency and understanding, and also they don't lose any information. We have to recognize that education and knowledge is good and effective, but it alone will not be a motivator. And using, either lecturing, coddling, babying, guilting them, using that you should approach, or over-controlling absolutely does not work. They very much respond more effectively to empathy and compassion and that reflective listening. Assuming what works for one patient does not automatically work for another one. And whatever we do, do not force a device, especially with teens. We got to help them understand this is a marathon and that they're going to have to want these changes on their own. And the final one that they said kind of goes together is positive peer social supports are key. However, every single one of them have so much shame with it. They don't feel comfortable with having face-to-face that peer support. Rather, what they would prefer to do is kind of gain that comfort level by easing into either peer support through social media or technology formats. So this real story, this young man, he was referred a little over 2 years ago from Dr. Stillman, as I mentioned previously, and it has been a marathon. Every single one of these barriers were real for him, to the point that he would not eat lunch at school, he wouldn't go to the nurse's office, would not take glucose readings or insulin at all during the school days. He had a huge issue with fitting in, refused to wear any kind of devices, and would not tell anybody because there was so much shame associated with having that. And there were apparently 2 other kids at school that he knew were diabetic, and people made fun of him, or made fun of these kids, and so that even drove his desire not to share that information. He definitely dealt with severe depression, lots of anger, and definitely risky behaviors, including recognizing what friends were really not all those good of friends, and they influenced him negatively in terms of alcohol consumption, and which impacted him, as well as not eating correctly. And family was a significant issue. This young man's parents are divorced, and there's complete disagreement, and that was a huge issue as well. Particularly one parent told this young man that he is now depressed because of his illness, his chronic illness. And so that was not perceived parental burden, that was a real parental burden. So all of those factors, every single barrier he had it, but he had it to a very high degree. And so it has been a challenge, and he has cycled through these stages where he does well, and then relapses, and then comes back. But he is in a really good place because he is now wearing a device, and his goal is to get his numbers in line so that he can actually get a pump. But this young man, and this is why this is funny, will tell you that probably the best motivating factor for him was to have a girlfriend who wants to be a nurse. And I find that he's got a great sense of humor, but he is definitely thriving now. In this presentation, I've shared with you of accommodations that you should put in a 504 plan. This is another motivating factor that will help kiddos. This is actually something that I found and have utilized with my patients already in the past, and it's very effective for diabetics in particular. And when we evaluate change, I always evaluate change using this transtheoretical model. I use the motivational interviewing, continuing to identify the barriers. Can keep in mind those barriers may change as they age. Looking at their attitudes and their beliefs and things that might impede their change, and then adjust those as we go. Now, next I was going to head for questions, But before I do that, I would like to be able to show you something else. Before I ever knew I was going to do this presentation, when I started first working with the young man that I shared with you, I found this website called Mastering Motivation with Diabetes by Adam Brown. And it was literally these tools that helped me with this young man. And so I'm sharing these with you, kind of more of the, not his entire article, but the concept, the gist of this, because these were very effective for him. And so when I looked at this with him, I helped him identify what is his purpose, why would managing his blood sugar and eating healthier important to me now? Again, is that focus on the here and now. And on the days when you're motivated, what are the biggest factors driving that? So then he can identify and connect how those good choices, what's happening that helps him continue with good choices. We talked at length about the biggest barriers, and we had to kind of, it's like an onion, you have to peel those barriers away, each one away, and address each one. Trying to overload at one time was not effective. And looking at what are the things in his environment that crushes his motivation. And then along with that is when we worked at goals, we would take the absolute smallest step. This was very helpful advice when I was working with him. We would look at 5 minutes and then 30 minutes, and then we would expand it again to an hour. And I had him actually get a sense where he was both emotionally and mentally aware of how he was feeling as he was progressing, because it helped him recognize that he was actually proud of himself and making change. And another big factor is looking at where he can get supports from others. What does he need to stop doing? What does he need to request from other people to stop doing? And helping them find an accountability partner. And we definitely worked on SMART goals. That whole point of, they've got to be SMART, they've got to be measurable, achievable, results focused, and time bound. So now I'll go back to the questions, and I hope I've got enough time. Are there any questions?
Oh, thank you very much, Lisa. Hang on a second here. I'm having some technical difficulties with my video. There we go. So very interesting presentation. Just a couple of questions. So can you speak a little bit about obesity? Now, obesity, of course, is a little bit more of a challenging topic because there are people that will come at it from the standpoint of, oh, it's all on the child or on the family. And while that's true that lifestyle plays a strong factor, as you probably are aware too, obesity can come in from a medical standpoint in cases like children who have, medical issues that impair their mobility. So do you have any special tips or tricks for talking to families and children who have obesity perhaps as part of the struggles that bring them in to see you, or that where obesity really is a center point or a struggle for them in terms of their self-esteem?
Well, and that's the good point, because oftentimes it really is more impacts their self-esteem. And so, it's interesting you say this, because one of the first things I always do, and you know this personally, is I will refer patients in just to make sure that we don't have an underlying medical condition.
Mm-hmm.
And it's not just necessarily like a medical condition, like you said, it could also be an orthopedic type physical kind of issue that needs to be addressed. And I guess my mindset with them is helping them is recognizing, rather than working on losing weight, it's more about let's be healthy. And how do we make those healthy choices? How do we eat healthy? How do we just have extra, positive, healthy exercise? But then how do we identify our self-esteem needs to not be tied into necessarily our weight? It has to be tied into our other accomplishments and who we are as a human being and what we have to offer others. But so it's not necessarily focused on just that weight scale.
Okay, very good. Thank you. And then one other question regarding diabetes. So again, kind of taking a page from the patient that we have in common here. So you know, self-esteem can be so wrapped up with some of the images, in diabetes or any other type of chronic condition can, I mean, it's basically a seismic change. There's typically no going back to before diagnosis state. So what do you see are the keys, or what are the things that you really offer to children and family in terms of helping them to make that shift and say, okay, this is my new normal. How, you know, how do you help them to move to a point where they're not tying up their self-esteem from what their old viewpoint is, and just also to help them to develop healthy tools and coping for future?
You know, this mutual patient was a very resistant patient.
Absolutely.
And so one of the things that was interesting is that he initially had a lot of anger because neither you nor I deal with diabetes, so we really don't know. So what I had to do is actually pull in a mutual colleague in the community who works for that county health department, but who has type 1 diabetes ever since, and was diagnosed when she was I guess maybe an early teen.
Mm-hmm.
And I would actually get permission from the parent to bring her in, and she and he would talk. And once we had that relationship and he could see that she was doing very, very well and that she had a great sense of humor, because she would carry her equipment with her in her bag called her pancreas, and it was labeled pancreas. And as long as there was a sense of humor with that, and knowing that here's a real life example, he then started to trust me more, and he actually trusts you more, that we're really on his team. So I think that was part of what was the biggest barrier to get past, is him not seeing you and I as understanding what it was like.
I definitely agree with that. I think, you know, that's one of the challenges that you know, I readily acknowledge too when I talk to families and to teenagers with type 1, is that I don't have type 1, so I don't have that ability to make that total personal connection. I mean, I have, and you have, you know, in the scope of our careers, had a lot of, you know, dealings, and so I have understanding at some level from that standpoint, but that personal connection is sometimes a real challenge. So that's really good. And we're very fortunate, I think, in our endocrine practice, that many of our nurses and other staff have type 1 themselves, which can provide, or, you know, they're the parent of someone, a child with type 1. And so that different level of understanding and connection, I think, is very helpful.
Yeah, it makes it relatable.
Exactly. And do you find, you know, from the standpoint of your work, is there anything that you, because I'll just say that one of the things that really struck me early on when I was dealing with this young man is, I think that there wasn't at some level some core resiliency. So one of the conversations I had with him is, you know, I think, you know, this really is difficult for you, but difficult times are going to come for all of us, whether we have to carry around chronic illnesses, chronic conditions, or changes in our life circumstance. And so building resilience is important. Is there anything that you feel that you would offer, maybe one or two pearls, as far as having a discussion with someone about building resiliency as they move from their teen years on into young adulthood?
Actually, you know what, to be honest with you, all teens need to understand that they need to have resiliency. You know, one of the things that we often do, and I guess maybe it's that back to that cost benefit or that decisional balance with them, oftentimes they do not recognize when they've overcome a challenge. And once they can see that they've overcome a challenge, or people that they care about has also overcome a challenge, they begin to recognize that they are actually resilient. And once they also to focus helping them understand that this is a marathon, and that there's things that they can still offer society, because it's more about their purpose. A lot of them focus on, what is my purpose? How am I supposed to impact this world? And that's very much part of the, you know, what is it, the Gen E generation, and the young people. Certainly not my, you know, much younger than me. But helping them see that they have a purpose helps develop their resiliency independent of the diagnosis.
Absolutely. And I would say one of the things that, and I hope that this is continue to progress. And again, of course, ultimately, just again, talking about diabetes, I hope we're going to have a cure at some point. But, the technology and the tools that we have at our disposal really helped. And really, one of the things that I present to families and to those, with that diagnosis is that you have very few limits. Military service unfortunately remains a limit, which can be really difficult for someone who may have wanted to do, active military service. But there are options, in firefighting, law enforcement, and other types of things too. So, the sky's the limit. I'd always point to someone that I worked with when I was at Vanderbilt who climbed Mount Everest with type 1 diabetes.
That's incredible.
So there's really very few mountains that can't be climbed or overcome with type 1 or whatever else you have as far as a chronic condition.
I do want to talk about where trafficking occurs. And I've done this lecture all over the state of Texas. I've been in small areas, I've been in big urban areas, and every time I do a lecture, I will go and do a search for that area to go, have they had trafficking in this area? Because a lot of times people think this only happens in third world countries. They think it only happens in big cities, and that's simply not true. I was speaking with one of the FBI agents that we have contact with about trafficking, and he reported that there was a town in Texas with 400 people, 400 population, where trafficking was occurring. So we see it everywhere. This is a recent one from Tarrant County where there were 41 people arrested. We have it all over North Texas, again, in small towns and in large towns. As far as the definition of human trafficking, and I get this question a lot, we'll have people that go, well, I hear about this and this is suddenly a huge problem. And you are hearing about it. And I appreciate the shows like 2020 and Dateline that have tried to get it out there for the world to know it's a problem. Unfortunately, a lot of times when they cover it, it will be there were two little blonde girls walking to school and a white panel van pulled up and snatched them off the street and took them to another state and began trafficking. Does that happen? Yes. Is it the norm? Absolutely not. And I'll talk some about that. The other aspect of trafficking is we've had trafficking probably since the beginning of humanity when we're talking about minors. We just used to call it child prostitution. And I'm going to talk some about that children can't consent. So it's really a misnomer. So probably our numbers were higher in the past. We just had it labeled wrong. And that is nomenclature that needs to leave our vocabulary. To put child prostitute in a sentence just shouldn't happen. And it's a struggle. Law enforcement struggles with it. I sit in multidisciplinary staffings where there's law enforcement, district attorneys, child protective services, and every now and again, one of them will say that, and it's like, no, it's not child prostitution, it's trafficking. So this is the definition. We do have in the United States, Congress passed a law that trafficking is considered anybody that is forced into either a commercial sex act or work under force, fraud, or coercion. Now that's for an adult. In the pediatric population, it's always trafficking, okay? So they don't have to prove force, fraud, or coercion in anybody under 18 to prove trafficking. The other thing that happened in the federal government in 2015 is it expanded the definition of trafficking to include anybody that patronized or solicited a child under the age of 18 for a sex act in exchange for something of value. And that was important because, if there was a pimp involved, they were getting punished, but the person that was buying that child wasn't necessarily falling under the trafficking laws. So that became very important. So this is probably one of the most underreported forms of child abuse. People just don't think of it that way. It is child abuse. I mean, when you really talk about it, people go, well, absolutely, that's abuse. 83% of sex trafficking victims identified between 2008 and 2010 were United States people. It wasn't those third world countries. So we absolutely know that. Again, it's very important to remember that in the pediatric population, you do not have to have force, fraud, or coercion to have trafficking of a minor for sex. Okay, so you don't have to have a pimp involved. There doesn't have to be a third party. It could be that if in an online situation, an adult offers something of value to that child in exchange for sex, that's trafficking, even though there's not that third party pimp. And it also doesn't require a child to be moved from one place to another to be trafficked. And some of our kids are trafficked by family members. It's not as uncommon as we would like to believe. So when we talk about this as a form of abuse, just remember it's in that big circle of child abuse. All right, so with this, sex trafficking also doesn't have to include money. It's really anything of value to that child that gets exchanged for that sex act. And we've seen all kinds of things. Sometimes these children are throwaway children where they've been kicked out of their homes. They may be runaways because it's a bad situation. So they may be exchanging sex for a safe place to sleep, for food, for a ride, or something of value to them. Oh, that person's going to get me an iPad. Or we had two little girls that were offered season tickets to Six Flags locally. So that's trafficking. Okay, it doesn't have to be the exchange of money. Vulnerability is really the biggest thing that leads to exploitation of our children. It's the main thing. And, I'll get people that ask, like, what were they thinking? And, I always say, think about what you were like when you were, 11, 12, 13. You just don't have those life experiences to protect yourself. And people who are trafficking children are very manipulative, and they use that vulnerability to their to help with what they're doing. It also leads to isolation of these children. They'll have enticement, promises of, I'm going to keep you safe. I'm going to love you. I'm going to be your boyfriend. Those types of things. It can have coercion involved. And then there's the exploitation that takes place, and then the sex trafficking. So as far as the scope of the problem, this is a huge industry worldwide. So, and again, these are estimates because, again, these people aren't paying taxes and reporting how much income they have. It is second only to drug trafficking, but it will likely outpace. A lot of the organized crime, cartels, gangs have realized I can sell cocaine once, but I can sell a person repeatedly over a period of time. So that makes them a whole lot more money. So they are moving into that industry. All right, so how many children are at risk? Again, these are estimates just because of the scope of the problem. We know that the vast majority of victims that we see, and this is, in the United States, but even in our region, the vast majority that we see are either those runaway or throwaway children. They're fleeing abuse in their home. With our LGBT community, a lot of those children, if they come out to their parents, may be banned from the home. And so they end up on the streets, and it's survival. I mean, they're exchanging a commodity to be able to survive because they don't have that loving home. And there are some kids that are kidnapped and forced into exploitation, but it's not always that. And that's probably one of the biggest things I want people to understand is you may be seeing these children in your clinics. You may be seeing them in the emergency department. And we'll talk about some of the things to look for. So again, the majority of identified children in the United States are legal residents or citizens. So it's not that third world country. It's not children that are being brought in from third world countries. And again, it happens in every state, every city, pretty much we can find it. So there are some social and ecological things that increase the risk of a child being exploited. Certainly there's some societal risk factors, and we'll talk about that. There's some relationship and community risk factors, and then there are individual risk factors as well. So the societal risk factors, some of it is lack of awareness. So that's why I'm thrilled that y'all are allowing me to talk about this topic that is not a fun topic to hear or think about, but it's important that as a society we know what's going on. There's some, having sexualization of children, and I'm going to talk about that. Glorification of the pimp culture. You'd be surprised what can be pimped in our communities. Gender bias, political and social upheaval, natural disasters. And I will tell you, this pandemic is certainly a disaster worldwide that's going to increase the risk to children. And some of that is the isolation that's taking place as a result of that. Certainly economic disparities increases the risk, and then migration. So when we talk about sexualization of children, I want you to look at some of these pictures, okay? And some of them are a little over the top, and some are things that you may have seen and not even thought about if you saw that in the store. So one picture is Miley Cyrus, and this was several years ago when she was younger, and she was performing at the Teen Awards on MTV. And so the people that are watching that probably aren't really the older teens. It's probably our little girls and boys that are, 8, 9, 10, 11, and seeing her and thinking, well, that's what you have to do to be famous or look pretty. So that's disturbing. We had Toddlers and Tiaras that was on television for quite a long time. That was little girls that were in beauty pageants, but they were dressing them up in very risque outfits. And so again, when you have little girls that think that's beauty and that's what they need to aspire to, it increases. And let me tell you what, predators love those shows because they get a quick, easy fix on what turns them on. And then the underwear that's on there, that was rolled out initially by Victoria's Secret, and it was marketed to the teen population. And I will tell you, I would have lost my mind if my teenage daughters had a thong on that said, "Call me." Like, that was not okay. Now, there were parents groups that were up in arms, so they remarketed that lingerie to an older population, but that's where, there's lots of money to be made. These are, other things that we see in our population that are sexualizing our children. Even something as simple as a Halloween costume. I mean, I know my mom always made homemade Halloween costumes, and there was nothing sexualized about it. It might have been, a pillowcase. So those are also things, and it becomes very embedded in our community. As far as the pimp culture, this became popular again on MTV, Pimp My Ride. But I mean, if you go on and do a Google search of Pimp My, it came up with even Pimp My Bathroom. So it just becomes very insidious in our population that we get kind of numb to what that really means. Community risk factors. In some communities, it's the social norm to have exchange of goods for sex. So if you've got adult prostitution in an area, it may not be as shocking as it is in a community where you don't have that. If these children live near a very transient male population, so that could be bus stops, it could be truck stops, military bases where you have people that are coming in and out of those areas a lot. Some of the community risk factors included criminalizing these children. And that's one thing about the last 10 years that we've really worked on with district attorneys' offices, governors, is, screening whenever we have adolescents that end up in the juvenile justice system and not making it a criminal charge for them, and really trying to get them some protection, okay? Because they are a victim and they shouldn't have a record for that. Now, as far as risk factors, anytime there's problems in the household, that can lead to it. So that family conflict, disruption, peer pressure. If you've got a child that her friend or his friend, I usually say her because the vast majority of our victims are girls, but boys can be trafficked. If they're coming going, look, I got this great purse and these cool shoes, and, you could have this too, and all you need to do is, X, Y, or Z, they may give in to that. It's not uncommon. Having unhealthy relationships is a big one. Now, I always say whenever you talk about family conflict or disruption, if you have adolescents in your home, you've had family disruption, right? I mean, that's just the norm. So all of our kids can be at risk if we're not really watching out and taking care of some of the things that we need to take care of. Now, I will tell you, one of the biggest risk factors for trafficking is just having that adolescent brain and the lack of development. Because if you remember, the amygdala is kind of in overdrive, right? So it's that high-risk behavior, immediate satisfaction, and you couple that with the fact that they don't have life experience, it increases their vulnerability. And then the frontal cortex isn't developed and may not develop till, their mid-20s. For some, maybe never, but they don't have that ability to think and process and life experiences to go, okay, if I do this, this may be the result afterwards. So that increases risk to our children as well. And then a very unifying characteristic among our children that get trafficked is low self-esteem. A lot of these kids come from homes where they aren't loved and nurtured and protected, and they crave that. And predators that are trafficking kids, they understand that, and they take full advantage. So who are the pimps? The pimps, most of us think, oh, it's going to be that stranger on the street that comes up and offers, security or money or a place to live, nice clothes, food. It may be that person. It may be somebody in their home. We've had moms that are trafficking. We've had dads that are trafficking. We've had neighbors in their neighborhood. So a lot of these children are in school. They're going home every night. But they're being trafficked in the afternoon or in the evening or on the weekends. So it may be those family members, friends, significant others. Regardless of who the person is, they are masters of manipulation. And they will find what that child is lacking and take full advantage of that. So it may be that they're just giving them some attention. It may be that they're offering love. It may be that they're offering items or money or season tickets to Six Flags. But they get into a cycle of abuse and affection. So sometimes they'll start with, you're really pretty, do you have a boyfriend? And then they will do things like take pictures of them nude. Or they may even physically assault them or sexually assault them. And then it's like, oh, I'm so sorry I did that. I love you. But now nobody's going to want you. And so you're going to need to do these things for me. Or, oh, I have these photographs of you. And if you don't do what I say, then I'm going to show that to your family or put it out on the internet. So then they have control over that child. And I will tell you, so this is Maslow's hierarchy of needs, right? And we all kind of go back to when we learned about that. Pimps are masters of using this. They will look at what does that child lack, what do they need in their life, and they will use this to their full ability. So if it's just the physiologic needs of a place to live, if it's love, if it's self-esteem, they will use that. So who are the victims? Again, the vast majority are teenage girls, so about 98%, but it's our LGBT youth, it's chronic runaways, children in foster care, children who have been in the judicial justice system, and if they've had previous CPS involvement, they're at high risk. 85% of kids come from single parent homes, but we've had kids that were in dual parent homes, highly educated, highly successful parents that have been trafficked. 56% had at least one, if not both parents incarcerated. And the vast majority of them have had a history of sexual abuse in their past. What we know is kids that are sexually abused, if they are in a home where they're believed, they get counseling, and they're supported, they usually are very resilient. But if they are in a home where they're not believed, they don't get the necessary counseling, it's going to increase the risk that they're going to be sexually abused again, and certainly that can lead to trafficking as well. So where do the pimps find these kids? Anywhere kids are. Okay, so it could be in foster homes, it could be in group homes, it could be at school, it can be at sporting events. Anything where kids gather, they're at risk, and pimps know where to find them, or traffickers know where to find them. I have social networking highlighted in red because that is a huge, huge resource for traffickers to find these kids. And so knowing what your kids are doing on social media is incredibly important. So these are just some of the apps that we have had kids when they were trafficked, because when we bring them in and we're getting history and it's like, well, how did you meet this person? Or, how did this happen? And it's like, oh, I was on Kick. I was on Hot or Not. I was on Poof. We learn about new social media apps all the time. And the minute that we hear about one, we will contact in our Crimes Against Children unit with law enforcement. They have a detective that all he does is the technologic side. And we'll call and go, hey, have you heard of this one? Nope. And they will immediately start doing their research and trying to find out about that app, because the pimps will move, whenever they realize that, they figured out on Facebook how we're doing it, then we're going to go to another one. I think one of the ones that always, whenever I do this lecture, that always kind of intrigues people or, concerns them is Minecraft, because we think of that as a game for, even the little kids. And what I like to tell parents is anytime a stranger can access your children, they're at risk. So even something as, innocent as Minecraft, if they're talking to somebody that they don't know, they're at risk. So you just have to be aware. And children don't understand. They'll be like, oh no, it's an 11-year-old boy just like me. Or, they believe everything that they hear because they don't have that life experience and that suspicion of those that they can't see. So there are internet resources. Craigslist was one that they had problems with. Backpage, which has been shut down, was a huge problem in the trafficking community because they wouldn't cooperate with police. They wouldn't release information, and there were lots of young children being sold on Backpage. And fortunately, that company got shut down, and their leaders are actually in federal prison. So we were glad to see that gone. So who are the buyers? And most of us will, you think of this, it's in seedy neighborhoods, it's in bad parts of town. The buyers are everybody. There is nobody that isn't, no group that hasn't been involved with this. Whenever you read some of the articles, you will see there have been police officers, there have been judges, air traffic controllers, teachers, physicians, nurses. I mean, it's awful. And if you think about the risk to these kids, who are they going to tell? I mean, if they go into court and the judge that they're sitting in front of is somebody who bought them, do you think they're going to tell? If their probation officer is the one trafficking them, do you think that they are going to trust anybody in authority? So those are the types of things that happen. We've had church youth directors that are trafficking children. So it's really our job as a community to make sure that we're doing everything we can to keep children safe. But where is that happening? It could be street prostitution. It could be at a truck stop. It may be at a sporting event. But again, oftentimes it's at home that these children are being trafficked. So again, I talked about that induction and maintenance. So again, it may be that they physically or sexually assault a child. They may take photographs of them without clothes on, and then they will use that as either I'm going to put this out there and everybody's going to know what you did, or they may threaten them with more violence. They may threaten their family members with violence. So oftentimes they're afraid and they believe that nobody can protect them, okay? And they will teach them to mistrust authorities. They're not going to help you if you tell they're going to make you go to jail because this is illegal. They'll have those kind of conversations. The pimp game, so there's instructional guides out there for people who want to become pimps. And probably most of the time you'll hear me talk about pimps. Like this is Mickey Royal. This is available on Amazon to buy. There are CDs that you can buy. I usually refer to men, but there are women who are trafficking children as well. And it's whenever you read or hear the things that they do and say to these victims, they're very manipulative, and they do understand the psychological aspects of how to gain control of another human being. So the conditions of captivity with these victims, and again, when I say captivity, it doesn't necessarily mean that they're not going home every night, okay? It's that just the captivity of control is probably a better word. Again, it may be threats against the family, physical abuse. With these girls, many of them may have had babies, and so they may have threatened that I'm gonna separate you from your child, and you'll never see that child again. They may threaten other girls or boys that they're trafficking. You know, if you act out, then your friend over there, I'm gonna hurt her. And so that becomes a way to control as well. So as far as medical providers and our response, it's so important that you understand what to look for and how to approach this. So, just understanding if we don't ask, if we don't look, we're going to miss it. But we also want to do it in a safe way to keep you safe, to keep the potential victims safe, and not to cause more trauma by the way that we approach this. Okay, so you may be the only opportunity that they have to speak with somebody from the outside. So I want you to think about what's reality and what sometimes the perception is. And I've had people, and I've experienced it here, and I've had to go back and do education with individuals in the emergency department. I got called in one night. It was a little girl that was being trafficked. She was found in a hotel room. They brought her in. It's February. I walk in, I've got on a coat, gloves, scarf, like I don't tolerate cold well. And I walk in and they had her sitting in the main waiting room. She had on little shorts, no shoes, and a halter top. And I about lost my mind because I was like, first of all, if this was your 14-year-old, you would want her to have a blanket. You would want her to be warm. You wouldn't want her out on display for everybody in the main waiting room. Like, what are you doing? And so sometimes there's that perception of, well, they made a bad choice. What did they think was going to happen? And again, it goes back to you don't know where they came from. You don't know the circumstances. And I don't want to re-victimize them when they come into the healthcare setting. So it's really thinking about, would anybody want that? There is not, I can't imagine that there is a human being alive that's like, sign me up for me to have sex with 10 different men a night or 10 different women, or, you know, that's just not normal. So we really have to change our way of thinking of who would want that. This is really a child and they're a victim. And did they have equal power? Because they don't. All right, so why is this a healthcare issue? There are so many things. Certainly the infectious disease that you think about with any kind of sexual contact, but there's also the physical. These children oftentimes are beaten. You may be seeing them present in a hospital because they have a broken jaw or broken bones because they've endured physical trauma. Certainly reproductive health issues. We know that these girls have a much higher increase of having things like PID and then infertility later in life. And then the mental health aspect. The vast majority of these victims are going to have PTSD and behavioral health issues long term. So things that you may see or hear that may indicate that you're dealing with a trafficked person. If they're accompanied by a person who is very much in control, they don't let them answer the questions. They want to do that for them. They don't want you to be alone with that patient. They don't want to use the medical translator if it's somebody that doesn't speak English. Those, are kind of red flags. And one of the things I would say is I think it's probably the right thing in every clinic that we have signs up that say a portion of our exam is going to require one-on-one or private. It gives you that chance to do those screening questions, and not just for trafficking, but for other things that a kid may not be honest about, even in front of their parent, because they don't want them to know that, yeah, I drink alcohol every now and again, or yes, I've smoked pot, but I don't want my mom to know. And if that's the norm in our clinic, it's going to be less questioned whenever we go, I need to talk to this person alone. They may be accompanied by multiple peers. Oftentimes you may think that's the best friend, but it may be another boy or girl that trafficker is in control of, that's there to watch to make sure that they don't tell. They may give false or changing information. They may have expensive things that you think, that family really probably doesn't have the money to afford that if you have that relationship. You may see signs and symptoms of sexually transmitted infections. They may be presenting because they need a pregnancy test or they need tested for STIs, issues related to pregnancy. Are kids with suicide attempts or suicide ideation? It may be that they're being victimized and that's what's leading to that. Any acute exacerbation of a behavioral health issue, we need to have in mind what's going on that's leading to that, and then certainly intoxication. Other things that they may use slang related to prostitution. So pimps, probably they're not going to use that word. They could, but it may be my daddy, my boyfriend, the stable, bottom girl, top girl. Those are words that we hear. They may have, a young girl or boy that has a history of multiple sex partners. We need to be questioning what's going on with that child. If they have an older partner, if we have a 14-year-old that's with a 20-year-old, number one, it's against the law in the state of Texas, but we really need to go, what's happening here? And then history of risk factors that we've kind of talked about. Physical exam, it's dependent on what's going on. It may be that they're not getting access to chronic, the chronic care issues like diabetes or asthma. It may be that they're presenting with that STI. Look for things like tattoos or branding. A lot of the pimps, they do that. And I'll show you some tattoos. So anything that has somebody's name, anything that has to do with money. So a diamond, dollar signs, we need to question. First of all, any minor that has a tattoo, I'm going to ask. And you don't ever want to approach them like it's judgmental, because if you've dealt with adolescents, they will like shut down in a heartbeat, and they pick up on that. So usually when I have a child that has a tattoo or what looks like a brand, I'll ask them like, oh, hey, that's a cool tattoo. Tell me about that. When did you get that? What does it mean? Because most people that have tattoos, there's a story behind it. I was in college and I was drunk and we all decided to get Bugs Bunny. Sometimes they may tell you, but you have to ask. If you don't ask, they're probably not going to volunteer that. The barcode is probably, to me, one of the worst ones, because it really labels that person as not even human. They're an object to be scanned. But looking for those. And we've picked up on kids here. We had a girl in the ICU, in the PICU here, that the bedside nurse saw this tattoo, asked about it, and got us involved. They may have injuries from physical violence, and that can be any type of injury. So it's doing that really good assessment. They may have injuries from sexual exploitation and violence. So again, the STIs, PID, irritable bowel, like all those kind of symptomatic things that can come whenever you've had sexual abuse. And then certainly the psychological trauma. And a lot of these kids feel shame, so they don't want to tell. They may feel guilt, especially if they've recruited other people into it. Depression. They may have memory loss. A lot of times these pimps use illicit substances. So they may give them things like ecstasy, because that will increase, or meth, to increase the sexual drive, to get them to participate. And then they'll give them things to bring them down. So alcohol and things like that. So they may have memory loss just because of some of the drugs that they've been exposed to. They may have chronic uncontrolled medical conditions. Again, asthma, diabetes, poor dental care, chronic fatigue, anything that we think about that you can have with brain issues, they may have that as well. So things that can make you not pick up on trafficking. Number one, just failure to recognize that it's a possibility, not having that in a differential. With these kids, they may fear physical and emotional harm, so they may not be forthcoming. If they're not here legally, fear of being deported. Language and cultural barriers are a big one. If they don't understand the laws, if they don't understand who's safe and who they can outcry to, that can be a problem. Pregnancy, shame, guilt, hopelessness, and they may be in debt bondage, where you have to pay me back this amount of money before you'll be free. And I will tell you, despite your best efforts, these trafficked children may deny that victimization. It can be for any of these reasons. Probably the biggest one that I've seen in care team is they don't perceive themselves as a victim. I love him. I chose to do this. That's what I wanted to do. And again, it goes back to that brain development, poor self-esteem that makes them believe that. It doesn't mean that we don't ask the questions, and it may take 10 or 15 times of a healthcare provider coming into contact to say, we're safe, and when you're ready, this is where you can come to, before they will outcry. So when you're responding, you want to ask the right questions. And we don't ever want somebody who's not trained to try and get all the details. Like, that's the worst thing you can do, because you may victimize that child more. You might have leading questions that taints an investigation. You really want to use that trauma-informed approach. You want to make sure everybody's safe, because again, these pimps make a lot of money off of these kids, and they don't want to lose that. So we don't want anybody to put themselves in an unsafe situation. Making sure you have a behavioral health evaluation, screening for substance abuse, and then your exam and diagnostic evaluation that you would normally do anyway. So again, we want you to stay safe. Don't try and confront the pimp or their handler, and having backup. For us in the hospital, we have security. I can call law enforcement. In a private clinic, I would make sure the police are understanding if you have a child that made an outcry of trafficking, I would have the police involved whenever you're kind of out there by yourself. So the first step, again, is that separation. You want to be able to screen in private because they're not going to tell. And that's hard. I get this question a lot. Well, how do you do that? So, again, if we have signs in our clinics or our areas that say a portion of the exam will be done in private, then it's just, you can say, well, it's our policy that we do this. There's some questions that just need to be asked in private. It doesn't mean that they're going to agree to it, but at least they don't pick up on like, well, they didn't do that with everybody else. And this happens in the adult world. I will tell you, I was in an emergency department as a patient. My husband's a police officer. He was in uniform with a gun belt on, and the nurse was checking me in, and it became just check boxes for her that she said, do you feel safe at home? Is anybody hurting you? Never made eye contact. And in my head, I thought, he's sitting right there with a gun on his hip. If I wasn't, do you think I would tell? So it's those kind of things that you have to think about whenever we're doing these types of screenings. Again, we want to use that trauma-informed approach to care. The first part is just realizing it happens in our communities, recognizing those signs and symptoms that you may see that may indicate that you have a child that's being trafficked, responding appropriately, making sure that you notify the right authorities, making sure that we are including that behavioral health piece with this, not just the physical care of the patient, and then resisting that urge to want to know more, tell me more about this, which can re-traumatize that child. Okay, because everybody has their role in how we wrap our arms around these kids to treat them. And like, I'm not going to do the investigation side. I'm really just, trying to make sure that they're safe, that medically they're taken care of. And then I then get law enforcement involved to do the investigative side, that we have behavioral health to take care of those needs. There are individual related barriers to preventing identification. Again, probably the biggest one is these kids just don't see themselves as victims. But again, it may be that they feel complicit. I agreed to this and I may get in trouble. It could be that they just feel that shame or guilt. There's a lot of different aspects that may come into that with the individual. As far as our barriers, just not having the knowledge that it's happening and what to look for. Checking off those boxes without really thinking about why am I being asked to ask those questions. Not having information on referral options. And so I will tell you, in our region, for kids that are at risk for abuse, we're the resource and care team. And we are more than happy to take phone calls, emails, consult us. We will help people walk through that process. And even if you're outside our region, you're more than welcome to call us. We will help you find the resources in your area if you think that you've encountered a child that's being trafficked. So again, important aspects of that history: reproductive, injuries and abuse, any substance abuse, and medical history and health. So you want to avoid any leading questions. If these kids start talking, don't interrupt. I always say you need to keep on, I call it my court face, because they may say things that you just want to go, oh my God, that happened. You can't do that. Kids pick up on that, and they will either think, I shouldn't have said anything, I should be ashamed, and they will shut down. So you really just have to go, okay, oh, okay. Really listen, but keep that kind of generic face on. Don't interrupt them. If they start talking, you don't want to interrupt, because that may stop them from sharing the information. You don't want to get into power struggles. It is not our job to interrogate these kiddos. They're not criminals, they're victims. And so it's really what they're willing to share is what we just need to document that. And don't press for details. We don't need to know every single detail. We just need to know that we're keeping them safe. Common relationships, about 27% are boyfriends, but 36% are family members. So again, don't think that it's just, that stranger that's trafficking these kids. These are resources for trafficking. If you think you have concerns, again, we're the resource regionally here. Call us, we'll help you. If you're in an area where you don't think you have that, you can always call the National Human Trafficking Resource hotline. They have access to 170 languages and are very good. Okay. These are some scenarios. Every one of these kids were children that came to our facility that when we got involved, we identified that they were actually trafficking victims. So we had a 15-year-old that came in for STI testing and a pregnancy test that was accompanied by her 16-year-old best friend. She was really another girl in the stable. And whenever it was separate, when she was separated, it was identified that she had been trafficked. We had a 17-year-old in the PICU with sepsis from IV drug abuse, and when the bedside nurse, started hearing some of the things she was saying, it became very apparent that she was a trafficking victim. We had a male 16-year-old that came in for a broken jaw, and by the nurse asking the right questions, identified that it was his pimp who had beat him up because he hadn't brought in enough money for the night. And that happens. A lot of these kids, they are told you can't come home till you make this amount of money, which means they're not going to get fed, they're not going to get sleep, they're not getting taken care of. So, one of the first things we ask these children when we see them is, when is the last time you had something to eat and have you slept? And if they haven't, I'm going to feed them and let them sleep before I'm going to do anything else with my workup on these kids. We had a 12-year-old uncontrolled asthma patient that was coming in frequently to the ER, accompanied by her aunt, who was indeed not her aunt. She was a trafficked child. 15-year-old grandmother again, a 15-year-old with a grandmother again. It wasn't grandma, it was the trafficker. And that child came in with repeated episodes of DKA. So again, it's that chronic child that's not getting the care that they need all the time. Okay? And then we had a mom that was a 17-year-old mother, had a baby in our NICU that wasn't coming for the visits, wasn't coming for the education. And it's easy to go, they're 17 and they just don't even care about their baby, or they don't want to do the right things. And what was really happening is her pimp wasn't letting her come. So again, it's kind of taking that step back and not putting that judgment of what we think, and really trying to figure out what is the underlying reason for what we're seeing.
So these will be the objectives. We're going to define it. We're going to discuss the ethical legal issues, the prevalence, signs and symptoms, and intervention and prevention. Okay. So let me talk about what bullying is. It's considered to be a conscious, intentional, and hostile act that is either meant to hurt someone and or also cause fear or harm. It can be done to you personally or behind your back. It can be done in front of you publicly where it's easy to identify. But it can also be done in the name of friendship even. The other thing too is it can be done by one person or a group. The action can be premeditated or just like spur of the moment, and it can be very obvious or subtle. But what's important is these three elements, and these three elements are actually the elements that have to be present whenever any of our laws were written. There has to be an imbalance of power. The intent is either to harm that person, either emotionally and or physically. And there has to be either pleasure in witnessing it or assuming that they're going to have pleasure because they know they're hurting someone. So keep that in mind. So there used to be 3 types. Now there's 4 types of bullying: physical, verbal, relationship, or also what we call social, and then cyberbullying. Any one of these alone is very harmful and very powerful, but when you combine more than one, it just amplifies that and makes it even worse. So we'll talk first about the physical bullying. Physical bullying is the most easiest to identify. Boys in the past, generally the ones who engage in this type of bullying more, that, however, has changed. It is now 50-50. Girls are just as aggressive as boys are these days, which is kind of alarming, honestly. Physical bullying accounts for about 1/3 of all the bullying, and it can be anything from hitting, kicking, slapping, punching them, choking them, poking them, destroying their property or clothes, just any kind of physical manifestation. And what's interesting and what we know from long-term, just valid statistics, is individuals that tend to engage in this type of bullying are oftentimes some of our most troubled teens, but not only that, if they continue, they tend to be ones who lead more into criminal behavior. Now, verbal bullying, that's the most common. 70% of all bullying is that. It is equally distributed between boys and girls. It's easier to hide, used to be with whispers and maybe notes, but now it's a lot easier because we have phones and text messages and computers. But while it doesn't leave physical scars, it leaves very stringent emotional scars. These can impact individuals' self-esteem and feelings for years, and they can actually last a lifetime. Verbal bullying is things like spreading mean rumors, gossip, lies, making accusations that are not true, sharing embarrassing truths about them, humiliating them, belittling them, taunting them, giving any kind of cruel criticism. And it can even include threats of extortion or threats with personal property or money. Now, what's interesting about verbal bullying, it is intended to hurt the individual, but there's also a very secondary gain to this too. It's also intended to change how people perceive that person. So it's kind of meant to make them look different or strange or unwanted or unworthy, which would create further isolation. And oftentimes it's the very first step that leads to more vicious bullying. Now we've got relationship or social bullying. Well, let me tell you, girls are just pros at this. They've got the highest engagement of this type of bullying, although boys have more so. But this bullying can be very powerful and scarring, particularly if it occurs during the middle school years or the high school years when kids are trying to figure out who they are and where they belong. And it can also be just as scarring and lasting a lifetime as verbal bullying. What this looks like, and I'm sure if you think about back in your days, it's where someone's ignored or excluded or shunned from a group, and they're isolated. Probably the worst case I've ever seen of a situation was a little girl that I worked with, again with a chronic illness, Friedreich's ataxia, and she had her tray at lunchtime, and she was going to sit at her table that she always sat at, that she thought she was sitting at with a group of friends. The moment she sat her tray down and the moment she sat down, every single one of those girls picked up their tray and left and removed themselves to another table. That's a profound example of social or relationship bullying. And it's exactly what it talks about. It prevents someone from being part of a group. And much like the verbal bullying, it's intended to make them look different and unworthy. So relationship bullying can be used to reject that peer, but can also be done to ruin friendships. So, eye rolls, mean stares, snickering at them, turning your shoulder at them, pointing at them and laughing at them or talking about them. Any of that kind of hostile body language is an indicator of social or relationship bullying. Now, cyberbullying. This type of bullying makes it a whole lot easier to hide their identities. Interesting, though, teens will tell you oftentimes they know who that bully is. But cyberbullying must require the use of internet, cell phones, video game systems, any kind of other technology that allows them to send either images or text messages that's intended to hurt or embarrass that individual. Now, why this is important, cyberbullying is truly considered an international health concern among adolescents. The reason for that is the plethora of correlational studies that have demonstrated this cogent relationship between adolescents' involvement in bullying and negative health outcomes. So teens who have been bullied themselves often report increased anxiety, increased depression, maybe even suicidal thoughts, loneliness, and somatic complaints. Whereas the kids who are the bullies also report increased substance abuse, aggression, and delinquent behaviors. The other reason why this is important, studies that were done in 2014, so this presentation is a few years old, but they even revealed the long-term effects of being bullied as a child or a teen and how that impacts overall well-being of an adult. So one study showed there's an increased risk of depression, anxiety, and a lower quality of life. Another one showed there's long-term negative consequences for their overall health, job prospects, and relationships. And another one also supported lower health, lower income, and lower quality of life. All three studies showed similarities. So now we'll talk about the types of cyberbullying, because there's different definitions for them. So cyberstalking is when you send messages repeatedly that includes threats of harm or intimidation, exposing someone, and it makes them afraid for their own safety or their reputation. Cyber threat, these are direct threats where they have got materials like naked pictures or whatever that's distressing to the individual and it suggests either harm to them. Another one is what they call denigration or dissing someone online, where they just post cruel gossip, rumors, things that are not true, just to damage their reputation or their friendships. Exclusion is where you exclude someone intentionally from an online group, kind of like that social bullying. It could be from a gaming group or even a friend group. And flaming is considered to be these online fights where there's a lot of angry, verbal, and vulgar language. Now, happy slapping. This is a sad situation, and I can share a true story with this one, but this is where a group of individuals use a camera to videotape a bullying incident where an individual is physically harmed. They hit them, kick them, slap them, but they physically harm them. And then that video is posted on YouTube or some other kind of site to get a large audience. And of course, that's humiliating and embarrassing to the victim. And there was a case over here in this North Texas area, and it was these cheerleaders, and one of the moms had bought one of the cheerleaders. They came from a lower income school, but one of the moms had saved money and bought kind of a used beat up old car as a way to help these girls get to cheerleading practice that was early in the morning. And these girls, the other ones who did not have the car, decided that rather than being grateful for having a car ride, they decided to gang up on her and beat her up. And she suffered a severe traumatic brain injury, which is how she came to me. So that's what they call happy slapping. Another type of definition for cyberbullying is harassment, sending rude, insulting messages repeatedly. Another one is impersonation, where you pose as someone else and you send text material online that either makes them look bad or gets them in trouble or danger. One of the worst ones was actually from a high school kid here. This young lady and this boy dated for 3 months. She broke up with him. He then had pictures of her, and what he did is he, I guess, photoshopped naked body parts with her face and sent them out everywhere. Of course, she became harassed and pursued and made fun of all the time, even though it came out that was not her body. That what ended up happening, how she came to me, she attempted suicide. And they now have moved out of the state. But what happened with that young man, because they were able to use several different laws because of the sexual content of this, he actually served time up in the Gainesville State School, and then he went into prison. I don't know where he's at now, but that would be an example of impersonation. Another one is outing. That involves sharing someone's personal secret or embarrassing information. And another one is trickery, where you're trying to trick someone into revealing private secrets, and then that information would be shared. So those are all the definitions, but when we look at cyberbullying, we've got to recognize that involves when a child, a preteen or a teen is either tormented, humiliated, embarrassed, and they're targeted by another child, preteen, or teenager. And it has to be some kind of mobile or digital device in some way. Now, it's no longer called cyberbullying. It crosses over into cyber harassment or cyber stalking when at least one of those parties is an adult. So when we refer to adult cyber harassment or cyber stalking, it's generally not called cyberbullying. So what are the ethical issues about this? Well, when we think of ethical behavior, we realize that we're demonstrating key principles of conduct or behavior. Fairness, honesty, equality, dignity, diversity, and respecting of individual rights. So we have to recognize that every form of bullying, doesn't matter if it's cyberbullying or physical or verbal, social, it's all a violation of ethical behavior. So the ethical issues to consider then is who should take responsibility? Who should regulate kind of bullying, particularly cyberbullying? Well, we have a lot of laws that do that. So let's talk about what is against the law. First of all, what is against the law is any harassment via computer, telephone, cell phone, or text messaging. And this is specific to cyberbullying. Any kind of verbal, textual, or graphic image that's either going to cause fear or physical harm, intimidation, humiliation, or embarrassment, that's also illegal. And any explicit pictures intended to harm another person, such as sexting or any text messages with sexual images, that is too. So one of the laws that we have is the Texas Penal Code. And that was amended in January 2012 to actually include the cyberbullying, cyber stalking, and cyber harassment concepts. And it also was expanded to include any of the sexual content or obscene content. So for us in Texas, cyber stalking is the most severe and can be punishable by a felony conviction. Now, I don't know how many of you, I wish this was an audience I could see you, if how many of you are familiar with the David's Law. This is a Senate bill that was passed, Senate Bill 179. It was passed and implemented in September of 2017. This law was driven out of a young man named David Molak, who lived in San Antonio. He was 16 years old, and he'd gone to school and was profoundly harassed. He was bullied verbally, physically, socially, as well as cyberbullying. They removed him from that school and he went to another school, and then the bullying continued. And he felt like he could not escape it and ended up taking his life. So the passage of this law, and I don't have this on there, but you need to know what is really, really important about this. This has actually given school districts, it's empowered them to do more about bullying that occurs either on a school bus. It's not just in the schoolhouse. It's in the school bus, school social activities. But here's the caveat too, and this is really helpful. If it impacts a child's performance, it impacts their behavior in the school, even though the cyberbullying or the bullying did not occur on a school setting, the school still has authority to intervene. So that's really powerful. So we've got the penal code now, and we've also got this within the school systems. So this law also provided new definitions for bullying and cyberbullying. It provided new guidelines for reporting assaults and harassment, and they can continue to report that without any consequences because if bullying continues. Schools also have to notify a parent, the victim's parent, within 3 business days, where in the past, they wouldn't notify a parent until after an investigation was done. So that's important. Schools also have to adopt policies allowing students to report people anonymously. And the other thing too, another very powerful thing is that schools can now either expel a bully or they can send them to an alternative disciplinary school. And also another one of the most important tools is that a minor, what it allows for is that the minor or the parents of a minor can actually seek injunctive relief from a bully, or even if that bully is also a minor, from their parents. So they can actually have legal recourse, and that has also been powerful. So when this was passed, this law also amended this Texas Penal Code to increase criminal penalties. It added jail time, higher fines, as well as more stringent guidelines and penalties for harassment. So what it does, this helps, I guess, make kids, ultimately the goal is to make them feel safer about that. Schools also have to provide grief counseling too, if they're involved. Now the prevalence of bullying. So nearly 50, and I'm going to try to go through this pretty quickly, but nearly 50% of the kids bullied, of all kids report they've been bullied online. 25% feel like they have been repeated bullied online. 87% of the students report seeing frequent bullying online. 68% of teens feel that it's a serious problem. And 81% of all the young people, which is teens and young adults, think that bullying online is easier to get away with because it's not done in person. And it does, there's research that shows there's this lack of inhibition. Kids are about girls themselves are twice as likely as boys to be victims, but they're also twice as likely to be perpetrators of cyberbullying. And those girls tend to send very mean messages filled with nasty rumors and anything that's intended to hurt them and isolate them. Boys actually tend to engage more in sexual nature or wanting to fight. And although there's some anonymity to this, there's 3 to 4 teens say that they do know there's cyberbullying. And what's key, and I want you to think about this and understand how this might apply later, is 30% of the teens express a desire to seek revenge. That's important. So, and 81% of these teens feel like the cyberbullying is funny. In fact, several of them will visit websites where they get to watch other kids being bullied. And 40% of teens have actually said their password has been stolen or they've been blocked out of using their account because someone's posing as them. Cyberbullying generally starts about 9 years of age. It used to end towards the upper ends of high school. That is absolutely not the case now. We're seeing this cyberbullying occurring at younger ages, but we're seeing this going all the way to college. And when you really think about what we see in our media environment now, this bullying is prevalent within our social dynamics. So it's not going away, it's actually getting worse. Bully victims are 2 to 9 times more likely to consider suicide. That's important to keep in mind. So what is the impact on these kids? The effects of cyberbullying specifically are far more extreme because it's 24/7. There's absolutely no escape. What used to only occur maybe in some environment or school is now occurring in their home and their devices, and it goes with them everywhere. And there's permanence to that bullying. Those insults never go away, and they're very harsh because we have a lack of inhibition. We just don't think anything about it. Why they say it's more anonymous, the reality is there's some familiarity because it spreads so rapidly that people that they do know hear of it. The insults are very far-reaching, and the speed of delivery of the insults is just rapid, and there's no sense of control or ability to control it and stop it. The victims of cyberbullying often experience some very unique and possibly even more intense and negative feelings. They have a lot more, and this is what I see even clinically, they have this intense vulnerability and powerlessness, and they don't even know how to get away from it. They feel very exposed and humiliated. There's an incredible anger and sense of vengefulness. They feel totally alone and isolated and overwhelmed. It really truly impacts their self-esteem, and a lot of them struggle with suicidal thoughts. When I mentioned to think about that sense of revengefulness, this is why this is important. Both school bullying statistics as well as cyberbullying statistics show that this bullying is a significant contributor to youth violence. That youth violence can be not just suicide, but also homicide. So both of these school bullying statistics and cyberbullying statistics have gone on to say that teenagers report that the strongest motivation for school shootings are associated with this bullying. 87% said shootings are motivated by a desire to get back at those that have hurt them. And 86% have said that other kids picking on them, making fun of them, or bullying them causes them to want to engage in lethal violence. So there are severe ramifications beyond just an individual. There's also within our community. So what are some of the signs and symptoms of being bullied? We've got obviously academic manifestations. They don't want to go to school, grades suffer, stop talking about their peers, they lose interest in their activities, they may even skip school, and they may even get in trouble at school. We have physical manifestations where there's sleep disturbances. That could be falling asleep, staying asleep, or more nightmares, withdrawing from family and friends that they'd always had before, complaining of somatic complaints, feeling very tearful and sullen, and having victim language. Emotional manifestations, That's where they feel very sad and depressed, or they could be very angry and irritable. Remember, oftentimes in tweens and teens, depression manifests as anger. They may withdraw and act more shy and timid, be overly moody and easily to irritate and agitated, anxious or highly stressed out, or aggressive behavior. The social and behavioral manifestations, you may see them withdrawing. They've got friends that used to be their friends are no longer their friends. They have a change in those friends. You may even see self-mutilation or self-harming. There could be threats to hurt themselves or others, talking of running away, and maybe even stopping using their computer or their mobile devices. So again, particularly if you come in or a parent comes in and enters the room, they may be very secretive about their use on the device, feel nervous when they're on it, spend way too much time, or become upset when it's removed from them. Things to be mindful of. 90% of all of our special needs students, which is oftentimes our kids with chronic illness, are bullied. They are targeted 4 times more than other peers, and 1 in 10 special needs students will likely experience a peer gang attack. So what should a cyberbully victim do? Absolutely, they should not respond. They've got to print the message and screenshot it, tell an adult, and discuss options for handling it. And I'm going to those more specifically. So these are the absolute to-dos, and this is according to school officials as well as police officers. Never ever respond to any message, text, or post, regardless of how untrue or hurtful it is. Never seek revenge. Save every bit of that evidence. Report all of that information to school authorities. They can even file a complaint with the internet service provider. If it includes threats or harm to self or sexual harassment, they need to also include the police, and they may want to include it if it's just repeated bullying. They can block all information from the cyberbullying, and there's been a couple of times where they've even I've had patients or parents contact an attorney. Now, and that was prior to the new David's Law. So now that we've got that, there's actually avenues to help them pursue those kind of legal ramifications. So things that a kid can do. Never give out their personal information. Never tell anyone other than their parents' passwords. Do not ever put anything online that they wouldn't want their friends or parents to know. Do not open emails from anyone that they don't know. And this is all stuff I'm sure you already know. Don't ever send messages that are angry. Always be polite, even if you don't feel like it. And then help other kids who are bullied. Be a good bystander. There's a lot of research that shows the efficacy of being a good bystander. And so here's some tools to do that. Spend time with them, and this is what we should do, encourage our kids to spend time with them, talk with them, encourage them, help them, get them away from a negative situation and stand out for them. Also tell the school or tell an adult. Now, things that a parent can do. Parents have to keep themselves educated. And just as like Christy was talking about, there's these new social media sites that come up all the time. It is hard to do, but we have to be equally savvy, if not savvier, than what our kids are. We've got to have a constant open communication and dialogue. I know when my kids were little, I would constantly share situations with them just as a form of education. Whenever it could be used in real life examples, made up or real, they seem to it resonated with them. Educate your child that everything they put in Cyberbullying is there forever, and it's important for them to have an online reputation. At one point in time, I used to be an advisor for a group of women at UNT, and there was a situation with one of the women that resulted in a lot of legal situations, and literally within 78 hours, we had access to everything this young lady had ever put on MySpace. So think about how far that went back. Facebook, Twitter, Snapchat, I think there was Kit Kat or Yik Yak, everything. We had everything within 78 hours. So it's out there and it can be retrieved. Always, as parents, we need to keep their computer in an active, busy area. Set up accounts with your kids, and that part of them having access to various devices and technology means that we have their passwords. Regularly monitor those accounts. Implement parental controls and use spam blockers. And those change all the time, and these people are savvy to figure out ways to get around it, but you've got to stay on top of that. I know there was word out about, at one point in time, there was what looked like a calculator was actually hiding a social media platform, and that was out there. That is true. I actually had a kiddo that had that, and they thought that they were getting away with things. So it's important for us as parents to always be aware of what's going on. Identify sites that your kids can visit, periodically check their computer history, and limit their screen time. Just as a neuropsychologist alone, we know that too much screen time, video game time, will definitely have ramifications on their brain in terms structurally, functionally, as well as chemically. So it's critical that you limit their time. And periodically Google their name and see what you find on there. Now I'm going to talk about this, and then I want to hurry up and get to the point of sharing with you a tool. But this big picture of prevention. This is actually information shared from my patients, both who are the bullies and also the victims. So bully prevention education should really begin early. It needs to be in every environment, home, school, with friends, but it definitely needs to be in the home. And these are the things that they've all reported, that they feel like the bullying is a problem because we lack a moral code these days, that we don't teach empathy, that we have lack of parental supervision and engagement, that parents are too busy with their own devices, that we have a negative influence from the media and the violent video games. And yes, there's truth to that, but it's not, if we would just look at what's happening in our news, it's full of it. It's everywhere in our world, and it's thrived upon. And bullies report that they enjoy power and attention. So the goal would be to help them obtain that in a healthy and positive way. So I always encourage parents to not be too naive and not think that their child is not the bully. I recently had someone share with me that they had seen something. I don't do Facebook, but they had seen something on Facebook where this mom, I guess it was a teacher, she found out that her son had been bullying. So she took that into her own hands, and she contacted the other mother whose son was doing it with her son, and they got to go get handcuffed and fingerprinted and interrogated, and they went through the whole booking process. And then she has taken away all of his devices and is making him be responsible for his actions and apologizing and paying retribution to this family in some way. That's what we need to do. We need to be aware that our child might be the bully, and we have to address that. So I want to quickly share with you about this tool, and I call it the RAT. Now, remember I told you about those 6 people, and so what was really interesting, all 6 of them revealed some very important information. One was that they really do like the power, and they like seeing their victim hurt. But what they also shared is that the reason why the ignore approach, just ignore the bully, didn't work for them is they were pretty self-centered. And so if they didn't see them, they made the assumption that they were still hurting. So that kind of cued me in that, we've got to have a different approach, because all 6 of them validated that, and just ignore the bully didn't work for them. They continue to target them. So with kids, what I do, particularly little kids, and of course I modify this for teenagers, but for little kids, I tell them, pretend you have a pet rat. And in this rat, you've got your feeder tube and your water tube, but you want to teach your rat new tricks. So you teach this rat to go punch a button, and every time they punch that button, they get a mini M&M. And so of course this rat is going to want to punch that button all the time because they like the M&Ms more than they like the food. And I kind of progressively lead them to what is behavior modification. So I get the kids to ask them, what do you think will happen? The rat's fat, you've got to stop, you're going to hurt your rat's health, so you have to stop this. So they just put a blocker on that M&M tube and the button. So the rat punches a button and no M&M comes out. So you ask the child, what do you think that will do? So eventually we get the child to recognize that rat's going to initially punch that button harder and harder and more often and more often. And eventually when nothing comes out, the rat, will give up. So it's a way of teaching a child how to learn a new behavior, and extinguish the behavior. So then I apply that to their bullies, and I call them rats. And I say, okay, every time this bully punches your button and you respond, you're feeding your rat. And once they get that concept, then they're all in, and they want to be able to stop feeding their rat. So then we talk about, how do you do that? Well, from what I learned from those bullies, we have to acknowledge their behavior. But we have to acknowledge their behavior that does not accelerate it more and communicates a message that they don't care, because then that takes away their power. So what I do is I focus on teaching them, and we role play this over and over. I teach them 1 or 2 words. The more words they're likely to say, well, if they say more than 1 or 2 words, they're more likely to say things that's going to get them into some problems. So we focus on just 1 or 2 words, such as so, who cares, whatever, big deal, sure, whatever. But then we have to also focus on our delivery of those words. So it's critical that what we do is we teach them not to convey any kind of emotion, because if a bully can see them being, fearful, hurt, sad, mad, that feeds them. So after talking with several friends of mine, who are speech pathologists, the only way that you can keep any of those negative emotions out of your voice is to kind of lilt it up a little bit, like, so, okay, who cares, whatever, big deal. And it doesn't matter if the child says the same word over and over and over again. So what it tells the bully is, I've heard you, I'm not going to engage with you, but what you're doing doesn't bother me. I don't care. Now, of course, we know it does internally, but they don't know that because their words don't convey that, and neither does their tone. So, like I said, with teens, obviously, I adjust that and don't have to use the rat approach, but they all buy into this. And then with little kids, one of the ways to help set them up so they can get rewarded in a way to help encourage them, I have them keep track. So they've got them and they have the rat. They can never, ever put up there the bully's name. So every time that the bully punches their button and they respond appropriately, they score the point. Every time the bully punches their button and they feed that rat, then the bully scores the point. And so this gives them something that instantaneously they can do that gives them their own personal reward. And then, of course, we share that at home and we set them up for more rewards for that way. But what I found, every single kid or even teenagers that I have taught this approach, and actually even some college-age kids, it's very effective, and the bullies tend to leave them alone. And what I have found that's very interesting is oftentimes those kids that have been the victim then want to help others. And so I just have to share with them, all you can do is practice this for yourself, protect yourself, but then be that good bystander. Share this with somebody else who you see being bullied, because that will help them as well. So that's what I've got predominantly with this. I think I may be a little bit maybe done before I should have been done, but I'm happy to answer any questions. And I guess I get so excited and animated about this because I'm so passionate about it that I just go through so fast. And so I apologize.
Well, 7 minutes is not that big of a deal. So definitely, I mean, that was a very fascinating talk, and thank you and thank Dr. Thornhill very much. I mean, both of those were just very, very relevant and areas that I think impact across all the different specialties. I wanted to go ahead and take a few minutes and encourage the audience to submit questions. We have up to 30 minutes that we can spend on a panel discussion before we run into our lunch hour here. So just to remind people, there's a Q&A function, so you can submit questions if you're on like a desktop or a laptop computer. And if you're on a mobile device, you can do by chat. So I'm going to go ahead. I see that we have a question that's popped up here and a few more that are queuing in. So the first question is for you, Lisa. So are there any YouTube videos out there that are available that maybe can teach people that are being bullied how to handle, basically kind of some practice exercises or tips or things like that?
That's a great question. Honestly, I don't know, because I just used my tool that I came up with. I've actually had several people in our marketing department said we need to patent, copyright that. You don't patent
Right.
that. That's an invention, that you copyright that. But I do know that there's some resources that I've attached to the end of this presentation. I don't know if there's YouTube videos. Maybe that's the thing to do, is make this as a YouTube video at some point in time. But
well,
I do.
the good news actually is that this is going to be permanent content.
Oh, wow.
You know, we won't have the opportunity, or it'll be content for several weeks at least. We can talk about offline whether you want to share that in a more permanent status as well. But anyway,
That's kind
I'm
of
sorry to
scary
interrupt you. But anyway, there will, as I said, people will have the opportunity to listen to your lecture. And I know for myself, I'm wanting to go back and listen to some of the topics too, as I had to step away a few times during your lecture.
Well, the thought of it being permanent could be a little alarming out there on YouTube videos.
I understand.
I avoid all social media. I don't even engage in it at all. But yeah, that would be absolutely something I would consider to do, because I do think this approach is very effective, and I've not had, knock on wood, I've not had a single teenager or child say that it does not work. Because if you think about it, with those elements of that they look for, the 3 elements with bullying, it removes the balance of power. It communicates that there's no harm. They're not intimidated, humiliated, and so it doesn't make them feel important. The bullies are not important. So it does remove all 3 of those elements.
Good, very good. I had a question for Dr. Thornhill real quick. So one of the things when, your lecture talked about the different settings that people come in, children or teens come in that have been trafficked. And one thing that struck me with that is, or something I've wondered is, the setting, it would seem to me that the setting where most of these people are going to be encountered, or most of these situations are going to be encountered, is going to be like in an emergent care, urgent care type of setting. What about recognizing it? Are there any things that can help me, when I'm having my first visit in the endocrine clinic, doing a consultation, or more specifically the primary care provider, the physician, the nurse practitioner, the PA, who is seeing someone in their clinic perhaps for the first time, or who's seen someone a few times, to help to raise their level of suspicion?
It's a good question. So yeah, probably when we talk about like the runaway kids, throwaway kids, it is going to be the emergency department or UCC that tends to see this more frequently. However, there's a lot of these kids that are being trafficked and going home every night. And it may be their parent that's the trafficker. It could be a neighbor. It could be a friend or another family member. So I think it's really important that as part of every encounter with a patient, that you do have that private time, and not just to screen for trafficking. We all need to be asking children, has anybody ever touched you in your bathing suit spots? Have they had those conversations with you? Because it may be whenever you do those screening questions, you pick up on those other things. It just gives them that safe, private time to outcry. And again, they have to be ready. So that's why I say every time we encounter these kids, we need to be asking those screening questions. But it needs to be in private. And so if you do have that up in your clinic of a portion of the exam will be private, it takes away the suspicion of somebody that may be hurting a child of, oh, that's the norm in this clinic. It doesn't mean that they're going to agree to it, because even families that don't. We encounter those parents like, you're not talking to my kid by themselves, unfortunately. But they do need that private moment to be able to talk to their provider to tell them concerns that they may be embarrassed to talk about in front of their parent or, caregiver. So yeah, that's a good question. Even though you think you wouldn't encounter it, just remember these kids may be living at home, but still being trafficked when they're at school or after school or visiting the neighbors, spending the night with them.
Is there anything, certainly teenagers are one area, but what about younger kids? Is there any clues that you would pick up on or that would help someone who's seeing a child pick up on that might make them suspicious about trafficking?
Yeah, that's hard. If it's a verbal child, again, I think it goes back to even with them having that kind of private questions of, and we do it in care team, has your mommy or daddy or whoever they're with, did they teach you about your bathing suit spots, that nobody's allowed to look at that, nobody's allowed to touch that, nobody's allowed to take pictures of that, except if you go to the doctor or it's, mommy. And if they say yes, then you can kind of go, okay, tell me about that and get what you can and then make a report. Not trying to delve into the specifics of it, because again, we want the right person doing that interview to find out more. Or if you have that child that's coming in with a lot of somatic complaints, that you can't ever figure out like what else is going on with that child. And it may not be sexual abuse, it may not be trafficking, but keeping that in your mind of what else is going on, that this child's presenting frequently for stomach aches, headaches, I don't feel good. I mean, just those things that bring them in, that it may be more of that psychologic impact on their physical health.
That's interesting, because I think many of us in both specialty and primary care see, children who are brought in frequently for non-specific complaints, multiple, complaints. And, in many of those cases, I don't want to broad brush it, but I find that there's a lot of emotional, behavioral issues that kind of overlie those. It's not to minimize and say that there's not something truly going on. And sometimes, these individuals have other problems too, or their medical issues too. But many times my first go-to with that is to move more towards, a psychologist, clinical therapist type of assessment. Do you think that would be a good way too, or is there anything that I could do or that someone in my position could do to try to determine, okay, is there any potential for trafficking there?
Yeah, I think it's just kind of doing those screens, asking those questions. If you have a child that makes an outcry that anybody's touched them or taken pictures, those types of things, a report needs to be made. And then CPS can do the more in-depth screen of, is it a trafficking situation or is it sexual? I hate to say just sexual abuse. Not traffic, sexual abuse. Because sometimes we do get those kids that, Uncle Bill touches them every time they go to their house. So we see some of those behaviors. It doesn't mean they're being trafficked. It's still something that needs to be investigated. I think the other thing is providers, with so many of us, like here we have Epic, is we tend to, as providers, get focused on just, okay, I'm seeing this kid today for this, and not looking at the whole record and kind of going, this child's been here 15 times in the last 2 months. What might be going on? And is it kind of those somatic things that we're going to a lot of different places trying to figure out? And then maybe that is a child that needs a little bit more in-depth screening or referral to the behavioral health side.
Absolutely.
And sometimes those referrals to behavioral health will allow them to outcry when they're there, because it's wherever they're going to feel safe and who they feel safe with, that they'll make those outcries. And it's not anything that we necessarily do or don't do to make them feel safe. It's really about that child when they reach that point of, okay, now I'm in a safe place that I can tell this person.
Thank you. The next question that's come up is for Dr. Elliott. So with all the many social media platforms that are out there, are there any resources that can provide education on the latest apps and just a rundown on how likely those, or how, if you will, trusted those apps are?
Well, actually, I wish now I would have probably included some of those into this, but there are resources, and Dr. Stone, I can actually send those to you later. Most of those resources actually came from our own education department. But I do know that if you just Googled safe apps for children or social media apps for children and teen, they will actually, there's tons of information out there on the web about that.
Good. Oh, well, thank you very much. And there's a follow, or not necessarily follow-on question, but another question for you as well. So this is from a pediatric subspecialist who takes care of children, who are medically complicated with chronic health conditions. As many of us, and especially as we move from primary care on into the subspecialties, we see a larger number of children, at least in my experience, a larger number of children who have developmental differences, learning differences, developmental disability, special needs. And I personally, I believe that there's some data that would say too that those children are much more vulnerable for bullying. So the question is, what what resources, education that we can provide to the children, their families, to people in the classroom are available that can help to reduce the chance of bullying in these children? Of course, without violating HIPAA was the other question.
Yeah, that's always the key, isn't it? So
yes.
And that's, just as I mentioned in that presentation, those are our most vulnerable children. So one of the first things that we do is I've been fortunate to work with some of our social workers that's in like neurology and some of our other departments. And so we have to get the releases so that we do not have a HIPAA issue. But I personally have gone out to schools and have met with teachers and the school administrators. And then we talk about how we're going to educate this child's classroom. So I had one child not too long ago that had the paddle for seizures. And she had been bullied, and she's a high school student, and she's continued to, deal with some of those effects. But what we did is we went into the classroom, we educated all of the students. We invited those students' parents to come so that there could be some kind of follow-up and continuity even outside of the school setting. And then we had the teacher's administration there. And the child in this situation chose not to be present at that time. But then we had a follow-up where she came in and she did a fabulous job of teaching them about this, about her type of epilepsy and the paddle and things like that. And that empowered her a little bit. And then all of a sudden it took away that fear of the unknown of what it is and created understanding. And shortly after that, she actually had 3 girls that came up to be her good bystander. And those are 3 good friends of hers even today. So I think kind of thinking outside that box a little bit and be willing to go, not just deal with them directly in the family, but taking it out to other environments was really, really helpful.
I agree. I think one of the key issues in moving back again to the experience with endocrinology and someone who is diagnosed with type 1 diabetes, when they return to the school setting, one of the things I talk to them about is beginning to share with friends, first close friends. I think it's important for sharing to be at the comfort level of the person. And so sharing with close friends, and then trying to explain and share in a very matter-of-fact way, okay, this is what the reality is for me that I have to do to take care of myself. I think so. Educating and trying to demystify the whole process, the steps, the things that need to be done now on a day-to-day basis, to maintain health and to be out there in school is very important.
I completely agree. And it's interesting though, when you talk about communicate this and demystify with their close friends, oftentimes that can be a challenge because someone who they thought was their close friend turns out not to be a good influence. And so you have to be able to be prepared for those risks as well and how you would handle that.
Definitely. Do you have any tips as far as helping people to discern in situations of bullying? Because sometimes the bully can be someone who was a friend formerly and who, has moved to a different social group or for whatever reason has decided now to become a bully or even move back and forth. And I can, not wanting to pull the curtain back too far personally, but that, in our family was an experience several years ago in elementary school with our child.
Yeah, I have to be honest with you. I'm very happy to pull back that curtain on ours because we had the same thing with one of our son. And one night at dinner time, he got so frustrated because he's 6'3", actually a legitimate 6'3" now.
Right.
He back to the pearls of growth. But he was very frustrated with me because I kept trying to help him be a good bystander, be a sympathetic and empathetic friend, and all this stuff. And he just put his hands on the table and said, "I'm sick and tired of you telling me why he might be like this. I want you to teach me what you teach all of your patients." So I taught him the rat, and by the end of that week, that rat's mother was calling me saying, "We've got to get together. Something's going on." And it worked. So I understand that. So let me talk about the friendship thing. I actually have this, and I wish there was some way I could show it to you. I use it all the time. It's what we call circle of friendship. And I'm going to see if I can actually.
Okay.
I
tell you what, if you want to try to find that, there's a question for Dr. Thornhill that's
right
on a related basis. If you want to work on that or mute your mic, I'll toss the floor to Dr. Thornhill here real quick. So the question is, so if you have someone who is being trafficked, and especially if that is someone who is being trafficked by a family member, there's that trust. So how do you work with children to try to help them to understand? Because sometimes I think unrealistically they may have trust or an attachment that is hard to break. So how do you help them to I guess, have the security and feel safe enough to make that kind of a break?
Yeah, and that one's hard. And even if it's not a family member, children that are trafficked oftentimes form these bonds with their abuser, or other children that may be in what we call the stable that they're trafficking. They form these bonds, and so they do have that. It's not an easy fix. It's not a one and done. I saw him and we took care of this. It's really, if you have that concern that a child's being trafficked, you can't fix it in one visit. You can't fix it in 10. And a lot of these children require a 6-month to a year-long inpatient kind of reprogramming and recovery. And unfortunately, we don't have enough of those programs, and certainly not in our state. But it's really get the report made. You've identified it, get the report made, and get the right people involved in that child's life, because it's going to be a long-term process. Because it is. I mean, if your mom, I had a little girl, an adolescent recently within the last year, that when I was getting history, it had been referred as a sexual abuse. And as I was getting history from this child, I realized her mother was trafficking her to this man. And, even during that interview, you know, because I asked about, I was doing just some screening, like how do you, you know, if you get in trouble, how's your relationship with your mom, your sister, those types of things. She was like, oh, my mom's my best friend. I'm not going to change that in that child in one visit or 10. That's going to be a long-term counseling piece with that. But it is getting the right people involved and getting them to the resources that they need. And it's hard. It's hard.
Thank you. Do you have something for us, Lisa?
Oh, yes, I do. So it's literally on my phone. So I'm going to show this up to the camera, but we call this, I use this all the time with kids to help them identify types of friendships or acquaintances. So I don't know, can you see that? Is that?
I can.
I don't know if everybody else can.
If you hold it up just a little bit higher.
Okay.
Stop.
Okay. So you notice the center is them. The next circle is their family. The one after that is what we call, kids oftentimes refer to as best friends. Notice how thin that range really is, because there's really not going to be that many best friends, because you can't sustain that kind of quality of connection with a ton of people, right? And then you have close friends, and I can't remember the ones out there. So I utilize that frequently to help kids understand the type of people that will enter their lives. And then we talk about the behaviors of how you identify someone who is a real genuine friend and someone who is not, someone who would be a good friend that you enjoy being with, but maybe not someone you share your deepest secrets to. So just, you know, tying this into that gentleman that we talked about in the very first presentation with motivation, that is our mutual patient, you know, he did share initially with some of those what he thought were close friends, and they were the ones that really influenced him to drink and not adhere to dietary restrictions and things like that. And so he had to eliminate those and move those down to a further circle.
Right. That's hard.
Yeah.
Question for Dr. Thornhill. This is from a nurse who works primarily at bedside. The question is, there are times that we know that a patient has been trafficked, or we have suspicion of that. How often should we try to talk about it? We do screen, and of course she mentions that they do screening questions on admission, but she wants to know, should they try to engage with the patient about what they've been through, or just be supportive? Especially, you know, assuming if they bring it up, obviously that's a bit different. But anyway, what's your advice?
Right. So I think doing that screening is the first step. We don't want to get into interrogating, trying to dig it out of a kid, because they will, when they're ready to share, they'll share. Now, if the child is talking about things, you can certainly say, you know, tell me about that. But I wouldn't keep trying to push them, because they will shut down, and then they become not trusting of all healthcare providers. And again, I was talking to a survivor. She's 17 now and had been trafficked from the time she was about 12 to 16. And she said, every time I went to the hospital, I got screened, and she just wasn't ready. She didn't see herself as a victim. She knew going back home, which she thought was her only option as an adolescent, that it was worse than what she was doing with this pimp. And it wasn't until she was ready to tell. But she said the fact that every single time she went to the hospital, somebody screened her and asked, it let her know that that opportunity was there for her. So I think that's probably the best, is do your initial screen and then just listen to them and be there when they're ready to make that outcry.
Thank you. Well, there doesn't appear to be any more questions. Do either of you have any final thoughts about your topics or anything else that you feel like would be useful to share, and before we sign off for lunch?
I don't. Like I said, with us, if anybody has a question, reach out to us. We are on call 24/7, and we would much rather somebody call us and let's talk about it and walk through the process than to not report, because you don't know what to do, or to do something that's going to make that child shut down.
Understand, definitely.
Well, the only thing I'd like to say is back to Dr. Thornhill. I so appreciate this type of education, and we need to have more of it because it is a very serious issue. You're exactly right.
I agree. You know, as a pediatric subspecialist, I'm a little bit removed from seeing it on the front lines. I certainly do, you know, have involvement with the care teams when there's concerns about, you know, physical abuse more than the type of trafficking. But this is very good education for me as well. So I thank you all both for taking time.
I was always smaller than all the other kids all throughout elementary school, but it wasn't till 4th grade where I really noticed that there'd be all these tall kids and then me, and in those pictures I looked like I was years younger than all the kids.
We're both, you know, very concerned about that. We watched him very closely. We were very protective of him.
We knew that we had to do something.
Every parent wants their child to measure up, whether in school, in sports, or in level of maturity. A parent's desire is for their child to at least be equal to the level of their peers. But what if your child doesn't measure up in stature?
You worry about your child. You want to find out, is there something you can do?
In children, there is often a feeling of anxiety about their small stature and slow growth. Often, they are teased, bullied, and it may be damaging for their sense of self-esteem.
Some of the kids tried to get up in my face and make fun of it more and be like, "Yeah, you have a condition and there's nothing you can do about it."
It made me feel a little embarrassed and sad.
The frustration is often compounded when parents are not sure what causes their child's growth failure or what to do about it.
It depends on the etiology. Some of those particular patients could be treated, so the diagnosis is very important. What is the cause of growth disorder, and some specific treatment could be implemented.
This is why the Human Growth Foundation was established in 1965, so no family travels this path alone. It is the oldest and largest nonprofit of its kind, with parents and friends of children and adults with growth problems, physicians, and other healthcare professionals.
The Human Growth Foundation has been an excellent source of support and assistance for us. I'm about to cry.
The Human Growth Foundation mission encompasses areas of education, outreach, and advocacy.
We have an educational committee who writes booklets about the different disorders that are related to growth. They're written in a way that parents can fully understand the medical aspect of what their child is going through. We also have an internet support list on our website, one for the parents of children and one for adults.
I'm very proud of all the people that work in the Human Growth Foundation. Most of us are volunteer medical professionals that have a passion for growth disorders, and the expertise that we bring really helps as far as crafting the message and the information that we can provide going forward in the future.
I had an excellent endocrinologist. She was the one who recommended HGF. Those are the things that matter to me.
Recognized as a global leader in endocrine care and advocacy, the Human Growth Foundation offers a wide range of workshops for parents.
It's a great educational experience, and it helps all levels of all parents to understand what's going on.
The organization works to keep physicians and other healthcare providers abreast of the latest developments with dedicated workshops across the country and even overseas.
Without Human Growth Foundation helping us to get together, we're not able to collaborate and share ideas and thoughts and approaches.
Take your mark, set!
The Human Growth Foundation brings the community together with family fun events and calls on the aid of Hollywood celebrities to increase awareness of growth disorders and the importance of early diagnosis and treatment.
Helping people is a passion of mine, and it's just really an honor for me to be able to give back.
And while the Human Growth Foundation is making a difference in the lives of those impacted by growth disorders and growth hormone deficiency, it needs you, the community, to be a part of this growing solution.
If you can donate, please do so. We need your help.
Helping people is good.
This is the one gift that keeps on growing.
Thank you for the invitation to speak. My name is Olga Gupta. I am a pediatric endocrinologist at Children's Health in Dallas, and I'm the medical director of our COACH program. That stands for Center for Obesity and Consequences of Health. And I'm really pleased to be a part of the program today. So today we will be discussing obesity in children and teens. Our learning objectives, we're going to explain the trends in the epidemiology of childhood obesity, compare and contrast the similarities and differences in prediabetes in youth versus adults. We're going to list 3 weight management strategies in youth with prediabetes and obesity, and identify pharmacologic approaches to severe obesity in youth. Let's start with a patient. So Kira is 16 years old, and she presents to your clinic for evaluation of weight gain. Now, I don't know how many of you use these BMI charts in your clinic, but just to orient you, this is the child's age down here, so she's a little over 16. This is their BMI here, and these extended dotted lines are the percent of the 95th percentile. And the reason these graphs are important is because on the regular BMI chart, if the points are up here, they just kind of max out at the top of the graph and you can't really distinguish where they are. But on this graph, you can see that Kira is at 170th percent of the 95th percentile. So that puts her in class 3 obesity. And just to remind us, class 1 is less than 120th percent of the 95th percentile. And class 2 is between 120th to 140th percent of the 95th percentile. And class 3 is above 140th percent of the 95th percentile. So Kira's class 3. Her exam is notable for acanthosis nigricans, and her A1C is 6.2%. So what do we do now? Should we do an OGTT? Should we start metformin? Should we encourage her to lose weight? Let's see. So I like to start my presentations with a historical perspective. So this is a textbook from 1929. And I thought, I wonder if they mention childhood obesity in this textbook. So I went to the index and I looked up obesity. There's no childhood obesity, but there is a section on obesity in the chapter that is titled Self-Care for Women. And it states that slimness has become the ideal of beauty today. And so it recommends, well, it says the secret of transformation in a corpulent woman's appearance is undoing the bad habits of years. So upon rising, 2 cups of lemon juice and hot water, then 10 minutes of simple exercises, taken in a nightgown or a one-piece swimming suit, but thicker in the winter and with the window open. So sounds a bit kooky maybe, but while some things are different, some things haven't changed at all. So obesity in children, over the past 30 years, obesity has doubled in children and quadrupled in teenagers. And today, 18%, or almost 1 in 5 children or teenagers are obese, and 35% are overweight or obese. this is a graph from within the past 2 years, and it describes the prevalence of obesity and severe obesity among children ages 2 to 19. And we discussed before the different classes of obesity. We have girls on the left and boys on the right. And so what we see is that it's steadily increasing. The class 1 obesity is steadily increasing for both girls and boys. The class 2 obesity is increasing as well. That's the one in the dotted line. And the hashed line, the class 3 obesity, the most severe, is about twice what it was in 1999. So all classes of obesity are continuing to increase. Now this graph is the most striking to me. It's the prediction of what today's 2-year-olds will look like at age 35. So here's the age on the x-axis and the obesity prevalence on the y-axis. So if you're 2 years old today, there's a 60% chance that you will be obese by the time you're 35. And of course, that prediction does change according to your current obesity status. And so here in panel B, if you're 2 years old today and you have severe obesity, there's about a 90% chance that you will be obese by the time you're 35. So I think it's really important for us to address and tackle the issues of childhood obesity today while they're still young. Now, while the prevalence of childhood obesity is increasing, the incidence of type 2 in youth is increasing as well. So let's focus on panel B, because panel A is for type 1 diabetes. And panel B is type 2 diabetes for children between the ages of 10 and 19. And let's look at the purple X's, because that's across all races and ethnicities. And that's slowly going up from about 10 per 100,000 youth in 2004 to maybe closer to 13 or 14. But look at the demographics that are at high risk, including the Native American population in the orange diamonds and the non-Hispanic Black population in the black triangles. And both of those populations are about twice the incidence as they were in 2004. Now, I know Dr. Delatorre will be discussing type 2 in the next talk. But I'd like to talk about what happens before type 2 diabetes or prediabetes. So this is a table from the recent ADA guidelines, and it discusses the criteria to diagnose prediabetes. And we're looking for an A1C 5.7% to less than 6.5%, or fasting glucose between 100 and 126, or 2-hour OGTT between 140 and 200. Now, there was an article in JAMA Pediatrics last year that examined the prevalence of prediabetes in the US teens and young adults. It was based on a population from 2005 to 2016. They looked at these teenagers, again, the ages 12 to 18, and what they found was that 18% had some evidence of prediabetes, whether it was an elevated A1C, impaired fasting glucose, or impaired glucose tolerance. And that's compared to about 24% in the young adults. So that's an alarming statistic, and many media outlets were concerned about that. And here's one from CNN Health that says 1 in 5 US adolescents is now pre-diabetic. But I'd like for us to really digest these data carefully, because there's little overlap between the subgroups that have the impaired fasting glucose or impaired glucose tolerance and increased A1C. So when you look at the groups that have 2 or 3 of these, the numbers really go down to maybe 1% or 0.7%, and only 0.2% had all three criteria. We have to remember that impaired fasting glucose and impaired glucose tolerance, they have poor reproducibility. In a separate study, 21% of individuals with a high A1C and 36% of those with impaired fasting glucose were actually normal on the second test. And in this data that we have here, the prevalence was higher in the individuals with obesity than those with normal weight. And also, what does it mean to have prediabetes? So there are few data that are available on the rate of progression from prediabetes to type 2 diabetes. So there's no guarantee that a patient with prediabetes will go on to develop type 2 diabetes. So while these data are interesting, we'll just have to use them cautiously. So let's say that we do have our patient Kira, with prediabetes. What do? Now, who here would prescribe metformin? Sometimes I do. Is that the right thing to do? So why are we prescribing metformin? Well, there's two outcomes that we're looking for. We're looking for weight loss, and we're looking to prevent the progression to type 2 diabetes. And I think we've all seen patients who have taken metformin and relate to us that they have stomach aches or GI upset or nausea. So that's a common side effect of the medication. And adults that were taking 2,500 milligrams for 6 months lost about 5.8 kilos compared to the placebo, and they gained 0.8 kilos. So there are some times where where physicians caring for adults will prescribe metformin. But there really aren't studies like these with the same degree of data in children. This is a forest plot looking at the change in BMI with metformin compared to controls. And these are studies in children. And they're grouped by how long they did their follow-up. So the first group of studies is less than 6 months. The second group is exactly 6 months follow-up. The third group is greater than 6 months. And we're looking at this line here that's at 0. Anything to the right of the line favors the control group. Anything to the left of the line favors metformin, because the children in that group did lose weight. So we do see that the majority of the boxes are to the left of the line favoring metformin. But they really didn't lose that much weight. They lost about 1 body mass index point. And so the authors of the study state, while our results show that some obese children and adolescents may benefit from short-term treatment with metformin combined with the lifestyle interventions, these benefits were very modest, not achieving a 5% reduction in the BMI based on mean response. So based on these data, metformin isn't a very good weight loss drug for children. Now, what about preventing progression to type 2 diabetes? So the adults in the Diabetes Prevention Program study at 2.8 years follow-up, the lifestyle group had a 58% reduction in progression to type 2. The metformin group had a 31% relative reduction compared to the placebo group. So for adults, the progression to type 2 does seem to be prevented by metformin. But for children, there are really no studies that specifically address the use of metformin for the prevention of diabetes in teenagers. So the ADA still recommends lifestyle changes and avoiding weight gain for diabetes prevention in adolescents. Now, there are special circumstances. What about patients with polycystic ovarian syndrome? So there are some small short-term studies that demonstrate that metformin can restore menstrual regularity, improve insulin resistance, the hyperandrogenemia and glucose intolerance in obese and non-obese adolescents with PCOS. Metformin may be more beneficial for adolescents with PCOS than it is in adults with this condition, but the duration of treatment has yet to be established. So that is one option where you may consider using metformin. Another one is your patients that are treated with atypical antipsychotics. And there was a study of 12 published studies with a total of 743 patients treated with antipsychotics. And the ones that were on metformin had a significantly better anthropometric and metabolic parameters than placebo. For them, the mean change in weight was about 3.3 kilos. So again, that's another patient population where you may want to consider using metformin. Honestly, what I do relates to this quote here, which I really like a lot. It says, "The art of medicine consists in amusing the patient while nature cures the disease." Honestly, sometimes what we do makes a difference and sometimes it doesn't. And so if I have a family that's really insistent that they want to try some medication for weight loss, then I will give metformin a shot. You just have to keep in mind that it can increase the risk of vitamin B12 deficiency. So you should really check a B12 level in those treated with metformin for greater than 1,000 milligrams a day for a duration for longer than 3 years. Interestingly, metformin does not appear to cause or exacerbate liver injury and is often beneficial in patients with non-alcoholic fatty liver disease. Now, how do I prescribe metformin? I usually start with 500 milligrams extended release with dinner for 1 week, then increase that to 500 milligrams extended release twice daily for a week, then increase that to 1,000 twice daily, but I use 2 of the 500s. Why do I use 2 of the 500s and not just 1,000? Because when you look at the price of the medications, here's the 500 extended release. The average price can be about $89 for a month's supply. When you look at the 1,000 milligram, it goes up to $242 for a month's supply. So a lot of times the insurance companies won't cover the 1,000s. So that's why I prescribe the 500s. Even though it's extended release, why do I prescribe it twice a day? Because I find that a lot of times patients have nausea and upset stomach if they take all 4 pills at one time. So that's why. And then recently, some extended release forms have been recalled because they contain an impurity, NDMA, above the acceptable limit. So it's important to check with the local pharmacy. All right, so back to our patient, Kira. Now, should we do an OGTT? I usually do not do OGTTs. And the reason is because they have a lack of reproducibility. You know, one day you'll do it and the patient will have a high 2-hour glucose value. If you repeat it in a week, it could be normal. They're inconvenient. The patient has to come in fasting. They have to wait for over 2 hours for those results. And they frequently cause symptoms. The solution is so sweet that it can cause some patients to gag or to vomit. And it really doesn't guide your therapy. I mean, if you do it and someone has prediabetes, as we discussed earlier, metformin may not be the best answer for that patient. If you do it and the patient does have type 2 diabetes, you may want to recommend weight loss ideas and have them come back to repeat the test. And so in my opinion, it doesn't really guide your therapy. Should I start metformin? Maybe. That's up to you and the discussion that you have with the family. Should I encourage her to lose weight? Absolutely. So let's kind of take a step back for a second. Talking about prediabetes and diabetes, There's two mindsets. There's a glucocentric approach and then a adipocentric approach. The glucocentric treatment considers diabetes to be the primary problem and obesity a complication. The therapeutic target is the hemoglobin A1C. Glucose control may get worse and more medications may be needed over time. And unfortunately, many of the first-line diabetes drugs usually cause weight gain. In the adipocentric treatment philosophy, obesity is the chronic disease, and prediabetes or type 2 diabetes is a comorbidity. The therapeutic target is weight loss reduction, and the A1C improves in parallel. So just take a moment to reflect on how you view treatment of diabetes and type 2 diabetes. I know my colleagues and myself, a lot of times we get caught in the glucocentric approach just because that's the data that we have available. But consider whether the adipocentric treatment approach could be preferred. And so in that approach, we're treating the obesity. So what are some tools that we have to treat obesity? Well, unfortunately, youth with severe obesity have limited options. Orlistat, brand names are Xenical or Ally, it's the only FDA-approved medication for long-term management of obesity that can be prescribed to adolescents 12 years of age and older. Orlistat works by reducing the absorption of approximately 1/3 of the fatty acids consumed by food through inhibiting gastrointestinal lipases. So here's our GI tract here, and here's the fat coming through. Normally, these little Pac-Man lipases will digest the fat and it's absorbed, but in the presence of orlistat, that blocks the lipases and it's not absorbed through the duodenal mucosa. So what happens to all that fat? It comes out in the stool. And so in one major trial, children were randomized to either orlistat 3 times a day, it's a drug you have to take 3 times a day, or placebo over a year. And by the end of the study, the BMI had decreased by 0.55 in orlistat and increased by 0.31 in placebo. But unfortunately, the side effects were astronomical. And the ones that were taking the orlistat, complained of fecal urgency, incontinence, fatty oily stools, and these were mild to moderate in intensity. So I like this little cartoon in here. 4 out of 5 people suffer from diarrhea. So does that mean 1 in 5 people actually enjoy it? So I don't know if anyone really enjoys taking orlistat, but I will say it's not commonly prescribed medication in the realm of childhood obesity, just because the side effects are so severe and impact quality of life. So what are we going to do? That's the only drug that's approved. Well, I do have some success stories from clinic I'd like to share with you, and we'll talk about the different tools that we've used in our program. So this is one success story. Again, I will orient you. This is a male patient. Here's his age. So he was 15 when I saw him. And here's his weight in pounds. And he was about 240 pounds. And at that point, he was diagnosed with type 2 diabetes with an A1C of 8.6%. And I said, buddy, we have to make some changes. We have to start metformin. And so he agreed to start the metformin. And he said, Doc, I will make the changes that you told me to. So 3 months later, he had lost 55 pounds and his A1C went down to 5.9. And then 6 months later, he had lost 66 pounds and his A1C went down to 5.8 to 5.5, sorry. At that point, he's off metformin and he's just making the changes that we talked about. So what was it that worked for him in our toolbox? Believe it or not, it was dietary modifications and increased activity. And I said, how often do you go to the gym? He says, every day. And I said, when did you start? He said, the day I left your office, doc. So it can work. And so research suggests that behavioral treatment can be successful for severely obese children, but not as successful for severely obese adolescents. So he was the exception to the rule. Unfortunately, intensive behavioral weight loss interventions have smaller efficacy for decreasing BMI as the weight classification increases. So it's more likely to work in our patients with class 1 obesity than the ones with severe class 3 obesity. This is an expert committee recommendation by Dr. Barlow and the rest of the committee that discusses or describes treating obesity with different stages. Stage 1 is prevention plus. It can take place in the primary care office. Stage 2 is a structured weight management program. It can also take place in the primary care office, but you really need the involvement of a registered dietitian, and you need frequent visits with the patient and the family. Stage 3 is a more comprehensive multidisciplinary intervention, and that's what our COACH program is. It's a multidisciplinary team with a psychologist, a registered dietitian, social worker, and we really provide an interdisciplinary approach to the child with obesity. And then stage 4 is tertiary care, involving medications or weight loss surgery. And so just to let you know what we have at Children's Health, we do encourage the primary care provider to assess the weight and the BMI severity and to screen for the weight-related conditions, including high blood pressure, high cholesterol, fatty liver, diabetes, or sleep apnea. We do have a robust nutrition clinic weight management program where the family's offered 4 sessions over 4 to 8 months that are one-on-one to address healthy food choices and adapting a healthy lifestyle. We have the Get Up and Go program, which is a partnership with the YMCA. It's free. It's a 10-week weight management program for children and their parents to attend once a week. And they meet with the registered dietitian. They take field trips to the grocery stores, which is actually a pretty fun family-based approach to healthier eating and increased physical activity. Then there's our COACH program, which we discussed earlier, which is an interdisciplinary clinic for children with severe obesity or complications from obesity. We also have a bariatric surgery program. And we have a wonderful bariatric surgeon, Dr. Qureshi, and over the past 4.5 years, we have successfully operated on about 75 patients. Now, we were talking about the lifestyle-based treatment before, and so unfortunately, studies suggest that for it to be successful, patients and families need at least 26 hours of contact time to reduce excess weight. And I don't know what it's like in your clinic. I know for our clinic, it's hard to get patients to come back every 3 months. So 26 hours is really not feasible for a lot of our families. So if we try lifestyle and that doesn't work, what are the next options? Here's success story number 2. So this is a 12-year-old male I started seeing here. His weight was about 231. We tried lifestyle for a few months and it continued to increase up to about 260. And then I tried an intervention and it decreased and it was stable. And then at this point, he said, "Oh, doc, I don't think this intervention's working anymore. I'm just going to stop it." And he stopped taking it, and then it continued to rise again. So what was that intervention that we used from our toolbox? Phentermine. So just a reminder, phentermine is an adrenergic agonist. It increases the release of norepinephrine from the hypothalamus. This reduces the appetite and also increases the resting energy expenditure. Phentermine is the most widely prescribed obesity medication in adults, but there's limited data in the pediatric population. It's approved for ages greater than 16. And in adults, it's been associated with a greater percent change in BMI compared to standard of care. So at 1 month, the adults lost about 1.6%. 3 months, they lost close to 3%. In 6 months, they lost 4% of their BMI. And there's variable responsiveness amongst participants. Right, success story number 3. This time we're using the BMI percent curves. This is a 16-year-old male with trisomy 21 and pretty significant developmental delay. So you'll see these first few points. We tried lifestyle modifications. He continued to gain weight. Then we tried a tool from our toolbox, and he lost weight. And the parents were very thankful. So what was that tool? That was topiramate. So topiramate, no one really understands the mechanism for topiramate's weight loss effects. Honestly, it was just noted as a side effect for patients that were on it for other reasons. But a retrospective chart review from pediatric patients treated with lifestyle management plus topiramate for 3 months. They looked at 28 patients. The mean age was 15. And they saw that within 6 months, the percent change in the BMI was close to 5%. So again, that's similar to what we saw earlier with the phentermine. Just a reminder, the phentermine for weight loss in children less than 16 is off-label. Topiramate for weight loss in children is off-label as well. All right, but there's a new kid on the block. So this was published a few months ago in the New England Journal of Medicine. This is a randomized control trial of liraglutide for adolescents with obesity. Just a reminder, liraglutide is a GLP-1 receptor agonist. It works on many different organs. It works on the brain by reducing appetite. It works at the level of the stomach by reducing gastric emptying. It works in the pancreas by increasing insulin biosynthesis and beta cell proliferation and decreasing beta cell apoptosis. It works at the muscle by increasing insulin sensitivity. It works on the liver by decreasing glucose production. And it's cardioprotective on the heart. So really a great drug. It goes by different names. Victoza is what's used for diabetes. Saxenda is what's used for weight loss in adults. There's an extended version by Ada and by Durion. There's also a dulaglutide, which is Trulicity, and semaglutide, which is Ozempic. These are injections. So in this study was a randomized double-blind trial, which consisted of a 56-week treatment period and 26-week follow-up off of the medication. They enrolled adolescents 12 to less than 18 with obesity and a poor response to lifestyle therapy. And they were assigned to receive either the liraglutide or placebo subcutaneously once daily, in addition to lifestyle therapy. And in total, at the end, they had 125 participants in the liraglutide group and 126 in the placebo. So this paper actually had quite a few figures, but these were the two that I think were the most important to me. This is the absolute change in body weight. So on the y-axis, we have change in baseline by kilogram. The x-axis is weeks since randomization. The blue line are the patients treated with liraglutide. The black line, patients treated with placebo. And then at week 56, everyone was off of the medication. So what we see here is a greater reduction was observed with the liraglutide group than with placebo for body weight. The estimated difference was about 4.5 kilograms between the two groups. So it works. It is effective for weight loss. But what was more striking to me was the differences in weight loss for each participant. So looking at this graph on the right, each little line is a different participant in the study, and the y-axis is change in baseline. So of course here's 0, suggesting there's no change. And so there's many, or there are a few patients that had a greater than 10% reduction in the BMI, about 26%. Then the yellow line is the greater than 5% reduction in the BMI, and about 43%. But there are also quite a few patients here on the right-hand side that gained weight on the medication. So there really is variability in response to this treatment, like it is for almost all treatments for weight loss. So part of this could be explained by the fact that more participants in the liraglutide group had significant GI adverse events, 65% in the liraglutide group versus 36% in the placebo group. And those adverse events oftentimes would lead to discontinuation of the study drug. So it could be that the participants that did not lose weight perhaps just weren't adherent to the medication. So just to summarize, this is a list of the treatments that are available. Metformin we discussed earlier, not significant weight loss, not FDA approved for adults or children for weight loss. Orlistat, 3% weight loss, approved in 1999 for children over the age of 12. Liraglutide, the GLP-1 analog, you can get about 6 to 7% weight loss. FDA approved in adults, not yet FDA approved for children. Contrave is a combination of bupropion and naltrexone. You can get about 6% weight loss. It's approved for adults. I've never prescribed it for children. Belviq was recently taken off the market. And then there's a combination phentermine and topiramate called Qsymia. That's the brand name. And that's probably the most bang for the buck, about 10% weight loss. Again, FDA approved for adults, not for children. Now there's one last tool in our toolbox. Oh, but before we get to it, just a reminder that responses to medications really are variable, and there's a lot of genetics and pathophysiology with regards to weight gain and appetite and satiety that we don't understand yet. So this is a slide looking at the results in adults. The top 3 bars are looking at high-intensity lifestyle intervention, and the bottom bars are looking at medication. And then on the x-axis are the percentage of participants who had either greater than 10% or 5% weight loss. And there's no magic bullet, there's no drug or lifestyle intervention that works for everybody. So these responses really are variable. Now that last tool in our toolbox, this is our last success story. This was a young lady. When she came to me, the weight was close to about 300 pounds. Then we did our intervention, and about a year to a year and a half later, she's down to sorry, I'm trying to do this without my glasses on. She's down to about 180. So what was that intervention? That was sleeve gastrectomy. And so this is a panel from the weight loss and health status. It was a paper from the Teen Labs study published a few years ago in the New England Journal, looking at the long-term outcomes up to 3 years from patients who had had either gastric bypass or sleeve. And again, these are all teenagers. And what we see is a pretty significant decrease in weight from baseline within the first year. And then it tends to plateau and maybe a little bit increase out to 3 years. And there's not much different between the gastric sleeve or the gastric bypass. And so at Children's, we are exclusively doing the gastric sleeve procedure. And also in this paper, they had great data on the outcomes of the comorbidities. And so for type 2 diabetes, let's look at these totals. So the prevalence of type 2 diabetes was 29 out of 225 patients, or 13%. And then at 3 years, the prevalence of remission, so it's a little bit flipped, was 19 out of 20 patients, or 95%. So at 3 years, only one of those patients that we have the data on for the follow-up still had type 2 diabetes. The other patients were in remission. So it's a successful procedure in teenagers for weight loss and for a resolution of comorbidities. These data are from our surgeon, Dr. Qureshi. Each line here is a unique patient, and then there's the weight on the x-axis. And so these are the data for the patients that we've done so far within the first 2 months. And you'll see that everyone has lost weight after the procedure for 2 months. Our clinic struggles with loss to follow-up past that time period, which I think is pretty common in other clinics that treat patients with severe obesity with surgery as well. There's changes in insurance. Kids just don't want to come back to clinic for follow-up. So that's a pretty tough issue for us right now. So these are my last 3 slides, but I just want to remind us that, caring for families and children with severe obesity really is an honor. And it provides us the opportunity as healthcare providers to deliver family-focused, compassionate care to pediatric patients living with obesity, and really gives us a chance to improve their health and quality of life. And this was a policy statement drafted by the AAP in 2017. And it really describes the stigma experienced by children and teenagers with obesity. Unfortunately, peers, educators, and even parents can be a source of weight stigma. Even popular children's television shows reinforce weight through stereotypical portrayal of characters who appear to have larger body sizes. And even us, healthcare professionals, studies show that healthcare professionals view patients with obesity as being lazy, lacking self-control, and being less intelligent. And unfortunately, there are numerous physical, psychological, and social consequences of these stigma that these children experience, including worsening weight gain. So it can really just make the problem worse. And so this policy statement recommends that pediatric healthcare professionals should model behavior with colleagues that is supportive and non-biased towards children and families with obesity, use appropriate and non-stigmatizing language in communication with families about weight. So preferred terms are neutral terms like weight and body mass index. Those are preferred over terms like obese, fat, and weight problem. And always use first or people first language and refer to a patient as a child with obesity as opposed to an obese child. And really, I encourage all of us to be an advocate against weight stigma. Thank you for your time.
The objectives today for the talk, so we'll be talking about characteristics of children and adolescents with type 2 diabetes. We're going to identify who needs to be screened for prediabetes and type 2 diabetes, and I'm sure some of this was talked about before in the previous talk with Dr. Gupta. We'll also talk about diagnostic criteria for diabetes and the classification of type 2 diabetes. And the last thing we'll talk about at the very end of the talk will be identifying current treatment goals and options for children and adolescents with type 2 diabetes. So type 2 diabetes, so this is something that as I said, we're seeing more and more in our adolescent population, and sometimes even before the teenage years, we're seeing some patients develop glucose problems due to insulin resistance. But we believe, so of course, the underlying problem in our patients is a development of insulin resistance, but at some point they also develop decreased insulin secretion, and this leads to a glucose decompensation leading to hyperglycemia. In type 2 diabetes as compared to type 1 diabetes, there's no evidence of an autoimmune process, and we'll talk about this a little bit later when we talk about the diagnosis. And these patients, there's a strong genetic, environmental, and metabolic factors that contribute to the eventual decrease in insulin secretion. So in the United States, estimates are about 5,000 cases per year, although sometimes it seems like this may be increasing. In individuals with prediabetes, and in our clinics, probably in our endocrinology clinic and also in the general pediatric clinics as well, we're following a lot of patients with prediabetes, and in these patients, persistent weight gain is one of the big predictors of progression from prediabetes to diabetes. And whenever we screen these patients for insulin resistance, prediabetes, diabetes, we also screen for other insulin resistance abnormalities, because a good way to think about this is we try to evaluate all of the risk factors for future cardiovascular disease. So not only glucose problems, but also dyslipidemia, hypertension, fatty liver disease, polycystic ovarian syndrome in our females. So we believe, so in our patients, of course, one of the big things that we talk about in clinic and, is trying to modify lifestyle habits, because for our patients, there is this weight gain that helps lead to these problems. But these patients also have a genetic risk, so they usually come from families with very strong family histories of type 2 diabetes. And of course, there's also the environment as well that contributes to the weight gain as well too. Whenever we talk about weight gain, it's not only total mass, but it's usually we think of this insulin resistance coming from visceral fat accumulation that leads to the insulin resistance, and from here the insulin resistance abnormalities that in the general pediatric clinics and in our multi-specialty clinic, we want to screen for these problems as these patients get older. Now, these insulin resistance abnormalities, so of course pretty much all of this talk will be talking about the glucose abnormalities, from impaired glucose tolerance to the development of type 2 diabetes. But also it's very important to screen for the lipid abnormalities. And the classic pattern that you see in the insulin resistance syndromes are increased triglycerides with low good cholesterol, but also there could be increases in bad cholesterol fractions like LDL and non-HDL. These patients also have increased coagulation factors. They can have hemodynamic changes that help contribute to higher blood pressures. They also have chronic inflammation, increased hepatic fat deposition, and in our females, they're at increased risk for PCOS. Now, what are the characteristics of children and adolescents with type 2 diabetes? So usually they tend to be in the teenage age group. So the median age of diagnosis is at 13 and a half years, but I think we all have patients who have been diagnosed younger. I think the youngest we have in our clinic is, I think we had one 8 or 9 years of age. a child who developed diabetes without any evidence of autoimmune markers. Type 2 diabetes is rare prior to puberty. Pretty much in the pediatric population, most have a BMI in the overweight category or greater. And patients predominantly come from lower socioeconomic and education populations. And there's a predominance for females to develop type 2 diabetes. Now, presentation may be asymptomatic to patients can also present with ketoacidosis. I remember when we were in fellowship, which, I don't know, what was that, 12, 13 years ago or more, you know, it's very rare to see a patient with type 2 diabetes presenting ketoacidosis, but nowadays it's more common. As I stated before, greater than 75% of patients come from families with a strong family history of type 2 diabetes, and there's a greater prevalence of type 2 diabetes in certain races and ethnicities. Now, who to screen? There's different guidelines out there. So one of the guidelines talks about in anyone who's overweight plus any 2 risk factors, so a first or second degree relative with type 2 diabetes, if the individual belongs to a high risk race or ethnic group, and if on physical exam or history there's signs of insulin resistance such as acanthosis nigricans, concerns about periods, high blood pressure, lipid abnormalities. The guideline that I got these recommendations from stated that we should do this every 2 years starting at age 10, but I know we're doing screening in much younger patients, and we're already picking up these insulin resistance abnormalities like dyslipidemia, high blood pressure, elevated liver enzymes in patients much younger than 10. So how do you diagnose diabetes? So there's different ways that you can. So of course you can use a fasting plasma glucose persistently above 126. Glucose tolerance test can also be used. So if there's a 2-hour glucose greater than or equal to 200. Also, if a patient has a random glucose above 200 plus symptoms of diabetes like polyuria, polydipsia, unexplained weight loss, and the hemoglobin A1C can also be used. So if there's a level greater than 6.5%. Now you always have to be careful with which tests you use, because some of these tests, you know, can change from day to day. So especially the fasting glucose and the glucose tolerance test, it's often recommended to repeat this on a different day to confirm diagnosis. But it gets tough for some of our patients, especially who are in the pre-diabetic range. They could be in the pre-diabetic, close to the diabetic range. And it's, even for us, very difficult at what point do you pull the trigger to say, okay, I'm going to give you the official diagnosis of type 2 diabetes. So it can be pretty challenging. Now, of course, whenever we see our patients, you know, of course, either in the clinic or in the hospital, if we admit them for diabetes, we always have to try and determine whether it's type 1, type 2. And this would seem like an easy task, but it's often difficult, and I think it's getting more and more difficult. Of course, when we first see a patient, there's always the history and physical exam findings. And of course, a lot of our patients who are overweight, or if their BMI is in the obese category, plus there's signs of insulin resistance like acanthosis, will lean towards type 2 diabetes, but we'll also need to confirm this with the type 1 diabetic antibody titers. But there's a lot of reasons why it's getting a lot tougher to differentiate between type 1 and type 2 diabetes. So obesity is not only occurring in our type 2 diabetic population, but also type 1 diabetes. So obesity is increasing in the general population. Like I said before, type 2 diabetics, before we didn't think could come in with diabetic ketoacidosis, but nowadays we're seeing more and more type 2 diabetics presenting in DKA. Given the fact that type 2 diabetes is so common in the general population, it reduces the specificity of a positive family history. And, you know, the other thing is insulin resistance. You can see insulin resistance in type 1 diabetics, just like type 2 diabetics as well. So it's becoming more and more challenging, and even in our clinic, oftentimes after admitting a patient to the hospital, afterwards in the clinic, we'll follow this patient for the antibody titers to see if there's any sign of autoimmunity that's causing the diabetes. But it's getting really tough, and pretty frequently I'm wrong at what I guess initially. So it is important, even if you feel like a patient has type 2 diabetes, to order and obtain the type 1 diabetic antibody titers. There are studies that show that up to 15 to 40% of youths and adults with type 2 diabetes actually have type 1 diabetic antibody titers. And so it should be, these antibody titers should be checked in any individual with new onset diabetes. There is, it gets difficult also how to treat these patients, because we have some patients who phenotypically look like type 2 diabetes but have an autoimmune component. So there's a lot of similarities in the treatment between both type 1 and type 2 diabetes, but there are things that are distinct for one group over the other. So often it is a challenge, if someone looks like a type 2 but has autoimmunity, okay, do we treat them more like type 2, type 1? And often I think the important thing is to try to not have one specific plan for everybody, but you might have to kind of mold a plan for a given individual and family depending on how they look phenotypically, but also what their labs show as well. So the goals of management, I'm doing on time here. So the goals of management, of course, number one for our diabetics, of course, you want to maintain a normal glucoses, or, when I say normal glucoses, or glucoses within kind of what are called diabetic targets. And these are targets that we set, and studies have shown over time that if patients can maintain glucoses in these ranges and maintain these hemoglobin A1C levels, that the risk of diabetic complications like nephropathy, neuropathy, retinopathy, that those risks go down dramatically. For our patients as well, we also try to kind of encourage weight loss, but spend a lot of time with talking on how to improve lifestyle habits from diet and physical activity. And the most important thing, well, I don't know if most important, but also very important, is not to forget about these comorbid conditions. So the dyslipidemia, hypertension, nephropathy, fatty liver disease, but also psychologic stressors that our patients frequently have, not only with type 2 diabetes, but with any chronic medical condition. So it's important to screen for these. And there's a big push in type 2 diabetes in adults too, to kind of stress, to patients and in the care to not only focus on the glucoses, but also to treat this more globally as a cardiovascular disease, and to decrease, all of the risk factors for cardiovascular disease that these patients will likely develop in the course of their disease. So management, lifestyle modifications, huge. Pharmacotherapy, we'll be talking about each one of these topics in a little bit. I just added this, probably last week, the bariatric surgery, and I know Dr. Gupta talked about the bariatric surgery as well too, but there are some studies that are comparing cohorts of adolescents with adults on bariatric surgery and what it's doing to their diabetes. So dietary management, of course, these are just kind of broad things that we talk about. Of course, it's always important to treat every patient and family individually and see what their needs are, what their habits are. But of course, we try to encourage elimination of sugared beverages, try to decrease the amount of processed foods, increase more natural foods, decrease concentrated sweets and fast foods. Frequently we'll talk about, I think we do this more in pediatrics than in the adult world, but we'll have carbohydrate counting and limiting of carbohydrates per meal. And as much as you can, changing family behaviors as a whole, because you can never ask the child to do this on his own. Now, certain recommendations for exercise management: moderate to vigorous exercise for at least 60 minutes daily, limiting screen time, try to increase physical activity as a family as a whole. One thing that I like to talk about, because one of the hard things is to try to motivate families and individuals to kind of get up and move. But also it's hard to be objective on how much exercise is enough. One of the tools that I use in the clinic, and everyone has a cell phone, but these phones will have those health apps that will allow patients to count steps, so trying to be objective about it and encourage, 10,000 steps a day. Try to make it fun where they can create competitions with family members, friends. But it is definitely a challenge of how to kind of effectively educate families, to motivate them to do what needs to be done. But also you should never forget as well that a lot of our patients are carrying a lot more weight on them compared to peers. So, you have to usually start slowly and kind of give very good recommendations on how to increase over time. We don't have an exercise physiologist in our group, but I think that's something that would be very beneficial in any kind of weight management type 2 diabetes group, because we have to give patients and families, realistic goals and how to kind of increase their physical activity. Because whenever you give recommendations, you want success, but it's kind of hard if you say, hey, you got to exercise an hour a day and they're not in enough shape, and then they'll get frustrated and it's a vicious cycle. So see where you can to kind of increase the likelihood of attaining goals so that, they can feel good about themselves and keep on moving forward. Now, the Today study, I'll be referring a lot to the Today study in subsequent slides. The Today study is a study that looked at type 2 diabetes in adolescents. And the main objective of the Today study was to look at time to failure of treatment in regards to glucose. So it was looking at different type 2 diabetic treatment options, and they were looking for, okay, how long does it take for someone to fail this treatment option, and what they defined as failure is a hemoglobin A1C greater than 8% for more than 6 months, or if someone was on insulin, if they were unable to come off the insulin within 3 months after glucose decompensation. And there are three groups. So one was metformin alone. The second was metformin plus rosiglitazone, and then the third group was metformin plus intensive lifestyle changes or recommendations. But they showed in these three groups that the time to failure over kind of like 3 to 4 years was very big in each group. So close to 50% of each group developed glycemic dyscontrol after 3 to 4 years, indicating that using just 1 and 2 medications may not be enough in these patients to maintain normal glucose levels over time. So we'll be talking a lot about the Today study, but that was kind of the big picture of the Today study. Now within this, one of the things they looked at was weight loss, and they were looking within the group that had intensive lifestyle education. And they showed that intensive lifestyle added to metformin did not decrease the risk for loss of glycemic control. And in the Today study, so they said 31% of the metformin plus lifestyle group decreased that initial percent overweight by greater than 7% compared to the other groups. However, one surprising thing was that this decrease in percent overweight disappeared between treatment groups at 2 years. So it also demonstrates that, a lot of our recommendations and treatments, it's hard to maintain good glucose control and kind of weight management for long term. Glucose monitoring, so these are kind of either finger pokes or now using continuous glucose monitors to monitor glucoses. There aren't any studies that show that in type 2 diabetes this is necessary, so there's no evidence of impact on glucose control. Of course, if we do have a patient who's taking insulin and requires insulin, we recommend frequent glucose monitoring, especially to monitor for low blood sugar levels. But in those who aren't on insulin, the studies are out, they don't really show improvement in glucose control. I often still recommend periodic checking just to make sure that someone's glucoses are not becoming more out of control as to need, an addition of more medication or the addition of insulin. But the frequency of glucose checking should be individualized, and it depends on the degree of glycemic control and whether a patient is on insulin or not. You can always check fasting and postprandial glucose levels. And during times of illness, that you might want to increase the frequency of glucose monitoring. Now, pharmacotherapy, so this is something that has changed recently over the past year. So in the summer of 2019, Victoza, which is a GLP-1 agonist, and I think this is the same as liraglutide, which Dr. Gupta talked about in her previous talk, but GLP-1 was added to the list of approved drugs for type 2 diabetes in children. But prior to that, the only FDA-approved drugs for type 2 diabetes in children was insulin and metformin. But like I said in the Today study, there's already studies that are showing that long-term management of glucose in these patients is very difficult, and often just one medication may not hold a patient for very long. So having more options to add on to metformin and or insulin would be very helpful for these patients. In the adult world, so I also included some other classes of drugs, that are used for adults, but they can be used in children. We don't use them as often. Now, pharmacotherapy, of course, and there's probably different guidelines out there on how to do this. And also, it's also physician dependent as well too. But in general, for endocrinologists, if someone has very, very high sugars at presentation, or, if they're already diagnosed and develop severe decompensation of glucose, like for example, glucoses are persistently above 200, 300, having symptoms. So we'll often add insulin. But if the person's hemoglobin A1C initially is below 9%, and that number may change from group to group, but most of the time we feel comfortable starting with one drug, metformin, increasing a small dose and ramping the dose up over a 4-week period, but also very important, going over lifestyle recommendations and changes, because oftentimes if the patient can, really decrease the carbohydrate intake, the sugar intake, and increase physical activity, oftentimes their glucose levels can kind of improve pretty dramatically over kind of the first few weeks after diagnosis. But like I said, if initially the A1C is greater than 9%, patient has a lot of symptoms, glucose is 200s, 300s, we'll often start insulin. And oftentimes you can start with just a basal insulin, like a 24-hour insulin like Lantus or Basaglar, on top of metformin. And after a while, if that's not enough, then adding fast-acting insulin for meal times or for glucose levels as well. But whenever we do start insulin, it is kind of a big push for a lot of us to try to wean the insulin off as quickly as possible. Even though insulin is very good at helping to probably control those blood sugar levels pretty quickly, one of the things that insulin does is it is a weight promoting agent, so, if we can control the blood sugars and get someone off insulin as quickly as possible and safely, that would be ideal. So a little bit about metformin. It is an AMP kinase. Studies show that it may lower the hemoglobin A1C by 1 to 2%. That's in the past why often, if someone's hemoglobin A1C is really high, we usually add insulin because we feel like metformin by itself may not do it by itself. But that's something that's kind of out there. There are some guidelines out there too. I think the AAP recently put out some guidelines. I haven't looked at them, but I heard about them, where they recommended even higher hemoglobin A1Cs, just doing metformin and lifestyle changes before jumping into insulin so quickly. Metformin is a very safe drug. The most common side effect is kind of abdominal discomfort, diarrhea, nausea, abdominal pain. That's why we start at a very small dose and increase it slowly over a 3 to 4 week period to a maximum dose of 1,000 milligrams twice daily. Insulin, these are different insulins that we use, so there's the basal 24-hour insulins, like Lantus and Basaglar. Levemir, we also can use, doesn't last as long for 24 hours. And NPH is a drug that we still occasionally use, but not as much. I remember we used a lot more when I was a fellow, but we don't use as much. And then there's fast-acting insulin for meal times and for corrections, to be able to bring down glucose levels. The two most common ones are Novolog and Humalog. And the side effects, of course, with insulin is causing hypoglycemia. But in our type 2 diabetics, like I mentioned before, it is also a weight-promoting agent. So sometimes it gets difficult if someone can't come off insulin, plus they're eating still a decent amount of carbohydrates. It's very difficult to lose weight and still can have very rapid weight gain over time. Now, like I said, so the pharmacotherapy, so 90%, so there are some studies that show, that metformin alone is a good drug. So 90% of type 2 diabetics in children can be, or type 2 diabetes in children can be managed with metformin alone. But other studies, like the Today study, like we've talked about, show that, glucose decompensation, after a few years on just metformin alone is very common. So the Today study demonstrated loss of glycemic control is 3 to 4-fold higher in youth with type 2 diabetes as compared with adults. So that was something startling that came out of that study. And, one of the things is the hemoglobin A1C after a short period of metformin monotherapy may be a good predictor of metformin monotherapy failure and a need for additional future diabetic pharmacotherapy. So in these patients initially who have glucose decompensation, and if their glucoses are well controlled and their hemoglobin A1Cs come down nicely on metformin and lifestyle changes, we feel like that's probably a good indicator that maybe we can manage them on metformin alone for a while. But with time, those patients where it's difficult to normalize the glucoses and bring down the hemoglobin A1C, we'll probably need early on to add in more treatment options. And this is where it was kind of exciting that Victoza, which is a GLP-1 agonist, was approved a year ago. And GLP-1, so what GLP-1 is a glucagon-like peptide, and your body actually produces GLP-1. It is produced by the L cells in the small intestines in response to food. But whenever you eat, your body releases the GLP-1 and it increases insulin secretion, helps suppress glucagon. So these are two things that, of course, help maintain normal glucose levels, but also this hormone, and then the GLP-1 agonists, they also help slow down gastric emptying and stimulate satiety. So these also can have added benefits for weight loss. There's a lot of different types or different GLP-1 agonists. Some are given twice a day, some daily, some weekly. Trials have shown weight loss with this group of medications and decreases in hemoglobin A1C. The numbers aren't great, but it does help reduce hemoglobin A1C by 0.5 to 0.8%. The most common side effect, which I know Dr. Gupta talked about, was GI symptoms, just kind of like metformin, upset stomach, abdominal pain, nausea. And sometimes that limits the ability to increase the medication dose over time. Now, the liraglutide, also known as Victoza, so this is a study that was published a year ago in the New England Journal of Medicine, and I'm sorry I didn't put the study on the bottom of the slide, but if anyone needs to know the name of the study, I can later send the article. But this is a study that looked at the use of Victoza or liraglutide in type 2 diabetics. So these are patients aged 10 to 17. So this drug is approved for anyone older than 10 and with type 2 diabetes. But this study, so it randomized patients into the liraglutide group and then a placebo group. And it was a 26-week double-blind period followed by a 26-week open label extension period. There's a total of 135 patients. And, there are a lot of the main thing that they looked at was change in hemoglobin A1C, but they looked at other secondary markers as well too, like changes in BMI Z-score. The two that I wanted to highlight was a change in hemoglobin A1C and also the change in weight as well. And for both of these groups, there is some change and some positive effect of liraglutide as compared to the placebo group in decreasing the hemoglobin A1C and decreasing the weight in patients. The numbers were pretty small though, and one of the limitations that the researchers stated, and I believe Dr. Gupta also talked about this, is in these studies. In this study specifically, they tried to ramp up the liraglutide pretty rapidly every week based on glucose levels and side effects. But given the rapid ramp up, very few patients were able to reach the maximum dose of 1.8 milligrams. So you usually start at 0.6 milligrams, and then you can go up every few weeks by 0.6 to a maximum dose of 1.8. But it is interesting, so this study did show that it is well tolerated, it is safe, and there are some positive effects on the hemoglobin A1C and change in weight. Even though the numbers weren't great, it is another medication that we can use, and it's important to have something in our arsenal, especially if metformin is not cutting it by itself. There are other drugs as well too. So there's a DPP-4 inhibitor. These we don't use as much in pediatric patients, but the DPP-4 is an enzyme that breaks down GLP-1 in the body. So a DPP-4 inhibitor, so this is given orally, will block that enzyme. So this medication will increase GLP-1 levels in the body. So it kind of works like a GLP-1 agonist, but one thing, this group of drugs does not have the weight loss. It's also associated with the GLP-1 agonists. And then another drug that if we were to use a class of drugs in our pediatric patients, often it'll be the sulfonylureas. These drugs also have been shown to decrease the hemoglobin A1C, but no greater efficacy than metformin by itself. But in this class of drugs compared to metformin, you do tend to have more weight gain and increased risk for hypoglycemia as well. So the goals of management, so of course and I'm sorry, I'm kind of going through this pretty quickly and there's a lot to cover. I just want to make sure I finish on time. But pretty much I went through kind of the first three pretty quickly, so the goals of management for type 2 diabetics is, of course, is to try to normalize those glucoses, kind of weight loss, change in lifestyle habits. But like I stated earlier in the talk, it's very important not to forget about these other cardiovascular disease risk factors that these patients can develop and actually do already have at the time of diagnosis that can increase their risk of diabetic complications, cardiovascular disease. And in type 2 diabetics, you often see the development of these medical problems at a much younger age than type 1 diabetics. So blood pressure, so hypertension in the Today study was present in 11.6% of the patients. And by the end of the study, this increased by 33.8%. Males have an increased risk of incidence of high blood pressure. We check, of course, everyone checks blood pressure at each visit, and it should be normalized for age, sex, and height. And initially, if someone has elevated blood pressures above the 95th percentile, we start with lifestyle changes, but if it's persistent after 6 months, starting an ACE inhibitor would be a good idea. Nephropathy, in the Today study, microalbuminuria was present in 6.3% of the patients with type 2 diabetes, and by 36 months, it had increased to 16.6%. Factors involved with the development and the progression of microalbuminuria include how long someone has had diabetes, the hemoglobin A1C, so how good is their control over time, and their diastolic blood pressure over time. The microalbuminuria we usually check initially and then annually. This is a little bit different than type 1 diabetics. Type 1 diabetics we often don't check right off the bat, but given how prevalent it is in our type 2 diabetics, we check it right off the bat and annually. If it's abnormal, we usually repeat it a few times before considering starting an ACE inhibitor. Usually in our clinic, in our medical center, if it's persistent, we'll send to the nephrologist, kind of further evaluate and see if they would recommend an ACE inhibitor. But you also, microalbuminuria, it is a difficult thing to diagnose because there are some other things that can cause the protein to be increased in the urine. If the patient is very physically active, smoking, the menstruation can also affect it, and orthostasis. Dyslipidemia, so here at Cook's, we don't have a obesity specific clinic, but we do have a dyslipidemia clinic. It's known as the REACH clinic. So in this clinic, of course, we see patients with primary dyslipidemias like familial hypercholesterolemia, FCS, but also in our clinic, we also see type 2 diabetics, kids with metabolic syndrome, because they do have a pattern of atherogenic lipids, that can increase their risk of a heart attack at a young age and the development of cardiovascular disease at a young age. But in our type 2 diabetics, we check the lipid panel soon after diagnosis, and then we check it annually. Goals, of course, we're pretty strict in our clinic too, where we kind of want to keep these patients LDLs. And another one that I didn't put there's another one called non-HDL, but these are the two bad cholesterol fractions, so if someone's even running a little bit high, we kind of pull the trigger pretty quickly to start statin therapy to help bring it down. These patients also can have problems with triglycerides, and frequently will have problems with triglycerides. Often if it's below kind of 400 to 500, we might just recommend lifestyle recommendations to improve the triglycerides. But as the triglycerides increase, then we might recommend starting like a fenofibrate. So, okay. So like I said, initially we'll, if the LDL is above goal, we'll try to recommend, diet changes, exercise, physical activity changes. And then if the LDL, a lot of recommendations will say if the LDL is above 130 persistently, then consider starting statin. But in our clinic, usually we'll start it even if it's above 100, for example. And for triglycerides, if levels get persistently above 400 to 600, adding a fenofibrate to the medications would be a good idea. Now the Today study, so even though the primary goal of the Today study was to look at loss of glycemic control, it also did look at other comorbid conditions such as the development of cardiovascular disease risk factors and microvascular changes in patients. And these studies showed that, that the complications and comorbidities in type 2 diabetics and adults is very similar, but they appear to be occurring more rapidly in our type 2 diabetics, in our teenagers, in our pediatric population. So it's this further illustrates that we have to be very aggressive, not only in controlling and managing the type 2 diabetes, but also these cardiovascular disease risk factors, okay? And these are some of the figures that I already kind of talked about a little bit, the presence of these cardiovascular disease risk factors at the beginning and at the end of the study. And type 2 diabetic youth compared to type 1 diabetic youth have increased mortality after a shorter disease duration and had more cardiovascular deaths. So there are studies that show that our type 2 diabetics are this disease process is very aggressive and very rapidly progressing. And I think it's not only because we're dealing with the glucose problems, but we're also dealing with all of the other weight-related risk factors, like hypertension, dyslipidemia. And one of the last things I do want to talk about is bariatric surgery. Dr. Gupta talked about it, but this is a study that was also in the New England Journal of Medicine that looked at two cohorts. So one cohort was teenagers, the second one was in adults, and they both groups had type 2 diabetes. And they evaluated the Roux-en-Y gastric bypass surgery on health effects in these teenagers and adults, and they followed them for 5 years. There was no difference, so there was good percent weight change and weight loss in both groups. So there was no significant change in weight between the two groups. But one thing they did see in the adolescents compared to the adults at year 5, the adolescents were more likely to have remission of type 2 diabetes and resolution of their hypertension. And by 5 years out, pretty much all of the adolescents were off all diabetic medications. So I think it's something that we're still, as a profession, we're still kind of studying, how to best implement bariatric surgery, which patients need them, which do not, and I know UT Southwestern Children's in Dallas has a bariatric program as well. So cognition and behavior, we also, we focus so much on the medical aspects of taking care of patients, glucoses, labs, but never forget about the psychological, the social environment that a patient is in. But there are studies that show that adolescents with type 2 diabetes perform worse than controls on tests of working and verbal memory and processing speed, and they also perform worse in internalizing and externalizing behaviors. And depression is very common in this population. And a type 2 diabetic team, of course, it's not limited to this, but of course, a physician, diabetes educators, dietitians, social work, clinical therapist. And I think it would be amazing to have an exercise physiologist or someone who can guide our patients and families on how to initiate an exercise program. And that concludes my talk.
Well, thank you very much. That was very interesting. Well, Dr. Gupta will come on here in just a few minutes. I have several really good questions that have come through. And I'll go ahead and start off. This is a question. I have a question that was submitted, and then I have a follow-up question as well. So the question is, one of the realities, especially with childhood obesity, is that economics and socioeconomic status plays a role in it. So the question is, what resources do you have, or what resources or strategies do you recommend to help families to make healthier food choices, either financially to assist them or other resources? So a question for both of you on that.
I guess I'll start. We oftentimes have our social worker come and meet with the families to provide financial resources. I will say that I've done one pilot research project where I provided families with healthy food options, and I actually told them the prices of the options, and I bought most of them from Walmart, kind of to set the expectation that healthy food doesn't have to be expensive. I think that's a common misperception. And you can find some pretty good choices that aren't as expensive as people think that they are.
Let me just to follow up on that with that personal experience. What was the food that you would consider to be healthy that you found at a really good price point at just Walmart?
Yeah, so it was actually a pilot study to try to get patients to come back to our coach program, because like most weight loss programs, we have a lot of lost follow-up. And so I said, every time you come back, I'll give you and your parent a free bag of food. So for breakfast, they got, I think, Greek yogurt and 1% or 2% milk. And then for lunch, I gave them some like almonds and some carrot sticks with ranch dressing and hummus, and the LaCroix, which is the sparkling water. And so those were the options that I was able to find at Walmart. I'll just cut to the punchline. The study did not work. The ones who didn't get the bags didn't come to follow up, just like the ones who got the bags. And one kid added juice to my LaCroix and said it tasted better with juice in it. So.
Okay. Dr. Delatorre, do you have any? Yeah,
no, I mean, I totally agree with Dr. Gupta, and, of course, number one is, we're lucky to have a social worker in our clinic, so they can always help family navigate. And it's so hard because each family is so different. It's not only kind of your finances, but also where do you live, access to kind of food, and, there are the food deserts out there. But also, I think one great point that Dr. Gupta made was, trying to make things more tangible, right? So it's like, okay, so it doesn't need to be expensive. So, our dietitian will meet with the families and say, okay, so what is your budget? And let's kind of make it work. So, but I think as much as you can, and oftentimes we kind of, our clinics are busy and sometimes you gloss over these things pretty quickly, but kind of really diving into, okay, well, what challenges do you have specifically so that you can give tangible recommendations, I think is very helpful. But it is a challenge, right?
I agree. I think also trying to make it relevant to the family. And that segues into my next topic. So what resources, because again, 2 resources as far as physical activity, one of the things that I'll ask when I have discussions about weight with families is I'll ask about physical activity options or opportunities for them, and safety for where they're at, I think is one of the factors too. But share any tips or tricks that you have as far as trying to elevate the level of physical activity for families. I'll let you start, Alex.
All right. So yeah, it's definitely a challenge for sure. I think, of course, I probably mentioned it a few times in my talk. I would love to have, kind of someone in our clinic who could kind of give families kind of specific programs, like an exercise physiologist, some things that we've tried, in our clinic, especially in the REACH clinic, is, how to, I think it's the same as, as the nutrition, how to be tangible about your recommendations and objective, So one of the things that we did is we, believe it or not, we handed out Fitbits for a little bit, so to our patients, and this was, we didn't give it to them, but it was mainly, actually the purpose of the Fitbit trial, we did a little trial on this, was to see, okay, to objectively see how much physical activity our patients were doing, so we gave them this Fitbit, and said, okay, wear it for a certain amount of time, and mail it back to us, and then we'll evaluate the information. And they were blinded to like how much steps they were taking, and we would kind of download the information and talk to them. Okay, do you remember on these days, what did you do, right? So, and on days where they did well, okay, so, on these days that you did very well, that's what you need to do every single day. So to kind of give them kind of more tangible things. And believe it or not, of course we were skeptical at the beginning. We didn't think we'd get any of the Fitbits back, but we got all of them back. But we just did that for a short amount of time. But I think it's what you can do. I try to, I use the steps as much as I can, because I just want my patients to be objective. But within that, trying to create competitions, try to make it fun, it doesn't have to be so all the time, and it's also not about sports. It's, it's also important, not only increasing physical activity, but limit the amount of time that you're lounging around, sedentary time, right? So it's, so it's okay, let's say you do physical activity for an hour, but then you lay around for the rest of the day. I don't know how much benefit there is. So it's also talking not about increased physical activity, but decreasing the sedentary time too. So, but I found that's a huge challenge, is how to effectively kind of motivate the patients or give them good goals.
Yeah, those are great ideas. I completely agree with that. I like the idea of the competitions. Sometimes I'll have the parents and the child work together to reach a goal, and say, all 3 of you have your phones with the step counters. Can all 3 of you together reach 12,000 steps per day? So that way they're like working as a team together. We have a walking program that kind of marches them up every week with gradual goals. So it's not just telling them go from 0 minutes per day, to 60, but we're starting off at 15 minutes per day for 1 week, and then 20 the next week, and then 25. So that marches them up. If they are going to be inactive, I encourage them to take breaks during the commercials to do jumping jacks or push-ups or something like that. So that way they use their break times while they're watching TV. And again, I don't call it exercise. I say, how can we get you to move and to be active? Because I agree, exercise kind of sounds like, whoa, like I don't like exercise either. Right. But to move and be active and have fun, that sounds more palatable.
Very good. What about, do you have anything, just one last question on exercise, then we'll move on. There's some very other good questions, but is there, maybe this is just for my own personal thing, is there anything that you feel has sort of worked as a go-to for families, or is it very individualized? You know, like just walking or calisthenics, or what do you find? Or the other question would be like sports. If you can get a child interested in participating in sports, which can be a challenge, what do you find maybe seems to be the best recipe for success?
My two would be swimming, seems to be a really good one. And if their apartment has pools, if they have access to a pool, that's fun and it can burn a lot of calories. And dancing. Like even if it's at home, turn on the music video or whatever you have and just dance. And that's fun and that's good exercise.
That's good. Yeah, I've had a couple of patients who've had success with getting really active and involved with dance. That's very good.
Yeah, I mean, I don't know if I have any one thing other than those two, you know. Sometimes families just, and even patients, surprise me and amaze me with the things they come up with too when they come to see me the next time, the things they do, you know. One of the, I always find the coolest ones is whenever it's like culturally related, you know, like for example, our Hispanic population, and if it's kind of the folklore dancing and those type of things, you know, because I'm fascinated by that because, you know, it's like they're proud about their heritage and then they can do something fun and physically active with it too. So but usually they come to me with that. I don't usually offer it. So.
Okay. Well, the next question is about metformin. So you'd mentioned about using extended release metformin, which does have better GI tolerability, but there's been, as you noted too, some recalls of extended release. So the question is in regards to a provider who's had to switch some of the patients to regular metformin. Is there anything that you would add? And then the follow-up question, and then I'll give you time to answer that, is what's the youngest age that you have used metformin treatment?
Well, for the extended release and the recall, I mean, there's about 20 to 30 brands of that generic metformin ER, and only maybe 6 to 10 of them have been recalled. Right. So you can still use metformin ER, just not the brand that's been recalled. So instead of switching everyone to immediate release, I try to keep my kids on extended release because of what you said, because of the reduced side effects, and just hope that the pharmacy can find a brand that's not been recalled.
Okay.
Yeah, agree. Yeah. And then also, you know, the hard thing is, you know, often when we get asked what to do, and also you know, it also, because we use metformin for more than just diabetes itself. So it also depends on, like, what are you treating them for? You know, do you need such a high dose? Can you tolerate a smaller dose? Or even, you know, given how they're doing, can you just stop it depending on what you're treating them for? So, but it's just metformin, you use it for so many different things, you know, you just have to see what you're using it for and go from there as well.
Okay. And then tying into that about the youngest age. So there is, and it's hard to get, you can use liquid metformin. You know, Riomet is the name it goes by. So there is opportunities to use metformin in ages younger than could typically swallow metformin. So what's the youngest age that you would use metformin, and is there any circumstances where you would use metformin in, say, a younger age child?
For me, probably my youngest kid with type 2 diabetes was probably 8.
Wow.
Yeah, me too. I think that's the youngest in our group too, was 8. And, you know, I think if there's, at least for me, if it's younger than 10, probably the only reason I would probably start metformin is if the child actually has development of diabetes that's not autoimmune.
Okay.
Right.
And then what about there's another question regarding weight loss surgery. Can you all talk a little bit more in terms of the process that you all follow for weight loss surgery, and is there a lower bounds age range where, you know, below that you'd say that's probably not a good idea?
I'll rely on Dr. Gupta on this one.
Well, I mean, we do. I mean, the REACH Type 2 program does obviously, work things medically, but there is a path towards, weight loss surgery should it reach that point.
Yeah, I'm really proud of our bariatric team. I mean, we have a wonderful surgeon, Dr. Qureshi, psychologist, social worker, dietitian. And over the past 4 to 5 years, we've had about 300 referrals come through. And we only operate on about 20% of them. The age that's covered by insurance is about 14 to 15. But recent papers and opinion pieces have come out that we should consider actually starting earlier if the weight is an issue at a younger age, just because that particular kid, will have so many complications by the time they're 14 or 15. So the process is they're referred to the bariatric program. They have to meet with a psychologist, they have to meet with a dietitian, they have to prove that they can make some changes to either maintain weight neutrality or lose some weight prior to surgery. We're pretty stringent about who we choose to move forward. Hey, Dr. Burton.
You guys are on live mic. Okay. Let's see. There was one other. First of all, if anyone else has any more questions, please submit via chat or via the Q&A. I did have one other question for you all as well, and that was about, and this is actually kind of torn from the pages of some challenges I've had recently. How do you address when families have reluctance to use medications? So again, let's use an example of someone with type 2 diabetes, and there's reluctance to use insulin, or a belief that insulin is bad, or even concerns that, metformin causes cancer, I don't want to use metformin. Do you have any strategies that you use to address, concerns, be it cultural or just personal beliefs that families have that really, run counter to the need for medical management for the patient?
Yeah, that is, it's definitely challenging, right? It seems like we're seeing more and more patients, some weeks, when we're on call where it's a struggle. Sometimes, you recommend a certain medication and for whatever reason, either in the news, on the internet, family experience, we had a horrible experience, I don't want to give it, and it's tough, but of course, as a doctor, you always have to kind of balance, of course, safety as well too. So just because someone doesn't want to give it, they still may need it from a safety standpoint. I think the only thing that we can do is, objectively, calmly, and without judgment, try to kind of go through our points, of, okay, let's go through each medication. This is why we're recommending it. This is the research that's out there, And I think, and also you always have to remember too, a lot of times these patients, patients and families, when they have these reactions, they're at a moment of great distress too, because it's a new onset. It's like, oh my goodness, now what are we dealing with my son or daughter? And it's scary too. So sometimes it's, it's a process too. So, it's kind of, don't feel like you'll win them over with one slam dunk, but it might be a slow process kind of over, a few times, visiting them a few times a day while they're in the hospital, or they might change their mind by the next day, right? So, but so far, even in the patients where I've had, difficulty, I think for the most part, by the time they leave the hospital, we've been able to convince, there's no one that jumps out in my mind that they completely refused, although I know there are some that have. But I think it's just kind of continue doing it. And the other thing I always stress, I'm like, believe me, I don't like medications, and I'm not going to start anything that I don't need, but if I need to, I will. And if there's something that I can take off, especially the insulin, I will. So I kind of always try to reassure them too. It's like, you know what? We need this now for his safety, but believe me, if we don't need it down the road, we'll take them off, because we don't like medicines if we don't need them, for sure.
Okay, that sounds good. Do you have anything to add, Dr. Gupta?
I mean, I would agree with that, and just try to meet the family where they are and understand their reluctance. I know I've had some families that have said, you know, grandpa had type 2 diabetes and he took insulin and he had an amputation, and it's because of that insulin, which is why he had the amputation, and then trying to, you know, backtrack and say that's not why he had his amputation. Let's talk about that some more. You know.
Absolutely. Well, thank you all very much. This is very interesting. And again, this represents both the spectrum of obesity and obesity associated with type 2 diabetes. Just represents a very challenging and complex, you know, segment of pediatric endocrine care. So thank you all very much for coming on and sharing your expertise.
A century ago, the first children's hospital in Fort Worth opened with 30 beds and a promise to provide every child in the area access to medical care. From these humble beginnings, Cook Children's has grown to become one of the largest and most recognized freestanding pediatric healthcare systems in the country, and now providing care to children all over the world. As we continue to grow, one thing remains the same: the promise we made long ago and intend to keep for generations to come. 3-time magnet designation, 6 endowed chairs, 9 nationally recognized specialties, level 4 NICU, only hyperinsulinism center of its kind in the southern U.S., only pediatric system to offer MIBG therapy in the Southwest United States. More than 1,000 stem cell and bone marrow transplants. 28 private inpatient oncology rooms. Comprehensive and highly innovative neurosciences program. 3-star rating from the Society of Thoracic Surgeons, among the elite in pediatric congenital heart surgery. Urology and genitourinary program with certified renal transplant center and a complete fluorovideo urodynamic suite. Leading genetics center in the nation, providing clinical and metabolic genetics evaluation. 433 sponsored clinical trials. 163 peer-reviewed publications. 31 specialties. Physician network with over 400 doctors. International patients from all over the world. Excellence in trauma. 60 locations all over Texas. And lastly, over 1 million patient encounters every year. Fort Worth, Texas is the home of Cook Children's, the 15th largest city in the U.S., known for cowboys and culture. A safe and diverse city, Fort Worth welcomes nearly 9 million visitors every year who enjoy everything from NASCAR racing, rodeos, world-class museums, restaurants and shopping, to a top 5 zoo, amusement parks, and Dallas Cowboy football. The Dallas-Fort Worth International Airport is a short drive and services flights all over the world with 200 flights from Latin America and Mexico. Cook Children's has a story 100 years in the making. And yet, through all the magnificent growth and acclaim, our promise carries on with you, the community whose generosity dares us to dream, and the patient who inspires us to excellence. Only time will tell what the next 100 years will bring, but one thing remains certain. You're the one who makes all the difference, and you're the one in our 100. Come and see what Cook Children's and Fort Worth have for you.
we'll talk about normal pubertal development, and then I'll differentiate what's normal in boys versus girls. And then we'll talk about signs of central versus peripherally mediated early puberty, and then we'll talk about therapies at the end. So I'm going to kind of talk about fetal development at first, because it's very important to how we evaluate and how it affects them long term. So sexual differentiation occurs as early as week 8. Ovaries actually meiosis starts at between week 8 and 13, and then they are arrested in prophase until girls start ovulating, which is at puberty. For testes, they are stimulated to develop by actually the placental HCG in the first 2 trimesters. But then their own pituitary, which the LH surge takes over about at week 20. And then puberty in boys initiates spermatogenesis and then fully differentiates the Leydig cells in the testicles. So the pituitary plays a huge role in utero. GnRH, LH, and FSH peak at between weeks 20 and 24 in utero. And then they drop to prepubertal levels until it's time to give birth. So boys, their LH begins to rise soon after delivery, and it actually increases tenfold after delivery. So sometimes when we're called to see a baby who you might think might have some kind of, ambiguous genitalia or something going on with their pituitary, we'll often check LH, FSH, and pubertal hormones, because those are actually increasing at birth. So the LH and FSH peak occur at week 4 and 10, 4th to 10th week after birth, and then they decrease by the 6th month. Testosterone actually increases by the 3rd month, and then by the time the baby is between 6 to 9 months, it goes back down. In girls, gonadotropins also surge the first week of life after delivery, and then they peak between the ages of 1 to 3 months, and then they start to drop again. FSH tends to be the gonadotropin that peaks the most until toddler age, until the age of 3 or 4. And then you'll see estradiol levels can fluctuate between birth and age 2. And I don't touch on it, go into it a lot here, but sometimes that is why we see something called mini puberty, because of fluctuations in the first couple years of birth, after birth. So you can see this table kind of shows the peaks. At the top is the boys. And you can see that LH, FSH, and testosterone all peak around 2 to 3 months, and then by 6 months they go back down to pre-pubertal levels. Girls, soon after birth, you can see LH and FSH also surge between by about 2 months of age, and you can see the estradiol actually fluctuates quite a bit during the first 6 months. So then what about after infancy? So normal puberty, you can see after infancy, they go to prepubertal levels. So all those hormones after the initial surge should be at prepubertal levels until they're ready to start puberty again. So what happens between age 2 until kids are ready to start puberty is that there's actually a suppression at the level of the pituitary. The hypothalamic pituitary axis is suppressed until the body is ready to begin puberty. So what happens is the reason that puberty starts is actually that suppression from the pituitary gland is removed. So when you remove the hypothalamic pituitary suppression, you actually start GnRH is secreted, which then causes LH and FSH to be secreted from the pituitary, which then signals the testes or ovaries to get started. So girls, the actual first sign of true puberty is thelarchy or breast development. When you see breast development, then you most likely think, ooh, there's, the central, this could be centrally mediated puberty. Usually that is from the pituitary causing the ovaries to create estrogen. So it can occur as early as age 8. And can be normal as early as age 7 in African Americans. The average age, though, across the board is 10 for thelarchy. It is, and I'll touch on this in a couple slides, thelarchy is starting slightly earlier over the past 40 years. So, you know, a lot of families will come in saying, oh, I hear puberty starting earlier, you know, and what we're seeing is that actually breast development is starting earlier. Menarche or periods is not as significantly earlier, and we'll go over that in a second. Adrenarche, which is, you know, the body hair, pubic hair, body odor, usually occurs in conjunction with breast development or thelarchy, but that can actually occur a lot earlier, as early as age 6 or 7. And usually when adrenarche occurs, you will see a spike in DHEAS. So that's the hormone that is most closely associated with adrenarche. Menarche, or the age of the initial period, the average age is 12. And everyone has thought, oh, periods, or girls are starting their periods much earlier. But if you actually look at the data, the average age of menarche has decreased by about 4 months over the last 40 years. So it's a little earlier, but not significantly earlier. Medically normal or average age for menarche is between age 10 to 12. It's considered precocious puberty if you start your period before the age of 10. And then we consider it delayed if a girl has not started her period by the age of 16. In boys, the first sign of true puberty or centrally mediated puberty would be testicular enlargement. And so the average age for that is about 11 and a half. That can range from 9 to 12, meaning it can be normal as early as 9. And then that would mean that the testes would be greater than 4 mLs or 4 cc's when measured. Testicles enlarge about 6 months before you notice any penile growth. So that is the first sign. Adrenarche, which is, you know, body odor, hair, things like that, that can be much more difficult to delineate between boys, you know, what's adrenarche and what's true puberty. Girls, it's a lot easier to figure out what's, you know, what's breast development and what's adrenal. So more difficult to delineate in boys because hair growth can be stimulated by the testosterone that the testes are making or the adrenal axis. So it's a little more of a puzzle sometimes when you see a boy come in with some body hair. So usually adrenarche also occurs at the same time as testicular enlargement, but it can happen a little bit earlier as well, as we're starting to see a little more of. So this just kind of shows you for girls when they kind of start growing faster. So when girls start thelarchy, and we're saying the average age is about 10, you'll see as soon as they start the first signs of puberty, which is breast buds, their growth velocity will start to pick up. So you can see their growth velocity starts to pick up before they actually hit their period. So I always tell parents, girls start to grow much faster before menarche starts. And you can see peak height velocity for the average girl picks up around 11. Boys are a little different. So boys will start puberty and you will not see that increase in growth, like a really fast growth, until a bit later in puberty. So you can see Tanner 2 average pubic hair, it shows here around the age of 12, but then you see that peak in height velocity is later, closer to 14. So boys, pubic maturation happens over a longer period of time. They go through the Tanner stages over, several years, and you can see that their height velocity increases a couple years after you first notice the first signs of puberty. So what's considered too early? So in girls, breast development before the age of 8 is considered too early, and before 7 in African Americans. Of course, you want to look at the pace of it, how fast it's going as well, but that is kind of what we use as our cutoffs. Adrenarche traditionally would occur after breast development. However, it's happening a little bit earlier now. We're seeing a lot more of just premature adrenarche. A lot of that is due to obesity and other environmental factors. Signs of adrenarche would be acne, axillary hair, pubic hair. Anything before the age of 6 with those signs would be considered early. Also, if it's starting somewhere between the age of 6 but progressing rapidly, those kids need to be evaluated. How about for boys? So any signs of testicular enlargement before the age of 9 is considered too early, or pubic hair before the age of 9. Like I said, it can be difficult to figure out what's happening if you just see hair. Is it true central precocious puberty, or is it the adrenal glands turning on? So a workup might need to be done when you see early hair development in boys. Precocious puberty in boys tends to be more pathologic, and in girls, the cases are more idiopathic, meaning there's not usually something else underlying going on. So what kind of workup should we do? So if you see a girl with early breast development, you would want to test the central axis, meaning the pituitary. So we'll check the LH, FSH, estradiol. You want to make sure and check thyroid functions, because hypothyroidism can actually induce a puberty type picture because it stimulates the FSH receptor, and then that would stimulate the ovaries. So definitely check thyroid as well, and then bone age. And if you're in true puberty, usually the bone age is advanced. So if you're seeing adrenarche, you're seeing more hair, acne, those kind of things, you want to check the adrenal glands. So you want to check 17-OH progesterone, androstenedione, testosterone, DHEAS. While it is elevated in benign, isolated adrenarche, it can, very high levels can be seen in adrenal tumors, so we do need to check for that. Bone age is typically not advanced, but it can be slightly advanced in those with benign adrenarche. So how about boys? So boys who have adrenarche or hair or testicular enlargement, you want to go ahead and see where that's being mediated from. So we want to check the LH, FSH, testosterone, 17-OH progesterone, androstenedione, DHEAS. So that's the adrenal axis and the central axis, pituitary and testicles. You may want to consider beta HCG as a tumor marker, like testicular tumors, liver tumors can cause male hormones. So AFP, so those are both tumor markers to rule out any kind of tumor that's stimulating a puberty type, like a peripheral puberty. Bone age also needs to be checked to look for advancement. So bone age, like we kind of discussed, would be advanced if it's central precocious puberty. Usually if a bone age is advanced, that means there's some kind of long-standing hormonal process involved. I will say it can be a little difficult in a child who's obese, because obesity in and of itself can cause the bone age to advance. So that's where it's a little harder to tease out, is this obesity, is it puberty? But typically if it's just benign isolated adrenarche, the bone age is not advanced. When would you refer to us? You may want to refer to endocrinology if any of the labs are abnormal, if the bone age is advanced, or if you're noticing rapid growth velocity with pubertal changes. So typically isolated adrenarche or just hair or body odor doesn't cause you to grow faster, a lot faster than average. So causes of precocious puberty. Peripheral causes in girls would be things like ovarian tumors. You can have a granulosa cell tumor, which would usually cause estrogen levels to go up. Sertoli or Leydig cell tumors may actually produce as excess androgen. So if you're not sure that's coming from the pituitary, we do look at the ovaries and do ultrasounds. Ovarian cysts, this can happen sometimes in girls where you just have a random ovarian cyst, can produce a little estrogen, and then the cyst pops and it's gone. So you may have a little transient production of estrogen with some spotting. And so some girls will come into your office, 7 or 8 years old, have one episode of bleeding and then nothing again. So when you tend to ultrasound them, you don't actually, because the cyst has already been gone, you don't see anything. But that is something to consider if we can't find an origin. McCune-Albright syndrome is a common, or not common, but is a cause of ovarian cysts and can cause peripheral puberty because the ovarian cyst is producing estrogen. And then exposure to exogenous estrogen. I always ask parents, there's a lot of parents now, moms and dads, who take estrogen, testosterone, whether it's supplements or some kind of cream. So I always ask about that. Also, a lot of people are using essential oils, so you want to ask about lavender and tea tree oil. Both of those have an estrogen-like component and can cause some early signs of puberty. LH and FSH will be low if it's peripheral puberty, and estradiol will be elevated alone, and this is in girls. Central precocious puberty, like I said, in girls is most likely idiopathic if the child is over 6, 80 to 90% of cases. A lot of times, central precocious puberty can be genetic, meaning the timing, you'll see a similar timing in the mom or the maternal grandmother. Obviously, we need to always consider CNS lesions. There can be something at the level of the hypothalamus, like a hamartoma, other CNS tumors, kids with history of irradiation, cancers, or neurofibromatosis is also a common one. Once confirmed with biochemical markers or labs, we usually will order an MRI to look at the pituitary. In boys, peripheral puberty, you'll see a low LH, FSH, but high testosterone. So examples, things that would cause that would be a Leydig cell tumor, which would be testosterone secreting. You would see on exam possibly asymmetric testicular enlargement. So an ultrasound would be what needs to be done, and then they would biopsy. A urologist usually would follow up with that and biopsy that. HCG secreting tumors can be in the testicles, brain sometimes, or liver. So that's also why we would check an HCG if we notice rapid progression of puberty in a boy. Testotoxicosis is more rare, but genetic. It's an activating mutation of the LH receptor gene. Boys will develop excess testosterone because the LH is always being activated, and it's autosomal dominant, so it tends to run in families, and there will be a family history. And then I talked about exogenous testosterone. So a lot of dads now, you see low T clinics everywhere. Usually those men are taking testosterone by injection, but you just want to make sure that they're not taking androgel or some kind of creams or other supplements that the child would have any exposure to. So I always ask. Causes of central precocious puberty, idiopathic, obviously happens often, but in boys it is more likely to have some type of CNS origin, like a tumor, hamartoma. So if you see a boy less than 9 with central precocious puberty, we're always, a little more alerted to look for a cause. Neurofibromatosis and other CNS lesions, like we mentioned in girls, a lot of similar cases. So as far as more peripheral, if you just see adrenarche with advanced bone age, you want to think about adrenal causes. Non-classic CAH might be one, and in non-classic can be different. The most obvious that we see is 21-hydroxylase deficiency, but there are other types of CAH, 3 beta, 11 beta, which can give you elevated androgens and cause advanced bone age, but is not true central precocious puberty. Adrenal tumors need to be considered, and then what we see is adrenarche, or early hair body odor development, is more common in premature or small IUGR babies. So I usually get a good history to see if that has been in their past. Also, adrenarche is linked with insulin resistance. So some of my families, especially those of the girls, will ask, is there any risk in the future? Because my daughter started pubic hair at the age of 5 or 6. And it is linked with the increased risk of PCOS, future risk of obesity, and insulin resistance. Okay, so pubertal trends. If we look at papers written back in the 70s, Tanner said that the average age of thelarche in a girl was 10.5 back then. Periods or menarche started average age of 12.5 or 12.8. Boys started puberty around the age of 11.5. So if we look at the more recent studies, there was a PROS study where they looked at 18,000 girls in the US and Puerto Rico. Thelarche, you can tell, has started earlier, has moved back. So the average age of thelarche is close to 9 in African Americans and close to 10 in Caucasians. So you can see that is definitely earlier than 30, 40 years ago. Pubic hair, average age in this study was seen to be 8.8 in African Americans and 10.5 in Caucasians. Menarche is slightly earlier, about 6 to 8 months earlier in African American and Latino girls compared to Caucasians, but the average age is still 12.5. And so the average age of menarche is essentially unchanged over the last several years. But we do see that the higher the BMI in girls, the earlier the puberty. As far as boys, 10 or 2, the average age of a boy reached 10 or 2 is about 10 in a Caucasian, and 9 in African American, and 10 in Hispanic. So they are seeing that boys between 6 months to 2 years earlier in previous studies. So the interesting thing about boys is obesity actually causes pubertal delay in a boy, whereas it would cause it to be earlier in a girl. So why? Obesity does cause increased levels of leptin, which is produced in the fat cells. Elevated leptin actually activates the hypothalamic, the GnRH pulse generator. So that kind of gets the puberty going. Some other causes of precocious puberty that are thought are BPA, the things that you can find in plastics and some canned foods, and endocrine disruptors. So there's a lot more study that's being done in this. So a lot of this is just early, but there's something called phthalates, which are which in a study was known to cause breast development in Puerto Rico. That's not really used in any products right now here in the US, but just so you know, that is something that has been shown to cause breast development. Phytoestrogens, which is what you see in soy products, can also stimulate thelarchy or breast development. So as far as how do we treat precocious puberty, so if it's peripheral, you need to remove the source of the peripheral hormone production. So if it's a tumor, we remove the tumor, like remove an ovarian cyst. If it's CAH, if it's the adrenal glands triggering early puberty, we would need to treat the CAH and with steroids possibly. If it's peripheral, we can't treat, at the level of pituitary, meaning like a GnRH agonist, which is typically used for central precocious puberty. So ways to treat peripheral, you block the hormone at the level of the receptor. So if you're making too much estrogen or too much testosterone. So aromatase inhibitors will block testosterone from turning to estradiol. So that is one way to prevent estrogen production. Androgen blocker or inhibitor like spironolactone or ketoconazole will block testosterone at the level of the receptor, or estrogen receptor blockers. These are all used in peripheral precocious puberty. Central precocious puberty, which is going to be way more common and what we see, we do talk about treatments with families, and I always tell families there are 2 reasons why we stop, central precocious puberty. One is height. So if children start puberty too early, it advances the bone age and will cause attenuated or shortened stature. And so if we start treatment early, girls can gain adult height if treated by the age of 8. And I'll be honest, even in my own personal experience, I look at the bone age, and usually if you catch the girls before a bone age of 10 or 11, you can add some, definitely 10, you can add some height. But once the bones are past 10, it's much harder to get extra height with treatment. And then boys, height is preserved if we catch them before the age of 9. And then the second reason why we stop puberty is psychological. So especially more for girls, the burden of managing periods every month at a young age needs to be considered as an option for stopping puberty. So an MRI always needs to be done to rule out any kind of lesions in the pituitary gland before starting any kind of therapy. So what are some example, when I'm talking about GnRH agonists, well, how does that work? It safely suppresses the GnRH pulse stimulator at the level of the hypothalamus to the pituitary. It stops that signal. And so once that's stopped, actually some of the effects are reversible, meaning some girls who just have 10 or 2 breasts, you may notice that they go down. And typically we continue this therapy until the age of 11 in girls and age of 12 in boys. It's obviously an individual decision. We look at their growth, their maturity, and talk with the family, and we try to make a decision all together. What are some examples of this therapy, GnRH agonist? So this is interesting. Just since a couple years ago, since we've talked about this, there's been several more therapy options. There used to just be two, Lupron and Suprelin. And so you'll see that there are a couple of new ones out there now. So Lupron is the oldest therapy that's been out there. It's Leuprolide depot shot, so it lasts for a long, it can last for up to 3 months. So there are monthly IM injections. That's what came out first. Right now, there are every 3-month injections. So every 12 weeks, IM injection is given, and it suppresses puberty at the level of the hypothalamic pituitary axis. As far as side effects, there are occasional site reactions. Some kids do get redness, tenderness. Some kids, if their estradiol levels are high when we're stopping puberty, by giving them Lupron or GnRH agonists, we are dropping their estrogen levels quite quickly, just like you would see a woman who's about to start their period. So they may have some bleeding or spotting the first time they use one of these medications, and I do try to warn parents about that. And it's just the first time when we drop their estrogen levels. And then weight gain tends to be a side effect of all of these medications, but it's because it increases their appetite. So I usually try to counsel these families that, hey, your daughter or son may be more hungry. We just need to really work on picking the snacks and treats and staying active. And usually most of my kids do pretty well if we try to work on it on the front end as far as weight gain. But weight gain is a side effect. Suprelin, so that's the subcutaneous implant, which I have a picture at the end, which is a small little pencil lead kind of thickness implant that you put under the fatty tissue of the arm. It is surgically implanted, but it's a very quick procedure that can be done just in outpatient surgery, and it lasts for 12 months. So it needs to be removed and it's replaced every 12 months. Same type of side effects, like I said, spotting or weight gain as well. So there are 2 new agents available that's come in the last, just very recently. Triptador is an IM, just like Lupron GnRH agonist, but it lasts 6 months instead of 3 months. So that's been out on the market for 1 to 2 years now, 2 years probably. It has also the side effects of injection site reaction, weight gain, but it seems to work just as well as Lupron and Suprelin, so that just gives families another option. And there's something that just came out on the market. It's called Fensolvi, and it's also leuprolide acetate, but it's actually sub-Q, so much easier to give. And it is every 6-month sub-Q GnRH agonist. It just came out, so I have actually not given it yet. It has been used in adult patients for cancer treatment. And so it's been in the adult market for years, and it was just recently FDA approved. So it hasn't gotten on all the insurances, so we're just starting to try that out. But that shows you that basically there are 3 different injection options and then 1 subcutaneous implant. So you can see the Hystrelin or the Suprelin implant, very small. It's put right under the skin after the skin is numbed up. Requires 1 stitch or even a steri strip to close it up. It heals up within a couple days, and the patient doesn't really notice it, and it stays there for a year. So those are treatment options that we discuss with families. So then after I discuss with families and we choose one, I monitor them every 6 to 12 months. And we will check LH, FSH, estradiol, and testosterone to make sure they are nice and suppressed. Once we decide, okay, it's time for the child to finish up treatment, and once treatment is halted, usually most patients resume puberty at the same pace as they started within a year of removing or stopping the treatment. So it's not like as soon as we stop the Lupron or remove the Supprelin, a girl is going to start her period. She just continues to progress like she was prior. And it has no, which a lot of families ask me this, has no effects on adult fertility or reproduction later. Okay. Okay. I think my next slide just says questions for some reason. There we go. So I think I am done now, and I am open to take any questions.
Well, thank you very much. Very, very interesting and a very thorough overview in the limited time. So thank you again. A couple of questions have come up. The first question I wanted to ask you is a question that I think a lot of us in pediatric endocrine get asked with precocious puberty, and that is families asking about hormones, quote, hormones in food. What's your answer to them when they ask about, what's going on? Why is my child starting puberty early? Assuming that there's no obvious pathologic reason that you can detect.
Right. Yeah, we get that all the time. So what I tell them is, from what we know, there's not a direct link to food sources or hormones in food. And I'm going to be honest with you, in my own personal experience, I tell them that I would say 80% of the girls that come into my clinic, their parents are like, they've been on organic milk for 3 years and they're still 7 and have breast buds. So, I mean, that's obviously just my anecdotal evidence, but I tell them there's really no studies that it's food that's causing, or that there's a link to hormones in food that's causing precocious puberty. Obviously, if the child is obese, we do know there's studies of obesity being linked to precocious puberty. So I may address, healthy eating and weight gain. But if the child is thin and otherwise healthy, I just discussed the few things I discussed in the slides, is that, that there's some links to BPA and estrogen disruptors, but there haven't been links to meat or milk or, those things that most parents worry about.
Very good. There's a question about use of GnRH agonists if you have a child who is in puberty to help prevent short stature. I'm assuming that the question is more directed maybe early onset, rapid progressing puberty with, again, presumably no underlying pathology, or at least pathology that wouldn't contraindicate some type of treatment. What's your opinion from that standpoint?
Right. So I do feel that if you catch it early enough, that GnRH agonists do help help increase, the height for most of these kids. But I would say I think I mentioned in one of the slides, but what I've noticed is that if you catch kids before, like girls especially, before their bone age is 10 or, I think you can add some extra height. But the problem is once you progress past then, I don't see that it adds a whole lot of height. And the same with boys. I think once they're, boys have longer, their growth plates are open until they're 17, or until their bones are 17. But so if their growth plates are already 12, we don't get quite as much, height, additional height by using Lupron. If the question is more geared towards, some people are wondering if you have somebody with short stature and you're trying to prolong, you're trying to add some height, would it be helpful to stop puberty? The thing is most insurances, if it's not precocious puberty, are not going to cover these agents, which are very expensive, to help add height. Would it be helpful? I think if you start it very early, at the very beginning signs of puberty, yes, you could add some height for these children who are already short, but the problem is getting it covered. I mean, Lupron is more expensive than growth hormone. So I think cost, unfortunately, would be a big preventer for someone coming into my office who just wants to add height. If it's not purely just about the puberty part.
Right, and I'll just to add to that, I know from my perspective with getting approval for GnRH agonist treatment, one thing I have to be very scrupulous about, because I have had recently some patients with, puberty right at sort of the cusp of precocity, but it's going very quickly. And documenting very clearly that there was onset of puberty before 8 in the girl or 9 in the boy. Otherwise, it's almost an immediate, denial that I see.
Right.
There's 2 questions about lab assays. So what is the level of LH after, and this is actually to back up, so the question is about GnRH stimulation testing. Okay. So I'll add on to that, so we can obviously, as pediatric endocrinologists, we can do a GnRH agonist stimulation test if we're concerned or want to prove precocious puberty, or we can just measure random gonadotropins as well, unstimulated. So can you speak a little bit about doing the test and as well as the random specimens and how you view or interpret those results?
Right. So a lot of times when children come into my office initially, I don't plan a stimulation test, because those take a little bit of planning. So whenever I have a child come in initially, I'll tell the family, especially if they're very early puberty, when they're in the very first stages of puberty, it can be very difficult to ascertain if someone's truly in precocious puberty or not. So I'll tell them, let's check a random LH. And so I do a random LH. We do pediatric assays because they're much more sensitive. So ultra-sensitive assays. And so I use a LH of 0.3 for random. And then, it depends on the lab, and then the estradiol, like a random estradiol, I think on Quest is a 10. So I think it depends on the lab, but if you have an estradiol, like a random estradiol greater than 10, that's detectable, in a young child, a child less than 8, a girl less than 8. But usually the LH is what I use as a cutoff, the random LH of 0.3. And if that's not clear, if they come to me and the random levels are all low, but I know I'm highly suspicious that they're in puberty, I'll bring them back for a stimulation test. And so we may do stimulation tests differently because I'm in a small office and I just do, I do a 30, 60 minute stimulation test in my office and then a 24-hour level.
Right.
So yeah, we stimulate them in the office with a small dose of leuprolide and see how their pituitary and ovaries respond. It's different depending on how you do the test. There's different cutoffs. But yeah, for me, I definitely use, it's nice if you can bring them in and get a random LH of greater than 0.3. And then, you've got that. I don't know how you guys do your stimulation tests.
Similar. I'll speak to what I do. Unless I'll generally do unstimulated results, and if it's not definitive or if it looks negative, then if I feel the situation warrants clinical follow-up. If it's a younger child, the tempo of the puberty is not overly fast, in my opinion. The bone age advancement is not more than a year plus maybe a little bit, then I'll follow that child to assess tempo. And if I'm still not getting a definitive idea, then I'll do leuprolide stimulation testing. And that kind of ties in, one of the questions too was asking about what you look at. So do you look at an absolute LH level after the test, or do you look at this person asked about an FSH to LH ratio?
I normally look at absolute LH, and for the stimulation test, I look at the LH and then the 24-hour estradiol response.
Right, and that's what I do as well.
Yeah, I don't really, even though we look at FSH, I don't look at that ratio.
And from my perspective, and you can tell me what your experience and opinion is, but the FSH response to me is helpful, but it's not the driver to me. It simply tells me that the axis is maturing, and if the LH is not definitive, again, I'm going to continue to default in most cases towards close observation,
Yeah.
and if things are progressing, then use that as kind of the final decision.
Yes, I agree. I don't use the FSH to really hang my hat on. I mean, I look at it and it adds a little information, but yeah, the LH response is really what I use for sure. And then in some cases, the LH will be borderline, but then you have a very high 24-hour estradiol, and so that'll,
Right.
yeah, I usually use those two, or testosterone. Yeah.
Absolutely. That finishes up the questions. Was there anything else that you would like to offer for someone who's doing primary care, say a Pearl, to help them to decide, okay, this is a child that needs closer investigation and a prompt referral, versus a child where maybe I can tell where you can advise the family to simply watch more carefully?
Yes. So I would say I think it can be very confusing because we're having so many more kids coming in for pubic hair, body odor, acne. So I think when you're looking at a girl, breast buds before the age of 8, definitely a referral. Just let us figure it out, from there.
Okay.
And that's how I think, just to be clear about it, because I think it can be very, parents are very anxious. And then I think for boys, boys are a little more difficult to ascertain, like I discussed so I think boys, pubic hair or testicular, changes before the age of 9 should be referred. And then I think just looking at the whole picture, looking at the rate of growth. So if these kids are starting to, most kids before they hit puberty are all growing at 2 inches a year. So if a kid comes in and has grown 4 inches this past year and has some pubic hair, you may want to, send them in, because the two of those combined likely mean there's something going on. So I definitely look at the rate of growth. I think it can be helpful to do a lot of pediatricians will do bone ages before they come see us. So advancement of bone age, and then, like I said, breast tissue before 8 in girls, or pubic hair, testicular changes before age 9 in boys. What I've been seeing lately is, of course, the overcautious people, but then I think some people are kind of jaded thinking that puberty is starting way earlier in children. And so I've had multiple cases in the last 2 months of 9-year-old girls who started their periods. And their pediatricians have said, oh, it's just happening earlier now.
Right.
So that's one thing I do want to make clear, is that that's not normal.
I agree. I mean, it does occasionally happen, but you
Right.
certainly need to look for pathology at that point.
Right. So that's kind of what I would kind of leave them with.
Absolutely. Well, thank you again very much for joining us, and I'm sure with your expertise, we'll be asking you again to talk to us in the future. It would be nice to, I think, take some time and talk about physiology, and I will touch on that a little bit. My goal is to make this more of a practical discussion and really to answer the two key questions on the slide. What do you do if you have a child who comes in with symptoms of polyuria and or polydipsia? And a very perplexing question that a lot of people deal with is, how do you handle abnormal values that you see on labs, particularly when we're talking about sodium levels? I know from my standpoint in pediatric endocrine, interpreting lab values and trying to make sense of whether this is true pathology versus lab errors versus some type of artifact can be a real challenge. And I'll have to say that for families, I get numerous questions asking me to interpret or provide perspective on results that they see that are flagged as abnormal. And one of the challenges, I think, for us as pediatricians or those that give care to pediatric patients is the fact or the reality that a lot of the norms that are quoted for the lab reports that we get are quoted for adults, or quoted, for instance, in the case of glucose, quoted with the assumption that you're dealing with the fasting glucose. And that could provide or create a lot of anxiety for families, because many have the ability now to look at the electronic medical record and see their child's lab results, sometimes before we in our busy volume of reviewing information have had a chance to do that. So when we talk about water and electrolyte balance, I think it's helpful to try to break this down into really looking at sort of the key areas. So, and I like to use a bucket analogy for this. So essentially, if you have a bucket, you have a bucket that you have to pour water in, and then there's going to be water or fluid that's coming out of that bucket, and that essentially creates a system where we have homeostasis. And within this system itself, there's going to be factors, illnesses, medications, other things that can affect this homeostasis. So to begin with, one of the questions, and this is very important both for us as we begin to evaluate whether or not the intake that's reported to us for a child is appropriate, is to look at what would we expect. What's basically the typical amount of fluid that one might expect? Because again, if a child is taking too much fluid, or if a parent is inappropriately giving too much fluid to a child, or if you have a child who has some developmental, neurologic, mechanical issue where he or she's not able to take inadequate fluid, that can lead to abnormal balance in fluid and kind of downstream abnormal electrolytes. So the table here on this side kind of gives you some ideas on what's considered normative. You can also look at, and this is more used in the setting for hospitalized patients or patients in an urgent care or emergency room, where we're looking at questions of fluid resuscitation and ongoing treatment. You can use the Holiday-Seeger formula, which for me, and I think many people in the medical field, is one of those things that I remember and have used since my first or second year in medical school. But this can also estimate 24-hour fluid intake given from like an IV standpoint. We also need to look at minerals and nutrients. Again, sodium, this is a estimated typical range of sodium that's taken. Generally, with an ad lib diet, you're going to probably get a lot more. If you eat like a lot of cheese, or if you have potato chips or something, you're going to get a huge amount of sodium. Also, many soft drinks have a lot of sodium in them as well. But the good news is that we have, most of us, a healthy body with healthy kidneys that can filter that sodium load and get rid of it. We have homeostasis within the body. So if we have issues where we have, again, mechanical problems with intake, or if we have GI problems where we have rapid transit or diarrhea, that can certainly impact our fluid loss. If we have a condition such as, say, cystic fibrosis, where there's enhanced loss of sodium from the body, that can also have negative impacts. And then we have what comes out. So again, this requires healthy functioning kidneys, a GI tract that is able to function properly and able to have normal transit time, so you can get absorption of most of your water that isn't absorbed through the small intestine in your large colon. And then there's just insensible losses which happen regardless. And again, these are primarily through the skin or through the respiratory tract. And one of the things that we can really appreciate, I think, when we're dealing with ill patients in the hospital, is that insensible losses can oftentimes be very, very high. If you're dealing with cases of fever, or if you have a respiratory illness or mechanical ventilation, you can lose quite a bit of extra water through that route. And if you're not careful, you can see dehydration or volume contraction, which again can translate into abnormal sodium levels. So again, another schematic, I won't dwell too long on this, is just looking at the effect of sodium and water together. So you have free water, you have sodium, again, taken in from the body, and you have the two in solution. If you add additional water, or you're not able to get rid of your free water, you have a state of volume overload, which leads to dilution of that existing sodium and leads to hyponatremia. On the flip side, if you have either inadequate intake or more commonly some type of GI illness with vomiting and poor oral intake, you're going to lose excess water and you're going to have volume contraction and hypernatremia. Now, certainly there are rare situations, and these can be very concerning, where you can have excess sodium intake and leading to hypernatremia, but those are fairly rare overall. So one of the things I want to mention before we segue into talking about the cases is just establishing priorities. So as a primary care person, and I think this is true really for me even as an endocrinologist in many cases of fluid balance, and is that the issue primarily is going to be an issue of dehydration causing these imbalances. And so my first priority is going to be evaluating for the potential that there's shock in the child and dealing with that emergent issue first. So in other words, providing crystalloid for fluid resuscitation if there's presence of shock. And so I've put in the schematic here, what's considered to be the standard sort of classification of shock. But again, this goes into I think the importance of providing medical care. And I speak to this both as a physician who directs care on patients, but also I speak to this too for nurses and other people that are part of the care team. It's part of your role and responsibility in assessing the patient to evaluate their vital signs and note if there's abnormalities, bring this to the attention of the care team so these can be addressed. So again, before addressing any abnormality in sodium, the volume needs to be evaluated first. Dehydration can be classically described in 3 different types. There's isonatremic, hypernatremic, or hyponatremic. You know, these two on the left side are certainly much more common. Most of what we're going to encounter in a medical practice or urgent care ER setting is going to be isonatremic. Again, hypernatremic dehydration definitely can happen, and certainly in children who have conditions that predispose them to more fluid loss, say someone with uncontrolled diabetes or someone with uncontrolled diabetes insipidus or someone with GI problems, that all of those things can predispose to hypernatremic dehydration. Probably the least common, but unfortunately a very serious situation is hyponatremic dehydration. And this typically is going to occur classically in the setting of a vomiting illness where the parent is inappropriately giving hypotonic fluids like water or other types of hypotonic fluids instead of using more of an electrolyte replacement like Pedialyte. And again, the seriousness from hyponatremic dehydration is going to be the neurologic effects of the low sodium they can have. So I'm going to change now and talk a little bit about a practical case. I find that practical cases can provide, I think, a really good illustration because many of us, I think, and certainly for myself, I spent 4 years as a general pediatrician before deciding to go back and punish myself with 3 years of fellowship in pediatric endocrinology. So I had quite a number of patients who I'd seen with symptoms of polyuria and polydipsia, and still have many consultations that are sent to me, and these can present very challenging cases. So this case and the next case I'm presenting are actually adaptations of true cases that I've dealt with recently. So this is a child who presents with a history of polyuria and polydipsia symptoms. Important thing to ask yourself too is going to be how long have these symptoms been around? Has this been a relatively abrupt onset, or is this a situation that began a long time ago and is continuing? So in the case of this particular child, these symptoms have been long-term, and the order of magnitude of several years. This child awakens to drink and urinate multiple times per night. Seldom has a dry night, so again, nocturnal enuresis also. This is an older child too, which again also calls into question a little bit about pathology. As many of you who do primary care know, nocturnal enuresis is fairly common in children, particularly the younger children. And while it can be very challenging for children and families, generally doesn't have any underlying pathology. So this patient, now we're going to throw in some twists here, because again, as we collect information, the medical history is going to form really the backbone of helping to determine or to steer one towards whether or not we're dealing with pathology or not. So this is a patient who had a history of long-standing vision impairment. This is an individual who has developmental delays and has received special educational services since starting school. This patient has a history of seizures and has been on ethosuximide for treatment for a long time. Very interesting piece of information, though, is that this patient has been seen occasionally drinking from the toilet. So again, not something that we would typically encounter, and could be indicating both of issues with the patient's developmental status, as well as, again, suggesting the seriousness of a child who has, you know, an extreme thirst drive to the point that they're drinking from the toilet. And again, if you look at more serious cases of pathology, you can see cases where children will drink straight from the faucet or from toilet or other fluid intake that is a little bit more concerning. Now, before I move forward and we continue with this case, I want to take a brief detour for a public service announcement, because common things being common, most of the cases that you're going to see with polyuria and polydipsia symptoms, the first thing that you need to think about and the first thing you need to address is the potential that this could be diabetes mellitus. The distinguishing issue in this child's case, and I can tell you she does not have diabetes mellitus, is that the symptoms with diabetes mellitus tend to evolve much more quickly. Oftentimes, the polyuria and the polydipsia symptoms are within a few weeks, or sometimes, depending on the situation, months. But over several years is unlikely. So, and again, on the slide here are some of the symptoms. But again, as a primary care person who's seeing someone in the front lines, your first job is to pick up diabetes mellitus with this type of a history. As if it's not detected promptly and not addressed promptly, you could have very serious complications, including diabetes or diabetic ketoacidosis. And again, a couple of things that you can do very quickly in your office, if you're in an office setting, is just a simple urine dipstick, looking for glucosuria, looking for ketonuria, or if you have a capillary blood glucose machine, a glucometer in your office, checking a glucose meter. And again, if you have a blood glucose reading of 200 or greater on a random specimen on a capillary reading, that's extremely concerning for diabetes mellitus, and you should really, at that point, be contacting pediatric endocrinology to discuss further, talking to even sending the family to urgent care or a local ER for more thorough confirmation. And again, if you have a high index of suspicion, just from my personal experience, don't send the patient to the lab, because that's going to only delay the diagnosis of potential diabetes mellitus. And again, in the cases when someone is having uncontrolled symptomatic diabetes mellitus such as this, you're on the clock, and you really need to get the diagnosis made as quickly as you can to avoid worsening ketones and DKA. So again, talking a little bit about history, some of the things that are helpful in inquiring on history. So again, asking about polyuria, if you can quantify with the family, sometimes they can provide this, how much urine output, that's extremely helpful. If you have a patient who's in an inpatient setting, and the question is arising, then you have the opportunity with the other medical team to do a more accurate measurement of urine output, and that can be extremely valuable in trying to determine if there's pathology or not. Again, polydipsia, so particularly if you're seeing nocturnal drinking. So the big challenge that we see in polydipsia symptoms oftentimes is trying to discern if this is a child that has habit drinking for whatever reason, or what has been previously called psychogenic polydipsia, or if this represents true pathology with the child attempting by drinking to compensate for underlying excess fluid loss. So again, nighttime drinking, particularly waking up multiple times at night to drink, waking up multiple times at night to urinate, are very concerning. Also, another clue with polydipsia, again, trying to determine between that versus habit drinking, is going to be the fluid of choice. Many times children with true pathology, in this case I'm referring specifically to diabetes insipidus, like water. So they want hypotonic fluids like water, even cold water. Growth patterns are very important too. Again, this can be both from a nutritional standpoint, if the child is drinking to the exclusion of eating adequate calories, you're going to see poor weight gain. Also, if there's underlying illnesses, either renal disease or potentially hypothalamic pituitary dysfunction, you're going to see abnormal deranged growth patterns. If you have a child, and again, coming back to our case here, a child who has vision problems, that centers your concern a little bit more on CNS abnormalities. Or if you have a child or individual who has a history of significant closed head injury, that can also predispose them to traumatic diabetes insipidus or hypopituitarism, which can be either transient or sometimes permanent. Other constitutional symptoms, again, things like fever, weight loss, skin rash, bone pain, illnesses. Medications are going to be extremely important too. If you have a child who is a more medically complex child on multiple medications, one of the things I think that's important is that you need to take into consideration how the medications this child may impact their fluid balance. And then lastly, looking at their development and looking at psychiatric comorbid conditions, as again, the consideration for compulsive water drinking, if there's comorbid psychiatric conditions, needs to be considered. Physical examination kind of tails into the history as well, and is essentially a continuation of trying to determine if these history points that you may see are positive may potentially translate into, again, help to build a case that there's underlying pathology. So again, some of the things that can be very helpful, so draining otitis media, skin rash, lymphadenopathy, hepatosplenomegaly, these, particularly if you're seeing this in a younger child, can be tip-offs for a very important, and at least to my experience, a fairly frequent cause that I see for rather abrupt onset diabetes insipidus, which is Langerhans cell histiocytosis. And sometimes that can be, diabetes insipidus may be the first real clue for this condition, or these other symptoms linger in the background with no explanation, with then the appearance of diabetes insipidus that finally gives closure and allows us to make the final diagnosis. So moving back to our case now, so a couple of other pieces of information. So one of the challenges that we had, and this is a challenge that many people have, is that we didn't have good medical records. So the information that the family had was not particularly complete, and we didn't have any outside information initially. But with continued efforts, we did find that this patient had optic nerve hypoplasia that was diagnosed in early life at another institution. And with some assistance, we were able to get some old growth points. So these are the growth points on this child, and you can see very clearly This is height. So you can see very clear linear growth failure in this patient. This patient's weight, which I didn't put in this particular graphic, remained normal. In fact, the patient was actually slightly obese as well, as I notate here. This patient, as you would expect in someone who has optic nerve abnormalities, had nystagmus on examination. She was delayed developmentally, so interactive, pleasant young lady, but not for interacting at an age level that would be average or appropriate for her particular age, and was delayed in puberty. This was actually a teenager, and so had not had menarche, had not had any appreciable breast development when we carefully assessed for actual true breast development. There was certainly the appearance of breast development because of obesity and lipomastia. So now we've started building our backbone. We have important points of information on our history. We have an examination which I've distilled down to the most important points. Now is the time where labs come into play. Sometimes, of course, we may see labs first and then try to address these. But in this case, just for the interest of continuity, here are the labs that we got. So these are random labs that were obtained after the patient's visit. This is with, no restriction on access to water and just going normally. So you can see the sodium is 147. Again, we have a normal glucose, which again I pointed out is extremely important. And we also have, again, another checkpoint to make sure there's no signs of impaired glucose tolerance or diabetes with the normal hemoglobin A1C. Slight dyslipidemia, which again is probably related to the obesity. So most of us, if we see patients in clinic or in some other type of clinical settings, most of us, especially as we've gained more experience, have a fairly quick differential diagnosis that we're beginning to develop as we look at the chief complaint that the patient has, and as we begin the process of history taking and observing the patient and observing the family. But here's just a brief list of differentials, again, in a young lady who presents with polyuria and polydipsia symptoms. So again, diabetes mellitus, diabetes insipidus, habit drinking, medication effects. Hypercalcemia is an important thing to think about. And again, this goes back to constitutional symptoms. So hypercalcemia, particularly if it's hypercalcemia of malignancy, can be very, very serious and can lead to significant dehydration. Primary renal disease, and also another endocrine tie-in would be adrenal insufficiency. The real defining issue with adrenal insufficiency is that polyuria and polydipsia symptoms are, while they're part of the picture, they're not the dominant. They oftentimes have other constitutional symptoms. So they have loss of appetite, they have weight loss, and as a clues to push towards adrenal insufficiency. Again, some of the things are important to look at are some of the medications and think about how those may be factors. Corticosteroids, again, can cause mild increase in sodium retention and also increase in free water as well. But these are some of the medications. If you look, there are many medications, and I would encourage you, if you have a complex patient, to take a few minutes and actually look at their medication list and look at it with an eye towards their particular complaints to see, could this be either wholly or partly related to medication effects. So here's our investigation as we begin to move in that direction. So again, it's important when looking at fluid balance that we need to look both at the serum and the urine specimens, because an isolated blood specimen in and of its own or an isolated urine specimen in of its own does not give us the context that we need. So again, if we see evidence of higher serum osmolality, again, the concentration of the serum, if we're seeing a higher sodium, and again, sodium very strongly influences osmolality of the serum. So 2 times sodium, it gives you a quick approximation. So you can see very quickly that if your sodium is abnormal, it's going to very drastically impact the osmolality. So again, if you see evidence of concentration in the blood, yet you see no evidence of what should be normal homeostasis in the kidney to have conservation of water. So basically dilute urine as reflected by osmolality or specific gravity, that's concerning. And then of course, electrolytes can be helpful too, looking again at things such as the calcium level, looking at potassium as you're trying to question the question of adrenal insufficiency, glucose and hemoglobin A1C. So I'll tell you from personal experience that there are probably maybe 50% or maybe a few more where there's no obvious ability based on random lab samples to render a definitive diagnosis. And particularly if you have really persistent polyuria polydipsia symptoms, you're oftentimes going to be moving towards doing a water deprivation test. And there's a couple of ways that you can do that. You can do that as trying to do an overnight just fluid deprive at home to get a little bit of a sense on what may be going on. And I'll, on the next slide, touch on some of the challenges and logistics from that standpoint. Or you can admit and do a much more formal, rigorous water deprivation test. And again, here you're looking for, with depriving the child of access to water, is he or she able to maintain homeostasis? And again, signs of homeostasis are going to be clinically apparent by losing weight, showing signs of dehydration, again, by labs showing evidence of abnormality where there's not the ability to concentrate the urine in the face of dehydration, and measuring an arginine vasopressin level can be helpful. Arginine vasopressin, or antidiuretic hormone. I'll tell you from a practical standpoint, measurement of arginine vasopressin, while it can be done, the level typically takes a week or more. There are very few places that run these in-house. So you're not going to have this as a quick answer. You're going to have to rely on all the other information that you've gained in order to make a definitive diagnosis. And again, here are some of the parameters that are considered to be passing. And then if we do diagnose diabetes insipidus, which again, the water deprivation test is going to be the primary means of doing that, then treatment with DDAVP, which again is a synthetic analog of arginine vasopressin, is going to be helpful to see if you have responsiveness, to basically say, is this central diabetes insipidus, which far and away is the most common cause for diabetes insipidus, or could this be nephrogenic, where you have kidneys that are not responsive as they should be? So again, I mentioned this patient had some suspicions based on her sodium and based on her osmolality. Because of the fact that this patient had been observed drinking out of the toilet, and we had strong concerns with her developmental status that she couldn't comply with an overnight deprivation, she was admitted for water deprivation test. And fortunately, in her case, which doesn't always prove to be the case, particularly if you have someone who has habit polydipsia, she was able to very quickly tell us within 6 hours, actually even sooner, but I allowed the test to proceed a little bit longer because the sodium levels were not rising into the 150s. So this patient had incredibly brisk urine output. So again, this is where having your nurses on the floor help you out by carefully documenting urine output and giving you careful, regular reports is going to be helpful. So this patient, as a teenager, this is a crazy amount of output in 6 hours. And again, this patient had concentrated serum with inappropriately dilute urine. So a definitive diagnosis or a working diagnosis of diabetes insipidus was made, and the patient was given desmopressin or DDAVP and showed appropriate response. So again, diagnosis is central diabetes insipidus. And then the final point I'm going to make before we close out some other points on this case is that in cases where you determine pathology, so again, central diabetes insipidus is obviously diagnosis, but there's still more work to be done because there are causes for central diabetes insipidus that need to be evaluated. Is this a congenital abnormality? Is this an acquired abnormality from a tumor or something that's extremely serious? So in this patient's case, and we could probably make some assumptions based on the long-term nature and based on her optic nerve abnormalities that this is probably congenital, and this patient did indeed have septo-optic dysplasia. So again, a challenge in this family's case because of moving around and other factors that a definitive diagnosis wasn't rendered sooner in her case. So she was started on oral DDAVP or desmopressin. And also, again, because of the septo-optic dysplasia, there was an increased risk for other hypothalamic pituitary dysfunction. And this patient was found to have actually multiple anterior pituitary hormones that were affected, including growth hormone, thyroid, and probably the hormones that control puberty. Briefly, if you do primary care, you may have some experience using DDAVP or desmopressin for nocturnal nuresis. It is a treatment option that's available. There are 3 different forms that are available. Most people use the oral tablet form as it's the easiest and tolerated the best. It is a little bit of a challenge to titrate the dose. For babies and very, very exquisitely sensitive children, they may require extremely low doses, which can only be given by injection. There is nasal spray DDAVP available. The challenge with that really is that in this particular one, which is a metered dose type of desmopressin, it only delivers 10 micrograms, and that may be too much. Because again, this can treat the condition, but if we have excess effects of DDAVP and we shut down their ability to excrete their free water and yet they're still drinking, they may actually go the opposite direction and develop hyponatremia. So water balance, again, hence the term balance in the title, is a balancing act between, and especially when therapy is started, between giving enough free water balanced with medications versus not giving enough free water. And so those are all challenges. So to finish up, I just want to give you a few pearls, and then we're going to talk about our final case here. So this young lady, I think, very clearly demonstrates that a child who has intact thirst, has free access to water, and has relatively normal cognition is going to be able to keep themselves in a steady state by free access to their water. So again, if you have the ability, the only way to really answer this question and determine if this is habit polydipsia or psychogenic polydipsia versus true pathology is going to be to do some type of deprivation. And again, oftentimes what you'll see in individuals who have compulsive water drinking is that their serum osmolality and their serum sodiums are normal or even sometimes typically low. And those individuals, because they drink so much, they've sort of washed out their renal gradient. It can take them a while with water deprivation, to reestablish that gradient and begin concentrating their urine. Hence, sometimes in those cases, those water deprivation tests can go an extremely long time. So my next, excuse me, my next case I'm going to talk about is the opposite. So now we have low sodium. So we've talked about high sodium and diabetes insipidus. So this is, again, another case ripped from the pages of True Clinical Care. So this is a patient who presented, and I've also gotten a report here that I need to hurry up and finish up so we can have questions and finish up our recording. But this is a patient whom I saw who had leukemia diagnosed, and the consult was because of low sodium levels. This patient was on several medications and was on induction. He was obese. Here are his levels here, so you can see mild hyperglycemia and mild hyponatremia with otherwise normal findings. Again, brief differential you can see. So again, we talked about hyponatremic dehydration. Again, here we think about the converse of diabetes insipidus, which is excessive anti-ADH or AVP. Laboratory interferences, and again, other effects. And this should be actually, and I apologize, renal adrenal excess. In other words, cortisol excess or mineralocorticoid excess. Or pardon me, excuse me, this is adrenal insufficiency where you have sodium loss. And again, renal abnormalities, cystic fibrosis, particularly in an infant, needs to be considered. Here, there's many more medications that can have an impact on sodium levels. Also, it's very important here to realize that there are laboratory interferences that can lead to pseudohyponatremia as well. And particularly in this patient, we need to consider that. So again, some of the things that we want to evaluate and ask again, these have some common features to what we've talked about before. This patient had, again, leukemia as his history. He had medications. His exam or assessment did not show any evidence of fluid overload, which is an important thing that needs to be evaluated when you have hyponatremia. Again, his investigation is also in the similar vein to what we would do with diabetes insipidus. He had a repeat sodium level that was even lower and a glucose of 208. He had not particularly high, significant hyperglycemia. And again, hyperglycemia can cause pseudohyponatremia and is one of the most common reasons. Some dyslipidemia, again, probably related to his steroids, and a low osmolality. The other important thing, and again, this is where having other specialists helps, is that he had very little urine output. And this is a patient who was on IV fluids already. And so the first step that I did was stop his fluids and monitor his parameters. And what I found is that this young man, in the face of hyponatremia and in the face of hypoosmolality, was concentrating his urine inappropriate. So his diagnosis is SIADH. And again, I did correct for a high glucose, but even with the correction, he still was hyponatremic as well. And so, again, this was presumed related to his vincristine, and fluid restriction and observation was key in this young man's case. So again, these are slides for you, but again, think about various medications. Also, acute illnesses, influenza in particular, or someone who's had head trauma. Our neurosurgical patients oftentimes can have SIADH as well as diabetes insipidus. So a critically ill patient with meningitis or encephalitis as well. So, sorry I ran long, but I appreciate your time. I'm going to take my screen off of share now so I can see questions and address these before we finish up. And I had a few other housekeeping questions for you. And so the question is, what is the dose of desmopressin test with oral formulation in the absence of nasal or IV? That's a good question. And again, the challenge from that standpoint is the strength of the tablet. So you can do somewhere between a half or a quarter of a tablet, particularly if you have a younger child. Generally, because of my setting, I'm using injectable DDAVP just because I can give low doses, but a half or a quarter of a tablet, so 0.025 milligrams or 0.05 milligrams would be a range that I would use for an oral test dose to see if a child has responsiveness. While I'm waiting to see if anyone has any other questions, I'm going to remind you all that you'll have an evaluation email sent to you here shortly after the conclusion of the conference here. We value that both from the standpoint of the feedback that you give us for formulating future programs. This is our first departure into doing a virtual conference, and if this seems to be very well received, so we may consider using either all or part of virtual for future meetings. So please tell us what you liked, what you would like to hear more of, what you didn't like. We really value your feedback from that standpoint. Also, just be aware too that the follow-up email will have a link for the continuing or professional education credits for you to claim should you want to do so. The link is going to be active for the next 2 weeks, so you'll need to be sure to get those done. So for those of you that are watching this conference after the fact, or who have done the buffet and had some live and some recorded, be sure to do that. Also, again, hop over to hgfound.org. There are other offerings for archived webinars that have been done for growth hormone. And also, as my behind-the-scenes person here has said, the virtual exhibit hall. And then I see there's one more question that's come up here. So the water deprivation test, how does that differentiate between nephrogenic versus central diabetes insipidus? So the test itself doesn't differentiate between the two. It basically provides or allows the diagnosis of diabetes insipidus to be made. And then it's the test dose of DDAVP or desmopressin that allows one to know whether you're dealing with nephrogenic, which again, if you have nephrogenic, you're not going to respond to DDAVP, versus central, where you should be able to respond to the DDAVP. And then there's another question. What is your opinion on the use of the specific gravity test? I think that the specific gravity test works very well. And again, the value 1.010 is sort of that cut point and gray area, but it can be very helpful. And I typically, from my practice, will use urine osmolality and urine specific gravity together to help out. I didn't really talk about urine sodiums. Those can be helpful in some cases too when you're looking for evidence of urine sodium wastage. And if one is on desmopressin and going to have surgery, what should be done to approach that? And you raise, I think, a very important question to that point is, again, if one, it can be a very tricky situation having a child under sedation and particularly having IV fluids. And so really, I think the important thing in those cases is both to use the medication. So at least for my patients, I will definitely use desmopressin treatment if they have known central diabetes insipidus. You're going to have some type of procedure. Because I think a lot of people labor under the assumption that they can use fluids and keep in front of diabetes insipidus. But generally, it's not, oftentimes, it's not, at least in my experience, possible no matter how much fluid you give, because there's an accelerated loss of free water. And again, unless you're giving extremely hypotonic fluids, which has its own risk factors, you're not going to be able to keep up with that free water loss when you don't have controlled diabetes insipidus. The challenge, of course, is that your surgeons and anesthesiologists are going to want to open the tap wide up and use lots of fluids. And if you have someone who's got an anti-diuretic effect, you can fluid overload them. So the goal is really to work carefully with your surgical team and your anesthesiologist and explain to them that yes, the patient does need IV access. They do need fluids, and of course, if there's significant blood loss during a procedure, that needs to be addressed. But they need maintenance or even lessen maintenance to try to maintain them. And again, they need careful monitoring where, again, your nurses can be very helpful and your OR techs in quantifying urine output and verifying that the patient isn't having breakthrough or that the patient hasn't urinated or had any documented urination for the last 6 hours or more. Because again, that information in of itself is going to give you some very quick idea of the situation before, or hopefully as you have labs also guiding you in the patient's care. So all very, very good questions. And again, I want to take a few minutes and thank everyone for the time that you've spent during the day today being part of our conference. And we really value or really feel appreciative of the time that you've spent with us. And we hope that this has been a valuable conference, and we look forward to hearing feedback from you all in the future. Thank you all again.